Morning to all. Good morning to all. Dear delegates.
Can you listen to me, Rajan?
Yeah, ma'am.
Okay.
Ma'am, Lakshmi ma'am,
Yes.
Tell me.
am I audible, ma'am?
Yes,
Yeah.
you are audible.
Okay, thank you.
I am audible now.
Yeah,
Ma'am,
yeah.
am I audible, ma'am? Aarti here.
Yes,
Yes.
yes, yes, Ardi.
All of you are audible. Okay, all the best.
Am I audible? Am I audible?
Yeah, yes, sir.
Yes, sir.
You are audible.
Thank you.
You are starting.
We'll go on live in two minutes. Please start after 2 minutes.
Okay, fine.
Start, ma'am, please.
A very good morning to all. On behalf of Arupade Vidu Medical College and Hospital, Puducherry, and the organizing team of the BMSECON 2022, the 3-day International E-Conference on role of basic medical sciences in academia, diagnosis, and research advancement. I welcome you all to this conference. This is the third consecutive year that the preclinical departments of anatomy, physiology, and biochemistry, along with the Center for Biomedical Research, are organizing this virtual conference. A heartfelt thanks to everyone who has joined us today. The inaugural program is scheduled at 9:45. Without further ado, we start our conference. We are very happy to begin the conference with the keynote address by an illustrious speaker, Dr. Chandan Sen, and our distinguished chairpersons, Dr. Ravi Kumar Chittodia and Dr. Koshi are there, along with our moderators, Dr. Gopinath and Dr. Shushmita Mahapatra. I request Dr. Gopinath and Dr. Shushmita Mahapatra to take over the proceedings. Thank you all.
A very good morning. I'd be privileged and happy to introduce our first chairperson, Dr. Ravi Kumar Chittodia, Professor of Plastic Surgery, Registered Academic and Head of IT Wing and Telemedicine. He did his graduation MBBS and post-graduation MS General Surgery and MCH and PhD in Plastic Surgery in India, higher training in USA, and he has 9 fellowships, including fellowships from Royal College of Surgeons of Edinburgh. He is presently Nodal Officer of NMCN project and NKN project and ISRO project Telemedicine, Government of India. And to his professional experience and achievements, he has research and assistant editor of Journal of NGMC, current editor-in-chief of Journal of Plastic Surgery and Transplantation. He has authored 5 textbooks, 7 manuals, and almost 6 chapters and 278 publications to his credit and 1 patent. He is recipient of 31 awards, including BMJ International Award and SKOCH Award. We welcome you, sir, for starting this session.
Good morning. At the outset, I would like to thank the organizing team, including the organizing chairperson and the organizing secretary, and all the participants and the faculties. Good morning once again. It's a very interesting session to start with the keynote address from Dr. Sen. And we all know that regenerative medicine is the upcoming and the most promising when it comes to regenerate the tissues, especially those like burns, diabetic foot, necrotizing fasciitis, or any other raw area which needs to regenerate. And we also know that nanotechnology is existing. And also we are aware of tissue engineering. But when we combine all these 3 technologies, then we are coming up with the so-called nanotransfection. And our speaker is the pioneer and the recipient of award and one of the authority, I can say, And currently he is the director of Indiana Center for Regenerative Medicine and Engineering, and associate president, J.S. chair and professor of surgery, executive director, Indiana University Health Comprehensive Wound Care Center, and vice president of research, surgery, associate dean, School of Medicine, Indianapolis, Indiana, USA. His credentials, awards, publication, H-index is innumerable because it's already 9:10. I should not take his time. So over to you, sir. We are eager to listen from you.
Very good morning to all of you. I would like access for sharing my screen, and somebody please help me with the process such that, let me see if I need to do the audio transfer. So let me check. All right. Suppose you can see the slide. Just swap it here. All right. A very good morning, and many thanks to the organizers for having me. And I have my Science College fellow student, Dr. Sushmita Mahapatra, with you, and thanks to her for bringing me here. Greetings to my co-panelists. Greeting to all in the audience. And I'm going to share with you, these are very precious moments that we will spend together the next, say, 40 minutes. And I'll try to communicate some message that sticks with you. I'll not get into the nitty-gritty complexities of science. This being a keynote, I'd like the scale of this presentation to be broad-reaching so that each one of you in the audience can connect with it. And hopefully we'll have an active discussion session if we have time for it. Thank you again. So today I'm going to talk to you about regenerative medicine. And so it's a new discipline in modern medicine. And speaking of modern medicine and the implementation of modern medicine, much of modern medicine, all of modern medicine, has to travel through a regulatory path. And if we look at the history of such regulatory path, it was in 1906 that the FDA was founded in the US. It was in 1940 that the Drugs and Cosmetics Act of the Government of India, formed the CDSCO. And the CDSCO is currently in FDA of Amman. I was very recently meeting Dr. Somani, the Director General of CDSCO, and I've been there several times. It's in Kotla Road in New Delhi. Now, before we get into regenerative medicine, it's important that we have a little bit of a context, historical context. So you see, in 1906, FDA was born. But at that time, it was primarily focused on regulating food material, so that food material is not adulterated, so on and so forth. Then came the revised Food, Drug, and Cosmetic Act in 1938. And it is at this time, in 1938, that primary focus was directed on the regulation of new drugs, and that people could not make false therapeutic claim in drug labeling, so on and so forth. So that was 1938. It was in 1982 that this was again revised to make room for what we know today as medical devices. So we had drugs, we have devices, and then something special happened in the US, FDA, in December 13, 2016. And what is that? We had the 21st Century Cures Act, as a result of which FDA, in addition to medical devices, have now added the RMAT designation, regenerative medicine and advanced therapy designation. So to make it simple, soon you will see human body parts made in the laboratory or elsewhere would be waiting to be plugged back into the human. So we had medical drugs, medical devices, and now we are entering into a new era of healthcare that would see the presence of, in one way or the other, human body parts that would be plugged into the body. Now, this is not about, it is not my field, it is your field. Anybody and everybody interested in healthcare must pay attention to this, because I just took a couple of clips from the news, one in November 14th, the other was published today, November 16th. And you will see that this is already a significant market, over $20 billion a year, and is supposed to be roughly $60 billion in the next 8 years. So if we don't pay attention to this, we will have other people advance with this and we will be followers. So it's very important, if you really want to participate in this growth, to actually take interest and actively participate while the field is developing. So you see, through the RMAT track of the FDA, until the end of 2021, there were 67 approved products. And this year so far, there are 12 more. So you have something like 79 products already approved through the RMAT track. Now, when you talk about regenerative medicine, people mostly think about stem cells. And stem cells, in my opinion, is one version of the existence of a cell where you have maximized plasticity. Now, unless we saw stem cell, we would never depart from our classical mindset of terminal differentiation. So, you know, tissues are terminally differentiated, and we always know that once they're terminally differentiated, they stay that way. They don't reverse course. But once we started knowing about stem cells, that remarkably changed. So now that story is like 2 decades old, and now stem cells, there's a lot of good biological research. However, the issue with stem cell is, if you have a pool of stem cells in your hand, and if you're injecting into the patient's body, some cells will become what you want them to become. But other cells may not listen to us and even become cancer cells, causing complications. So we are dealing with a lot of issues with stem cells. Now, that is an extreme form of cell plasticity. What I'm going to talk to you about is that you do not necessarily need stem cells. Pretty much every cell of the body has some level of plasticity. And if you pick the right tissue and you pick the right cell type, you would be able to actually change state or fate. I'm going to come to those definitions shortly, without actually using stem cells. So why am I right now not so interested in stem cells? Because stem cells are wonderful in trying to understand cell plasticity, and they are tremendous with respect to their potential. But today we don't know enough to really safely handle them. So this article was authored by the FDA in the New England Journal of Medicine, where you see that the FDA is quite excited about this new track. However, as expected, they are laying a lot of emphasis on safety before we talk about efficacy. So safety first. Now let's go back to the concept a little bit. So you see, if you talk about tissue plasticity in vivo, we know that under fetal conditions, the tissues are highly plastic, meaning if you went in utero and you did some injury, when the baby is born, you can't even tell where the injury was made. The repair that happens in the mother's womb is near perfect, or as we call it, regenerative repair. But once the baby is born, and of course, when the baby then grows up to be an adult, this regenerative repair cannot be recapitulated. So in the child, you have blunted plasticity. And in the adult, as we learned in the textbook when I went to school, that the adult tissues are terminally differentiated, so they're not supposed to have plasticity. But if you now look at what we know today, in adult tissue, there can be 3 categories: low plasticity, intermediate plasticity, and high plasticity. So this concept of terminal differentiation is no longer valid. And if you now mess around or play around with adult tissue with high plasticity, for example, the skin, the fat, then you can actually generate cells and tissues of interest that could be of therapeutic benefit. Now, why have we been so excited about stem cells? Because stem cells actually taught us that plasticity can happen. And then when we knew plasticity can happen, we started looking for plasticity in cells other than stem cells. But in brief, stem cells can make more stem cells. Stem cells can make any one of the 206 specialized cells of the human body. But often what we don't talk about is that stem cells can also make cancer cells. So once we inject the cells into the human body, we are responsible not only for the cells that actually became the muscle or the nerve we wanted, but also of the cells that did not listen to us and had this type of a neoplastic fate. Now, most of you would have heard about induced pluripotency. In brief, originally fibroblasts from the skin were taken, and then you grow these fibroblasts in the petri dish in the laboratory conditions, and then you go through a process that is several weeks, could be easily 3 weeks, and you now generate pluripotent stem cells. So now these cells taken from the adult skin have been converted to IP cells, or induced pluripotent stem cells. Now, based on what you do to these cells, you could make beating myocyte, you could make gut cells, you could make blood cells, skin cells, neurons, you could make a whole lot of stuff. But all of this happens in the laboratory. So when you now take these cells, although those fibroblasts came from they were autologous, when you put them back into the body, the immune system is not happy. The immune system objects. So you are confronting with a problem. Plus, most of these pluripotent stem cells will not listen to us and go to the fate we want, and will continue to be stem cells. So if we now inject these cells into the human body, we have again the risk of stem cells becoming cancer cells. So embryonic stem cells, we know plenty about it. We just discussed about induced pluripotent stem cells. But notice at the bottom of your screen, and you will see an arrow highlighted in yellow saying direct conversion. Now, this concept of direct conversion, where an adult cell, so mind you, we had adult fibroblasts from the skin, we made them into pluripotent stem cells, and then we brought them back to, say, neuron or muscle or whatnot. But in this case of direct conversion, you do not need to take the fibroblast to stem cell. You can directly convert the fibroblast from a fibroblast into, say, a neuron, or into, say, an endothelial-like cell, or a muscle cell, so on and so forth. So this direct conversion is of interest because now you don't have any intermediary stem cell, so you don't have to worry about handling stem cells that don't listen to us. So fibroblasts, this process of direct conversion, if you failed, you are left with fibroblasts that you had to begin with. If you succeeded, you now have the cell you wanted. You don't have to deal with any intermediary stemness. So what was our interest? Our interest was to develop a technology where the reprogramming does not happen in the laboratory. First of all, scalability of anything happening in a cGMP laboratory is very low. Only very few people will have access to it. It is highly expensive. Plus, I told you, if you do these changes in the laboratory, bring it into the intact body, you will have to fight the immune system. So we wanted to develop a technology where no laboratory is needed. We will actually do the reprogramming, not of cells, but the entire tissue. So the field of tissue reprogramming came forth. We are going to do it because we are doing it in the body. We are doing it under immune surveillance and in negotiation with a complex in vivo microenvironment. If you're doing it in the laboratory, of course, you can manipulate a number of parameters, but those parameters would never approach the complexity that you have in vivo. So you're going to be achieving this tissue reprogramming in constant negotiation with a complex and dynamic in vivo microenvironment. If we can achieve such technology, we felt that it would be giving us a sustainable functional impact. So this is the original version of the technique with the first time we did in the laboratory. So we developed this technology called TNT, or tissue nanotransfection technology. So this involves a nano chip, as you see the square sitting on the skin of the hand here, and then you have a couple of electrodes, and this entire process is 100 milliseconds long. 0.1 second long. And then you only do it once. The chip does not stay with you. So you're done in 1/10 of a second, the chip goes away, and then this reprogramming starts. I'll show you then what happens. So when this was first published, the NICE director wrote a blog, and if you go to YouTube and write tissue nanotransfection, there are more than 1,000 videos talking about it. Different people are coming up with different ideas about it. So should you be interested, go to YouTube and see. And there are a few videos from our own group. I'll share with you a couple of them. Here is the first one. I hope you can hear the sound.
As cells differentiate, they acquire specialized functions. For decades, scientists believed this process ended with terminally differentiated cells. Committed to a particular cell fate, the ability to switch function irreversibly lost. In a major breakthrough, iPSC technology established the possibility of inducing plasticity to terminally differentiated cells. But several limitations arose, including a lengthy multi-step lab-based process, possible inefficiencies due to experimental conditions, low fidelity with which the final cell type is generated, and safety concerns, including potential cancer risk. More recently, scientists found that mature, fully differentiated somatic cells could be directly converted to another cell type by ectopic expression of specific transcription factors, without the need to acquire intermediate pluripotency. However, this technique requires viral gene transfer, an approach which, 1, requires an exhaustive laboratory procedure, and 2, carries risks, such as insertional mutagenesis, irreversibility caused by stable transduction, and increased cancer risk caused by long-term proto-oncogene expression. Therefore, it is not well suited for point-of-care applications. Thus, a non-viral tissue nanotransfection approach was developed for direct cell conversion in vivo by Professor Chandan K. Sen in collaboration with Professor James Lee. This work has been published in Nature Nanotechnology in 2017. This approach is simple, does not require elaborate laboratory procedures, and can be used as a point-of-care approach. This approach consists of 2 components. First, a hardware component, or chip, fabricated for efficient delivery of cell-specific cargo in murine model. Manufacturing of this chip has been scaled up to fit dimensions relevant to human need. Such chip has been successfully tested in preclinical porcine studies. Second, the cargo itself, which consists of a combination of different reprogramming factors. Thus, by applying a highly intense and focused electric field through arrayed nanochannels, this device nanoperates the adjacent tissue cell membranes and electrophoretically drives reprogramming factors into the cells. This new nano-electroporation technology is distinctly different from bulk electroporation. The simplicity and utility of this approach was demonstrated by nano-electroporating the skin that served as an agricultural land to cultivate cells of different functional abilities. Using a specific cargo, a combination of different reprogramming factors, skin fibroblasts were successfully converted to endothelial cells that ultimately formed blood vessels with 7 days. These blood vessel networks anastomosed with the parent circulatory system and restored tissue and limb perfusion in 2 murine models of injury-induced ischemia. Similarly, using a different cargo, skin fibroblasts were converted to neuronal cells that showed similar gene expression profile and electrophysiological function to that of cells in the developing brain. This tissue nanotransfection platform technology has the potential to ultimately enable the use of patients' own tissue as a prolific immunosurveilled bioreactor to produce autologous cells that can resolve conditions locally or distally upon harvesting. This simple-to-implement nano-electroporation technology generates favorable biological responses. It is a one-time treatment, applied topically, and only lasts for a fraction of a second, without elaborate laboratory procedures. And it could have applications beyond reprogramming-based cell therapies, such as gene, protein, and drug delivery.
So this work was first reported in 2017, and Daniel and Durba and Shubhadeep. Durba is actually now in IIT Ropar, and this chip is now in preparation for human testing in Mumbai under the oversight of AIIMS New Delhi. So a lot of progress in the meanwhile has taken place. There were a couple of editorials in JAMA, Science Translational Medicine, so on and so forth, quite favorable. So people are very excited that you don't need fancy laboratories. You can actually use the body to reprogram a part of the tissue that can be converted to cell types that are of therapeutic interest and can be transplanted within the body, depending on the need. So what is the technology? The technology, most of you may have heard about bulk electroporation, where you electroporate and deliver gene that is shown on the top. What happens there is most of the cells, many of the cells die. All of the cells have a hole in their membrane, and then the plasmids are left out and they enter the cell, and the cells that were able to repair their hole, you consider that as gene delivery. But what happens is that when you do that type of injury to the cytoskeleton, you blunt inherent plasticity of that cell. So what you see at the bottom is nanoelectroporation, where we open up less than 2% of the total surface area of the cell. And using that approach, we now deliver, as you see to the left, this type of cargo. And by the way, depending on what we want to reprogram to whatever fate or state, the cargo changes, but the device remains the same. Now, more recently, we manufactured a more large-scale version of this chip that is, a high-scale manufacturing, industry design, and this was published in Nature Protocol. And here is a small video explaining what this chip actually does.
Certain organs in our body can serve as a bioreactor. Through real-time feedback from our immune system, we can grow new body parts. We can even grow them in one place and then transplant them to where they are needed. One well-suited organ for such bioreactor function is the skin. This largest organ of the body provides ample real estate to grow therapeutic functional tissue structures. Tissue nanotransfection technology, or TNT, enables in vivo reprogramming of the skin to produce functioning blood vessels, active nerve tissue, insulogenic tissue, and more. This process depends on specialized chips created from silicon wafers. A coating is added to the top, then lasers are used to write small holes into the chip, then etched deep into the wafer. On the other side, a new coating is added and then lithographed to create hollow microneedles. The chip is then etched to make the needles longer, cleaned, and then treated with a new coating to improve precision. The exact nanofabrication process for manufacturing the TNT chip is now reported in a new publication in Nature Protocol. The delivery mechanism consists of two components. First, the chip, fabricated for efficient delivery of cell-specific cargo. Second, the cargo itself, which consists of a combination of different reprogramming factors. The cargo is different for different applications. By applying a highly intense and focused electric field through arrayed nanochannels, this device nanoperates the abutting tissue cell membranes and electrophoretically drives reprogramming factors into the tissue. In this approach, the skin may be viewed as an agricultural land that can be used to cultivate cells and multicellular structures of different functional abilities, such as perfused blood vessels, electrophysiologically active nerve tissue, etc. Using a specific cargo, a combination of different reprogramming factors, skin fibroblasts were successfully converted to vasculogenic cells that ultimately formed perfused blood vessels within 7 days. These blood vessel networks anastomosed with the parent circulatory system and rescued against ischemic insults. Similarly, using a different cargo, neurogenic as well as neurotropic reprogramming skin cells were achieved. Such intervention proves to be promising to rescue against stroke as well as diabetic neuropathy. In future, TNT is expected to involve dispensable chips with injectable factors supplied as liquid-loaded cartridges. During use, the chips will be stamped on the skin. Such approach will be compatible with point-of-care using minimum training for local and remote use. This TNT platform technology has the potential to ultimately enable the use of the patient's own tissue as a prolific immunosurveilled bioreactor to produce tissue, grow body parts, and resolve conditions. It is a one-time treatment applied topically, only lasts for a fraction of a second, and can be applied at point of care without elaborate laboratory procedures. And it could have applications beyond reprogramming-based cell therapies, such as gene therapy, protein delivery, drug delivery, and cell-specific exosome labeling.
So now that you have an idea of what the technology is about, I'm going to share with you a few examples of what have been accomplished so far. So the first example that we already have published is that we have developed a particular cocktail, gene cocktail, which when TNT, so we call that the vasculogenic TNT, and Durva, Shubhadeep, and Kanaya are the primary drivers of that, and this part is already published in Nature Nano. And what we have been able to show, several experiments were done. This is one where the femoral artery has been transected, and once you transect the femoral artery, you have this type of a sort of auto amputation of the limb, severe ischemia followed by auto amputation. And what you see to the right is a leg that does not have the femoral and was subjected to a one-time 0.1 second TNT with our vasculogenic cocktail. And we show tens and thousands of new blood vessels that grow and rescue that leg. All of this work obviously is now published. I'm going to take you through the wide range of what have been accomplished so that you get a feel for what is possible, and maybe some of you will be interested in this. More recently, we took the vasculogenic cocktail, and this paper came out, I think in 2020, showing that in a sciatic nerve crush model, you could actually improve recovery by doing vasculogenic TNT. Now, this EFF that is shown here is E2B2, FLI1, and FOXC2, which is basically the trifecta vasculogenic cocktail that we use for TNT. The work by Savita and others in the group has achieved neurogenic and neurotrophic TNT. Let me explain what that is. So what you do is when you do that TNT, so we use in this case ABM, ASL1, BRN2, MIT1L, as you see on the top. And in about 2 to 3 days, you start seeing the delivery, of course, of these genes into the fibroblast. In about 5 days, you start seeing neuron-specific markers. So this is a neuron-specific class 3 beta tubulin, TUJ1. Then you also have microtubule-associated protein, or MAP2. These start showing up. And in about day 20, about 3 weeks, you start seeing, if you do patch clamp, you start seeing electrophysiology. And it is also around that time that you also see, neurofilaments, you see synapsin, and this is now you're going longer, you see a choline acetyltransferase. These are all sort of in a temporal manner seen over time. And in vivo, when we actually patch the part of the skin, we were able to show excitable neurons, thousands of them that were reprogrammed. Then we harvested those neurons growing in the skin, put them back in the stroke-affected damaged brain, and were able to rescue brain function. So all of this is already published. Now, interestingly, when you do this type of neurogenic reprogramming, what happens is, of course, many fibroblasts of the skin become neural cells, but then the fibroblasts that do not become neural cells start making large amounts of, say, NGF, neurotrophin. So you have a very neurotrophic environment in the skin. And this neurotrophic environment of the skin can be leveraged to rescue diabetic polyneuropathy. With diabetes, these types of peripheral nerves start dying off, and this TNT-based neurotrophic environment of the skin helps rescue those. The next example just got published, I think, last month or so in Nature Regenerative Medicine, where we have been working on a model, because of the interest of the US military, who became very interested in this. We actually just reported a myogenic TNT, and this myogenic TNT was in a model of volumetric muscle loss of the tibialis anterior. This is in PubMed, just came, I think, a couple of weeks ago. And what we showed here is not only that you have myogenesis, but you have improved torque of the muscle. So basically, this is the functional recovery of the muscle is pretty effective. And together with the functional recovery, you have a bigger muscle. So the weight of the muscle is also higher. What Kanaya published a few weeks ago in the Journal of Clinical Investigation is that he studied a whole bunch of patients and showed that in a chronic wound patients, you have certain genetic pathways that are epigenetically silenced. So he used TNT in a new way. So what did he do? He used TNT in vivo to do cell-specific gene editing. So the first example of in vivo cell-specific gene editing was achieved in this paper that came out in JCI in July of 2022, a few months ago. This paper is also out, and I would encourage you to take a look. In another example, in a paper that just got published today in Molecular Therapy, another very well-known journal, this is Professor Gail Gordillo, our chief of plastic surgery, and she is very interested in the problem of hemangioma. Now, if you take this, it's we have a few plastic surgeons here, so they will be very familiar with vascular malformations, and you see this in children. So if you take these cells and you inject them in mice, what happens is you get a tumor because of which the mouse dies in about 2 weeks. So what we did was we demonstrated that you can now find out what is the molecular mechanism of this tumorigenesis, and then you can target that. In this case, the target was MIR-126, which is an angiomir. So we delivered anti-angiomir using TNT. Mind you, again, one application, 0.1 second. That's all it takes. No second application. And based on that, we see remarkable, as you see with the blue line, all these animals are dead 100% of them are dead in 2 weeks. And you see in red, a lot of survival. Also to the right, you see survival and continue. We then followed up for 6 months, and we are able to see tumor-free survival. Dr. Ghatak, who is currently an associate professor in the group, what he did is that he used TNT to label exosomes fluorescently. So you know these exosomes are nano carriers of gene, protein, and many other factors. And what Subhadev did was to see that in the blood, to be able to trace the origin of the exosome, he reported a technology that just got reported in ACS Nano, a highly reputed journal again, where he was able to demonstrate that exosomes originating from the keratinocytes actually are involved in keratinocyte macrophage crosstalk. And when this crosstalk happens, that is central to the overall process of wound healing. And if there is an impairment of that process, as is now seen in the cases of diabetes, once you know what this mechanism is, you can target that and you can correct that. Finally, Al Hasnain, one of my mentees, is a plastic surgeon. And Al just won for this project a major national award here in the US. So he is interested in lymphedema, especially after mastectomy. So he developed a model of a mouse tail vein lymphedema. And essentially, once you have this lymphedema, what the surgeons do is they do lymphovenous anastomosis. So they surgically do lymphovenous anastomosis. Now, interestingly, in developmental biology, the lymph and the lymphatic vessel and the vein is one structure. Eventually, it cleaves off. And there's a molecular process that cleaves it off. So what we were able to find is that using a particular molecular target where TNT was used for the delivery, we are able to reopen that or undo that and fuse the two without having to do any surgery. So this paper, one part of it just got published, and the bigger paper is currently in review. And Al is able to report a significant, as you will see with the red line, the black line versus the red line to your right, bottom right, a remarkable improvement. And again, it says TNT-LC. This is the lymphovenous anastomosis cocktail. So it's the LC. Of course, this is subject to patent, so it is not named exactly what it is. And finally, diabetic wound healing is obviously a major problem. And for most of you that know, and I just mentioned a short while ago, that once you have a wound in the fetus, it repairs perfectly. We have regenerative repair under fetal conditions. So we studied the feti to understand how that happens. And then in this case, we actually turned on that fetal pathway in the diabetic adult and was able to improve wound healing. And this also was done using TNT. So the paper, this also came out just recently. So it's supposed to be out in January 2023, but the paper is already in PubMed. You should be able to read it. Driving adult tissue repair, especially diabetic adult tissue repair, where re-engagement of a pathway required for fetal healing. With that, I'd like to sort of conclude my talk here, so we have some time for discussion. Thank you very much for your attention. These are the sponsors, primarily the NIH and the US Department of Defense. Thank you.
Thank you very much, sir. It was really eye-opening and excellent. The amount of work being done under your mentorship, and I really congratulate you and your team and the center, and hope that you will be, and you are already into our Indian platform. And as a plastic surgeon, I wish to invite you in JIPMER Pondicherry Institute of National Importance, where we have our anti-aging and regenerative clinic since 2012. We are also doing a regenerative, but the level which you have achieved is tremendous. So we will love to hear from you. Because of the paucity of time, maybe we can take one or two questions if any audience has. If there is a no question, I would like to just ask one question, sir. Any question? Any question?
Yeah,
we have a question
in the chat box.
We have a question, sir.
Okay.
Sir, it is share your insights on long-term structural and functional behavior of tissue nanotransfection tissue.
Yeah, very good question. So you see, whenever you do something like this, you're always concerned about safety. So far we have done 6-month follow-up studies, and we have also done a genome-wide mutagenesis study, based on which, so far, as you know, the alternative is viral. Once you do viral gene transfer, there is inflammation, and you have unrestricted propagation of the gene transfer potentially. Because this is a biophysical approach, you're using electric field to nanopurate. This does not propagate. So far, in the study that we have done up to 6 months on mutagenesis, we have not seen anything, and we have done whole body, tumorigenesis, pathology. So no negative, indications yet. But of course, this will have to be tested in humans. So far, rodents, pigs, and monkey done. So therefore, we have, we're approaching the human.
Thank you very much, sir. I think we should call it a day for this session. Why? Because the next program is also very important to the institute. And thank you very much, all the participants and Dr. Sen. Thank you very much.
Thank you.
Dr. Koshi, do you have any questions?
Yes, if there is time, I have a quick question.
Yes, please go ahead.
Yes, Dr. Chandan Sen, thank you very much for this amazing keynote address. We in AVMC, we are indeed lucky to have had you. Yes, my question is, it's mind-boggling, the TNT technology, but what is it that makes the skin fibroblast have more plasticity than, say, the other cells, say a kidney cell or a bone cell? What do you think is the fundamental characteristics that makes you work on the skin fibroblast?
So first and foremost, the skin is much more robust in repair and regeneration in general, historical studies would show. But the specific answer to your question lies in the observation that the skin fibroblast is actually made up of 8 different types of cells. So when you do single cell sequencing, it is made up of 8 different types of cells, of which 5 clusters are housekeeping, and they are not plastic. But you have 3 clusters that are dedicated to plasticity. So whatever challenge you do, these 3 clusters can either move and become a neuron. Just injury itself, you don't have to reprogram. Just injury itself is a physiological signal that triggers reprogramming in these subclusters. So single cell sequencing is showing us that you have dedicated cells that account for this plasticity in the skin.
Thank you. Thank you.
Thank you.
Without much further delay, there is no other questions. We can end this session, and we'd like to thank our keynote speaker by giving a certificate of appreciation.
Definitely.
We'd like to thank our chairperson, Dr. Ravi Kumar Chitoria. Thank you, sir.
Thank you for giving me this opportunity.
We'd like to thank our next chairperson, Dr. Apen Koshi. Thank you, sir. Thank you for chairing us.
Over to the organizers.
Thank you, sir. Thank you very much. Thank you so much, Dr. Chandan Sen, for a very insightful keynote address.
Thank you, madam. I appreciate
Thank
that.
you. Thank you, sir. Thank you very much.
Thank you, everyone. We'll now move on to our inaugural program. I once again wish everyone a very happy morning. On behalf of Arupadi Medical College and Hospital and its entire fraternity, with immense pleasure, we welcome you to BMSECON 2022, the third International E-Conference on role of basic medical sciences in academia, diagnosis, and research advancement, organized by the preclinical departments. Organized by the preclinical departments of anatomy, physiology, and biochemistry, along with the Center for Biomedical Research, Arupadi Medical College. I, Dr. Aarti, will be emceeing this inaugural program. We'll just hold on for 2 minutes before we start the sessions.
Come in.
Morning, sir.
Morning.
Medicine இன்னைக்கு
10 மணிக்கு வரும்னு சொன்னேன். அவர் போய்
சரிங்க சார் வந்த பிறகு நான் அந்த பேஷண்ட்க்கு முன்னாடி வந்து வாங்கிட்டு சார்.
அவர் காசு தரலையோ?
ஃபர்ஸ்ட் குத்துறோம் சார்.
Mr. Sudhir, kindly mute Dr. Koshi. I request everyone to kindly stay tuned. We are going to start the inaugural program soon. We are expecting few more dignitaries to join in. Kindly stay back. Thank you.
We welcome everyone back to BMSECON 2022. Now that our dignitaries have joined us, let's begin the conference. On behalf of Arupadi Medical College and Hospital and its entire fraternity, with immense pleasure, we welcome you all to BMSECON 2022. This is the third International E-Conference on the role of basic medical sciences in academia, diagnosis, and research advancement. It's organized by the preclinical departments of anatomy, physiology, biochemistry, along with the Center for Biomedical Research. The purpose of this conference is to bring together clinicians, educationists, diagnostic consultants, and biomedical researchers on a single platform to share their knowledge towards the advancement of basic medical sciences. So let's begin by invoking the blessings of the Almighty with the Tamil Thai Varthi. Thank you. I request the organizing secretary, Dr. Lakshmi Jatia, Professor and Head Department of Physiology, to welcome the gathering.
Thank you, Dr. Aarti. Distinguished Chief Guest, Dr. Chandan Sen, Honorable Chancellor, Dr. A.S. Ganeshan, Sir, Mr. Suresh Samvil, Member, Board of Management, Dr. P.F. Couture, our Dean, Dr. Mahalakshmi, Dean HPE, Dr. Vishnu Bhatt, Director Medical Research, Dr. Jay Singh, Medical Superintendent, Dr. T. Rajan, Vice Principal, Dr. Anachalam, Vice Principal Student Affairs, Dr. Deepa, and Dr. B. Jayakumar, our DMS. Speakers, chairpersons, delegates, good morning and a very warm welcome to Galaxy of Luminaries. As organizing secretary, I, on behalf of the organizing team, take pride in welcoming you all to the inaugural ceremony of BMSECON 2022. We at Arupadi Medical College and Hospital are honored and delighted to host this international conference for the third consecutive year. The theme of this conference is Role of Basic Medical Sciences in Academia, Diagnosis, and Research Advancement. This conference has the distinction of bringing together such a large number of resource faculty and delegates across the globe for a vibrant and intense exchange of views, knowledge, and experience on emerging trends in research, diagnosis, and innovative teaching learning methods. BMSECON has now become synonymous with Arupadi Medical College. This year too, we had an overwhelming response with 800 registrations and 230 plus abstracts for Young Research Scholar Awards and oral presentations. This conference is the result of collaborative and synergistic efforts of the departments of anatomy, biochemistry, physiology, and Center for Biomedical Research. On this momentous occasion, we are honored to welcome our Honorable Chancellor, Dr. A.S. Ganeshan, Sir, a visionary who has been constantly supporting us in all our endeavors. Sir, I extend a warm welcome to you on behalf of the organizing committee and all of us present here today. Welcome, sir. The organizing team also welcomes our Honorable Chancellor, Ma'am, Dr. Anuradha Ganeshan, whose invaluable guidance is cherished by us all. Though Madam is not able to join us today, we welcome Madam and we seek her blessings for this program. The organizing committee is extremely delighted to welcome Dr. Chandan Sen, chief guest for today's inaugural program. He is an academician and ardent researcher working at Indiana University. We extend a warm welcome to you, sir. The organizing team also takes pride in welcoming Mr. Suresh Samvil, member, Board of Management, a man who is highly ambitious and lives by principles. Welcome, sir. We cordially welcome our Dean, Dr. P.F. Kotur. He is a man with abated energy and enthusiasm. Welcome, sir. We also welcome Dr. T. Rajan, Vice Principal, who had been a guiding spirit and a crucial link between the organizing team and the management. We also welcome all the honored guests present here today, Dr. Mahalakshmi, Dean HPE, Dr. Jay Singh, Medical Superintendent, Dr. Vishnu Bhatt, Director Medical Research, Deans of other medical colleges under VMRF, university officials, members of STB, faculty members of AVMC, and friends from press and media on this auspicious occasion. We welcome delegates who are joining us from far and wide. Without your support and encouragement, this conference would not have been possible. We sincerely hope you will enjoy today and the next 2 days of deliberations and networking. I once again welcome you all, especially our Chancellor, Sir, Madam Chancellor, Dr. Chandan Sen, Mr. Suresh Samvil, other dignitaries and delegates to the inaugural ceremony of BMSECON. Thank you.
Thank you, ma'am. I now request Dr. Rajan T., Vice Principal, AVMC, to enlighten the gathering on the history and growth of BMSECON.
Thank you, Dr. Argani. Aarti, I'm audible?
Yes, sir.
Yes, sir. Audible, sir.
My screen is visible?
Yes, sir.
Yeah. Dignitaries on the screen and off the screen, dear delegates and the faculty of AVMC, a pleasant morning to all. With the support and divine blessings of God Almighty, our founder chairman, Dr. A. Sanmusundaram sir, and the benevolence of our trustee, Srimati Annapurni ma'am, in the year 2023, State Conference was jointly organized by Dr. K.R. Srinivasan with Association of Anatomists Tamil Nadu, the Department of Anatomy of Harvard Medical College, Vinaya Missions Research Foundations, which made very good impact among the delegates. In the year 2007, the State Conference has been again organized in the Department of Anatomy by Dr. K.R. Srinivasan, along with the Association of Anatomists Tamil Nadu, which created a very good image on Harvard Medical College, Vinaya Mission Research Foundations to conduct the conference. After 10 years, on one fine day, during the department meeting, it was decided to conduct an international conference in physical mode. It was organized during the year 2008 at Hotel Accord with the support of all the faculty in the Department of Anatomy. It was organized very well in a grand manner. Let me go for the growth of the BMSCON, how it is changed into from the ANATCON to the BMSCON. On the occasions, I would like to express my sincere thanks to each and everyone for the success of the first International Conference. By seeing the grand success and better outcome of the conference, we decided to conduct the same in the next year. During the discussion, we decided to include the preclinical subject, anatomy, physiology, and biochemistry combinedly, as well as Center for Biomedical Research. We have discussed with other preclinical department HODs and faculties, along with the head of the Center for Biomedical Research. Everybody appreciated and accepted the good initiatives. With the support of Honorable Chancellor Dr. A.S. Ganesan sir, Director Dr. Anuradha Ganeshan, and guidance of Mr. Suresh Samvil sir, Member Board of Management, and Dr. P.K. Sudhir sir, Vice Chancellor, and Dean Dr. P.F. Kotur, and the leadership team of the AVMC, it was conducted successfully in the November 2020. it's the first BMS conference. It was planned as a physical conference, but it was organized well in a virtual mode due to COVID. By seeing the appreciation and very good feedback from the delegates, it was decided to continue every year and conducted during the 2021. Around 10,000 participants were from the various countries. Now we back with the bank, and we are now at the virtual auditorium for the inaugural program of BMSECON 2022. BMSECON 2023 will be conducted hopefully in physical mode at our campus. I thank the organizing team for giving me the chance to share the history and growth of the BMSECON. Thank you, Dr. Arti.
Thank you, sir. I now request the organizing chairperson, Dr. M. Manju, Professor and Head, Department of Biochemistry, to address the gathering on the theme of this conference.
Thank you, Aarti. Respected dignitaries, esteemed speakers, chairpersons, and dear delegates, a very good morning. As the organizing chairperson of this third international conference, BMSECON 22, it's my honor and privilege to introduce the theme of the conference. The theme of this conference is Role of Basic Medical Sciences in Academia, Diagnosis, and Research Advancement. The theme for this conference was decided keeping in mind the major roles played by a doctor in a medical college, like academician, diagnosing and treating physician, and researcher, with special emphasis on recent advances on all these three fields. The medical professionals, they should be aware of the latest research advances related to the basic medical sciences, as it helps to translate the bedside research into bedside management and be assertive in evidence-based practices for efficient and effective patient care. So keeping in mind, the topics were decided by the speakers, and the topics which will be covered in the sessions in these coming 3 days of the conference include role of skills, technology, and basic medical sciences in medical education, advanced research related to epigenetics, next generation sequencing, next generation cytogenomics, role of artificial intelligence in diagnosis, latest imaging technology in diagnosis, 3D printing in research, T-cell vaccines, immunotherapy, synthetic biology, gut microflora in health, and in vitro and in vivo studies related to latest scientific developments. Basic medical sciences. It forms the strong foundation for medicine and surgery and its allied specialties to build up. After the new CBME curriculum has been implemented into the medical colleges all over India in 2019, the teaching learning methods like early clinical exposure, self-directed learning, integrated teaching, small group teaching, skills training, DOP sessions, etc., they have gained prime importance. And diagnostic modalities in a lab testing related to clinical biochemistry, immunology, and molecular biology, they have advanced in leaps in the last few years. Information on such recent advancements in diagnostics helps the medical fraternity to render better patient care services. We hope this conference can serve as a wonderful platform for educationists, diagnostic consultants, and researchers to share their experiences and findings, which would be of great help for many other participants to gather, improvise, and put into practice the novel and innovative ideas. And I'm wishing you all a very wonderful scientific and academic BMSECON 2022. Thank you.
Thank you, ma'am. Light symbolizes knowledge and wisdom. To solemnize this special occasion, on behalf of the dignitaries, may we illuminate the lamp virtually. Thank you. May I now request our Honorable Chancellor VMRF, Dr. A.S. Ganesan, who is the epitome of excellent leadership, to address this gathering.
Very good morning to all the participants for this BMSECON 2022. It is my pleasure to be part of this inaugural session of this third international conference of basic medical sciences in academia, diagnostics, and research advancement. AVMC has been like has been trending this conferences, organizing these conferences since 2020. The first international conference was conducted in 2020 that emphasized on emerging trends in research in the field of basic medical sciences. The second international conference in 2021 focused mainly on exploring new modalities in teaching, learning, and research. And of course, the third one being in academia, diagnosis, and research advancement. The objectives of this conference, as you all know, is to enlighten the participants on the role of basic medical sciences in academia, diagnosis, and research in the field of medicine, and to serve as a platform for sharing the latest developments in the field of diagnosis, research, and teaching, learning methodology related to basic medical sciences. And of course, to encourage young budding medical professionals to present their research work and update their knowledge, ultimately enhancing their network. I'm glad to note that faculty, PhD scholars, postgraduates, and undergraduates of disciplines from medicine, dentistry, veterinary, nursing, physiotherapy, and allied health sciences are participating in this conference. And I'm sure that this conference is going to be extremely useful for all the participants to improve their knowledge and put in practice the novel and innovative ideas that they will gather from this conference. The key highlights of this conference being the number of registrations that has crossed 700, and the number of abstracts received for oral presentation about 235, and the number of Young Research Scholar Awards for UG, PG, faculty, and PhD categories contestants, with the cash prize and certificate. And the number of e-posters for UG is about 46. And I'm glad to know that we have about 7 international speakers and 9 from across the country. And I would like to thank all the participants, all the speakers who have taken the time and effort to share the knowledge for all the participants in this conference. And I would like to congratulate the advisors for this conference, Dr. Vishnu Bhatt, our Director of Medical Research, our Dean, Dr. Kotur, Dr. Mahalakshmi, Dr. Rajan, and the organizing committee chairperson, Dr. Manju, Professor Head Department of Biochemistry, Dr. Ilankadir, Dr. Lakshmi Jatia, Dr. Ravi Kumar, and the various committees that have taken all the effort in organizing this conference. I wish all the participants a grand success. Thank you.
Thank you very much, sir, for your wishes. It is with great enthusiasm that we have prepared the souvenir this year. It's a conglomeration of scientific knowledge and the various aspects of this conference. I now request our respected member BOM, Suresh Samuel, sir, to release the souvenir.
Thank you, Dr. Arati. Good morning, all of you. It's my pleasure and honor to release the souvenir for the third International E-Conference on role of basic medical sciences in academia, diagnosis, and research advancement.
Thank you, sir. May I now request our member BOM to deliver the felicitation address.
Honorable Chancellor, Dr. A.S. Ganeshan, respected dignitaries, online, offline, participants, online, offline, Team AVMC, the organizing team, Dr. Chandan K. Sen, Chief Guest for this conference, the leadership under Dr. P.F. Kotur, Dr. Vishnu Bhatt, Dr. Mahalakshmi, Dr. Jai Singh. His hearty congratulations to the entire team in organizing this third international conference on basic medical sciences. In this juncture, I would like to also highlight one important area that what this conference will also be focusing upon, specifically with regard to medical informatics. I think medical informatics is the science and art of processing medical information. In this age of information explosion, choosing the useful one is rather difficult, and there lies the scope of electronic database management. However, still many outstanding personnel related to the healthcare sector take pride in being computer illiterate. The onus of the best use lies on the end user healthcare providers only. Another term, telehealth, encompasses all the e-health and telemedicine services. Computer-aided or assisted learning is a computer-based tutorial method that uses the computer to pose questions, provide remedial information, and chart a student through a course. Now, the emphasis in medical education is on problem-based learning, and the computer-aided or assisted learning could be of utmost help if used judiciously. Basic medical education and research lays the foundation for advancing and applying proper healthcare delivery system. There is no doubt that deep knowledge of anatomy is mandatory for successful surgery. Also, comprehensive knowledge of physiology is essential for grasping the principles of pathology and pharmacology adequately to avoid incorrect and inadequate practice of medicine. In this regard, the medical informatics is not just a subject to be learned and forgotten after the first professional MBBS examination, but this is something which would really help in terms of the artificial intelligence, health data management, health analytics, health information, which is how the medical programs and the medical care is being steered forward. So integrating the technology aspects in this basic medical science in today's conference is something very encouraging and in thing at this point of time. We are going to cover subjects with regard to 3D printing, with also to health informatics, with regard to health database management, and also extending it for newer technologies areas, how specifically we can look in terms of the healthcare adoption with regard to blockchain technology for more secure transactions and likewise. So I wish the conference a great success and happy to see this organizing committee has put together a very comprehensive agenda. I wish all the participants and also thank all the speakers for participating in this conference. Wish you all the very best.
Thank you very much, sir. We are very honored to have with us today our chief guest, Dr. Chandan K. Sen. Dr. Chandan K. Sen is a distinguished professor, J. Stanley Battersby Chair and Professor of Surgery, Director of Indiana Center for Regenerative Medicine and Engineering, Executive Director of the Comprehensive Wound Care Center at the Indiana University, Methodist Hospital, and where he serves as Associate Vice President of Research and Associate Dean of Research at the School of Medicine, Indiana University, USA. His research is funded by prestigious agencies, US Department of Defense, US Department of Veteran Affairs, and the National Institutes of Health. He is also an elected member to the National Academy of Inventors. Sir, we are very happy to have you with us today. I now request you to address the gathering.
A very good morning to all dignitaries and teachers, students. This is quite a special experience for me to participate in an event like this and to see the enthusiasm of the institutional leaders and their commitment to develop research and education. It's clear that in our country of India, and obviously there is a large need, there is a large gap in healthcare that we must all fulfill. But together with that, as we do that, there comes other responsibilities that are integral. Such responsibilities include assuming global leadership in specific aspects of healthcare. That is the only way that we could generate cutting-edge solutions in a way that could be affordable for our citizens. There is a tremendous amount of science going on around the world, but unfortunately, not all of that is affordable. And in my opinion, the only path to affordable healthcare within this vast nation of ours is for us, some of us will be within the country, some of us will be outside the country. But together, we must assume leadership to a point where we can grow solutions within the country and disseminate that to people of all strata. To that end, I think the commitment of your institution, training your students, setting a curriculum that respects what we learn traditionally, but also is responsive to the changing foundations of science are critically important. I think through events like this, you would be able to achieve those changes. And some of us that are perhaps geographically not in proximity, but share a common interest, could pull together and help achieve what seems like a large task, but together, definitely it is achievable. I have utmost confidence in our new generation and their interest to assume global leadership. To that end, we must enable our students and must ensure that the resources that are needed for such aspiration are provided. I'm quite confident that the Institute leadership would cater to those needs, and I thank all of you for having me here, being a part of your family. Thanks to all of you.
Thank you very much, sir. I now request our beloved Dean ABMC, Professor P.F. Kottur, to deliver the presidential address.
A very good morning to one and all over here. Respected chief guest of this inaugural function and the keynote speaker, Dr. Chandan Sen, Honorable Chancellor of our prestigious Vinayaka Missions Research Foundation, deemed University, Dr. E.S. Ganeshan, our beloved member of the Board of Management, Mr. Suresh Samuel, and my colleagues, head of the institutions, other constituent units, and the organizing secretaries, Mr. Lakshmi, Professor Manju, Professor Kilankati, my vice principal's colleagues, Dr. Arunachalam, Dr. Rajan, and the Director of Research, Professor Vishnu Bhatt, the staff members and invitees, resource persons and participants from across the country and across the globe. As a primary host and as a head of the institution of this virtual platform of AVIMC, I'm indeed honored and privileged to deliver this presidential remark. And an humble beginning, which was made 3 years back, when the COVID struck all of us, the humble beginning to drive away the claustrophobia has resulted in a short span of 3 years an institutional character of AVMC. This international conference has become a character and is going to be continued uninterruptedly. That's what is the commitment. And for this to happen, it is my prime duty to, of course, pay respects to our founder chancellor, Dr. A. Shanmugasundaram, Madam Shanmugasundaram, and our beloved honorable chancellor, Madam Chancellor Dr. Anuradha Ganeshan, and the esteemed board of management and the university at large, the pro-chancellors, vice-chancellors, and the university administration, being proactive in promoting such events. I'm very proud to say that our management and the university at large have adopted an aggressive approach to promote research at all levels. And a lot of investments have been made in terms of equipment, in terms of human resource, in terms of incentives offered to the researchers. And there has been a lot of accelerated activities to promote research at all levels has happened. And now we all know this is an era of evidence-based medicine and personalized medicine, wherein every disease or ailment is being defined at the molecular level, at the biochemical level. And such research in this innovative areas, emerging areas, will answer many questions which remain unanswered for years together. And this environment, research environment that is prevailing over here in the AVMC or the VMRF campuses, certainly I consider the students, our students, very much lucky. I already said that the new curriculum has been rolled out, new methods, early cell exposure, early problem-based learning. We are offering our students early exposure to basic medical science research. I consider the students to be very, very lucky. And we all know that research and education are the two sides of the same coin and go hand in hand. And if we are laying down the foundation to create a new Indian medical graduate or a global doctor by inculcating or impregnating all these paradigms in the early part of their career, so that when the final product comes out as an AVMC refined product into the global platform, it is quite valued, appreciated. That's what is the perception as a teacher, as a head of institution, I foresee. And at this point of time, I must thank all the resource persons coming from different parts of the country, different parts of globe, and the participants from across, nearly 1,000 participants, and also the students who have participated in this. And I'm sure they will be able to make most of this opportunity that is put forth in front of them. I must thank all the resource persons for having respected our request to share their expertise, to share their knowledge on this platform. And my special thanks to the chief guest, Dr. Chandan Sen, whose eye-opening key address, addressing many innovative discoveries he has shown us. So special thanks for him also. So once again, I thank and wish that the next 3 days the platform is going to offer quite a lot of food for thought and for the improvement of all the participants, staff, and students. Thank you very much. Namaste.
Thank you very much, sir. I now request Dr. S. Elankadir, Professor and Head, Department of Anatomy, to propose the vote of thanks.
Thank you, Dr. Marti. Good morning, one and all. It is the biggest day in the history of our institute. Today, we have hosted the biggest academic conference in India. As an organizing chairperson, I really feel honored and privileged to get the opportunity to propose the vote of thanks on this special occasion, for which I humbly thank the organizing team BMSECON 22 for giving me the chance. I thank the Almighty for the blessings showered upon us for the ever success of our conference. I want to express my heartfelt gratitude to our founder chancellor, late Dr. A. Shanmugasundaram sir, and Mrs. Annapurni Shanmugasundaram madam, who have provided us this platform for conducting this mega conference. On behalf of our university, institute, and the organizing team, I would like to thank our honorable chief guest today, Dr. Chandan Sen, Director of Indiana Center for Regenerative Medicine and Engineering, USA, for his guest lecture. Sir, you have readily accepted our invitation and granted us your valuable time amidst your busy schedule to enlighten us in tissue reprogramming in regenerative medicine. It was a wonderful session, sir. Thank you. From the bottom of my heart, I would like to thank our beloved Honorable Chancellor, Dr. A.S. Ganesan, sir, who always welcomes us whenever we try to approach him with any academic proposals. As a student, as a faculty, I have always thought how these many academic programs across various disciplines are being conducted in this institute. No one needs to tell me now. I have the answer. It's you, sir, who have been behind the success of all the academic programs conducted in our institute. Thank you, sir, for your valuable and gracious presence with us in this conference. I also would like to express my sincere thanks to our beloved Honorable Madam Chancellor, Dr. Anuradha Ganesan Madam, in absentia, who always stood beside sir and supported us in organizing our conference. Your wishes are always with us, Madam. Thank you, ma'am. My sincere thanks to our beloved Vice Chancellor, Dr. P.K. Sudhir sir, in absentia, who have always showed interest and supported us in conducting our conference. His wishes are always with us. I also take this opportunity to thank our other VMRF administrators for supporting us in organizing this mega event. On behalf of the organizing team, I would like to extend my sincere thanks to Member, Board of Management, Mr. J. Suresh Samuel sir, for his constant encouragement and support in organizing this conference. Whenever we come across any hurdle, sir has always been a bridge and paved us the way for our smooth conduct of this program. I also take this opportunity to thank sir for releasing our e-souvenir and delivering the felicitation address. We thank you, sir. Deep from my heart, I would like to thank our beloved Dean, Dr. P.F. Kotu, sir, for his constant support. Really wondered, sir, you are equipped with enormous experience. Your support has given us a framework upon which we have planned and executed this program. Thank you, sir. We also thank you, sir, for delivering the presidential address today and for your constant support and inspiration. Now, I would like to put forward my sincere thanks to our advisory members, Director, Medical Research, Dr. Vishnu Bhatt, sir, Dean HPE, Dr. V.N. Mahalakshmi, ma'am, Medical Superintendent, Dr. J. Singh, sir, Vice Principal Academics, Dr. T. Rajan, sir, Vice Principal Student Affairs, Dr. Arunachalam, sir, Deputy Medical Superintendents, Dr. Deepa and Dr. Jaykumar, for their constant support. Thank you all. I also would like to thank the heads and staff of our other colleges under VMRF for their valuable support. Thank you all. I also would like to express my heartfelt gratitude to our esteemed speakers, chairpersons, and judges who have consented to support us in this venture. Thank you. I also thank the entire team BMSECON 22 who have tirelessly worked for the conduct of the program. Upon my personal experience and from other administrators, faculties of our institute, wherever we go for attending any academic programs like conferences, CMEs, we have been constantly inquired by various sources like, when is your next conference BMSECON? That depicts our success in conducting the conference. If time is money, we have millions now added to our wallet. It's time to thank you all enthusiastic delegates globally who have dedicated their valuable time by showing interest upon registering for our conference, participating live today, and making our conference a benchmark in history. Once again, I thank each and every one present live in an ambition to make our conference a grand success. Thank you all. Thank you.
Thank you very much, sir. I thank all the dignitaries who have joined us today. We shall now conclude this inaugural program with the national anthem. I request everyone to raise for the national anthem.
जनगणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you all. We request everyone to stay logged in for the scientific sessions, which will begin right away. Thank you, everyone. And we also again thank the dignitaries for joining us today.
Dear delegates, we'll be starting our scientific session in another 2 minutes. Kindly stay online. Very good morning. Let us start our scientific session. The first session for today, we have among with us our esteemed chairperson, Dr. S. Sundarapandian, sir, Professor and Head, Department of Anatomy from SRM Medical College, Chennai. Sir has completed his MBBS from Tanjavur Medical College and MS Anatomy from same Tanjavur Medical College. Sir has got a teaching experience of 28 years. Sir's professional achievements and awards include Global Faculty Award in 2020 from AKS Education. Sir has received Best Performance Award from SRM University. Sir has received Dr. M.M. Cooper Best Paper Award on the paper Congenital Diaphragmatic Hernia. Sir has also received M.M. Cooper Best Paper Award by presenting the topic Dilated Coronary Sinus with Persistent Left Superior Vena Cava in the year 2006. Sir's field of interest includes microanatomy, embryology, and genetics. Sir has published really 50 journals, both in reputed national and international journal. We welcome you for the first scientific session, sir.
Thank you, sir.
Welcome, sir. We also have with us our second chairperson, Dr. Manisha Sandeep Takate, Professor and Head, Department of Anatomy from D.Y. Patil Medical College, Navi, Mumbai. Madam has got her qualification MBBS from Pune University in 1993. Madam has also received DLO from Pune University in 1996. Madam has completed her MS Anatomy in 2000 from same Pune University, Maharashtra. Madam's experience includes she has worked as medical officer in the Department of Surgery and for 6 years in Fiji Island. Madam's professional achievement and awards includes she has been a recognized PG guide since 2017 and 2 PhD scholars have registered under her guidance. Madam has published more than 15 articles in both national and international reputed journals. Madam has got an experience in conducting hands-on fetal dissection workshop on GI tract development and congenital anomalies in the International Summit, MediSpine, in 2019, organized by D.Y. Patel Medical College, Navi, Mumbai. We welcome you, ma'am. I request the chairperson to introduce our speaker today. Over to you, sir.
Good morning, sir.
Good morning, sir.
Good morning, ma'am. Deepthi, ma'am. Am I
Good
audible,
morning,
sir?
sir. You're audible.
Yes. Very good morning to one and all gathered here. I am very happy to introduce Dr. Deepthi Sastry. Actually, madam, I don't think madam needs introduction. Madam is a popular personality. So, madam has completed, presently working as Deputy Dean in Vinayaga Mission, Kirbananda Warrior Medical College Hospital, Salem. Madam has completed her MBBS at 1990, MS Anatomy in 1993. Madam is working now as professor also at Vinayaga Mission. So, madam is having around 30 years of experience in anatomy. Madam served in various positions in various associations. Recently, madam was the president for the Association of Anatomists and conducted the conference, National Conference of Association of Anatomists. Madam is the membership in various prestigious associations. Life member in Association of Anatomists Tamil Nadu Pondicherry, life member of Anatomical Society of India, life member of Indian Medical Association, fellowship International Medical Science, then founder member of Academy of Dental Education, member and National Academy of Medical Sciences. Like that, madam is having association with so many associations. Madam has published around 50 scientific papers. Then madam is having vast experience in conducting conferences and CMEs. So during COVID, madam has organized so many CMEs and conferences. I attended all the conferences, ma'am. So one coincidence, my year of birth, year of completion of MBBS, year of completion of MSc, all are same. I am happy to share with you, ma'am. So over to ma'am. Hello, ma'am.
Yes, sir. I'm sorry. I got disconnected for a while. Can I share my slides, sir?
Yes, ma'am. Yes, ma'am. You can share.
Yes. Are my slides visible, sir?
Yes, ma'am.
Your slides are visible.
Good morning, everyone. Thank you, Sundar Pandian, sir, for that wonderful introduction you gave me. And I would like to thank ABMC Organizing Committee for inviting me as a speaker for today's session. Well, for those of us who were entertained by these 6 on the slide through their sitcom, that is Friends, right through 1994 to 2004, Joey Tribbiani and his defining phrase, "How you doing?" would not be lost. Well, how often do we greet a complete stranger, or for that matter, a colleague that we meet every day by a simple quote, "How are you doing?" Well, is that important? To dig deeper into a seemingly innocuous greeting, which most of us in the midst of our frenetic schedules choose to ignore, and that which could be a defining moment in the chaotic lives of the people that we meet, Let us explore it through this session on fostering emotional intelligence, a 21st century skill in medical education. Well, I'm Dr. Deepthi Shastri, the Deputy Dean and Professor of Anatomy, Vinayaka Missions, Kripananda Varia Medical College and Hospital, Salem, Tamil Nadu. Our cerebral cortexes and the IQs have always assumed importance in medical education, be it in the admission process or promotion to the next phase of education. What then is the role of the limbic system? Should our emotions override our thoughts? Well, EQ, or emotional quotient, the other name for emotional intelligence, most certainly is set to overpower our IQs. The objectives of my session are, by the end of this session, you will be able to define emotional intelligence in terms of medical education, discuss research evidence on influence of emotional intelligence on medical education, identify the emotional intelligence competencies, justify the role of mindfulness in enhancing emotional intelligence, and champion the cause of fostering emotional intelligence in your students. Well, let's start at the very beginning. The term emotional intelligence was created by two researchers, Peter Salovey and John Mayer, in their article titled Emotional Intelligence, published in the journal Imagination, Cognition and Personality. And this was as late as the year 1990. How do we define emotional intelligence? There are several definitions to emotional intelligence. They all mean the same, but we need to acknowledge the one by Dr. Daniel Goleman, who is a psychologist and a writer, and who has been credited with popularizing the term emotional intelligence in 1995 in his bestseller, Emotional Intelligence, and later through his other book called as Working with Emotional Intelligence. Dr. Goleman described emotional intelligence as a person's ability to manage his feelings so that these feelings are expressed appropriately and effectively. According to Goleman, emotional intelligence is the single ladder of success in the workplace. Stephen Stein and Howard Book, in their book, The EQ Edge, have defined emotional intelligence as a set of emotional and social skills that influence the way we perceive and express ourselves, develop and maintain social relationships, cope with challenges, and use emotional information in meaningful and effective ways. Alicia Monroe and Elisa English, in their article titled Fostering Emotional Intelligence in Medical Training, the SELECT program, in their effort to emphasize the importance of physicians' emotional intelligence, have said that emotional intelligence of a physician is how they manage themselves, their emotions and behavior, and their relationships can have significant influence on team-based care. Physicians' emotional intelligence can support empathy and improve communication between team members. It can promote shared decision-making amongst medical professionals, help in conflict management, and it improves transitions between healthcare settings, be it hospital, nursing home, community, or even the death of an individual. Now, although the study of medicine and the tradition of the medical students gaining clinical experience in hospital wards has not changed significantly over the years, The experience of the physicians practicing in the current times, I'm sure all of you will agree, has changed drastically. Physicians who were once deified are confronted with increasing regulations, which of course are aimed at quality healthcare, but also may be inconvenient to physicians at times. And they're also faced with conflicts with patients and their relatives. A number of doctors are seen to experience professional burnout. And there's also threat to their mental health and their work-life balance. So in this scenario, as the next generation or generation alpha of physicians enters into the healthcare environment that is existent today, they need to adapt to the new practices as well as regulations. Emotional intelligence and mindfulness provide a possible solution to the struggles that these physicians are invariably going to face. Now, look at this phrase, to empathize or not to empathize. That's not the right question. I hope Shakespeare does not roll in his grave. In the past, emotional distance from patients was advocated in order to maintain a degree of objectivity. But in current times, an empathetic approach is advised. And the relationship between patients and doctors is moving towards more of a partnership. And this is bound to foster good communication skills in order to improve the patient satisfaction and to build mutual understanding. The results of a study by Debbie Johnson show a direct correlation between medical education and emotional intelligence competence. It makes the field of medical education an ideal one in which to integrate further emotional intelligence training. Is emotional intelligence tangible? Well, if you have ever held yourself back when you have felt like lashing out at somebody, you're already familiar with one of the ways that emotional intelligence works. Can emotional intelligence be felt? Can it be touched? Can you see it? While, like other aspects of the self, it is not tangible. But even though we cannot see emotional intelligence or feel it, we can certainly feel its impact. Now let's move on to the competencies of emotional intelligence. These competencies have been identified by, once again, Daniel Goleman. I'll be referring to Dr. Daniel Goleman several times in the course of my session, and that's because he has done pioneering work on emotional intelligence. Well, according to Daniel Goleman, emotional intelligence has 4 competencies: self-awareness, self-management, social awareness, and relationship management. Now let's look a little bit more in depth into each of these competencies. Self-awareness means knowing your own emotions. Self-awareness is about recognizing and understanding your emotions, what you're feeling and why you're feeling, as well as knowing how your emotions affect the people around you. How will your emotions affect your professional life? Well, self-awareness is the basis of good intuition and decision-making. It helps you to instinctively make the right choices for you in all aspects of life. Self-awareness is also knowing about your own strengths and weaknesses and what is important to you in terms of your values and moral compass. Next, we move on to self-management. It's also called as self-regulation. It's about managing your own emotions and motivating yourself. So once you've mastered emotional awareness, the next step is managing yourself, your emotions, particularly the negative ones, more effectively. How do we go about it? It needs you to treat other people with respect and try to always stay in control. Now, if you have a tendency for emotional outbursts, in that case, you need to practice being calm. That is, you have to take a step back and take a deep breath. It's also important that you stay true to your own values. It also means that you set very high standards for yourself and work hard in order to achieve those goals. You need to stay optimistic and try to always look at the positive side, even in negative situations. Next, we move on to social awareness. It is about recognizing and understanding others' emotions. Now, social awareness is described as being a people's person. Those who are socially skilled are good at dealing with others. It involves empathy. That is the ability to put yourself in other person's shoes and being able to look at the situation from their perspective. Next, we move on to relationship management. This is about managing relationships and others' emotions. It also means you need to manage change and resolve conflicts effectively. Where needed, you need to give praise to your colleagues if it is due. It is also about awareness of others' feelings and responding to others' feelings positively, even if you do not agree with them at times. Dr. Daniel Goleman, in his book, Emotional Intelligence, Why It Can Matter More Than IQ, advocates the emotional competence framework of personal competence for self-awareness and self-management, and social competence for social awareness and relationship management. Now, for the most important question, can emotional intelligence be taught? What do you, the participants, think about it? Do you think emotional intelligence can be taught? If you can post in the chat box, or you can unmute yourself and respond. Just a couple of you, if you can post in the chat box, if you feel emotional intelligence can be taught, you can just say Y for yes, N for no. Ma'am, Nakte ma'am, can you please read out the response?
Can be modified. It can be modified. As you said, you have to be optimistic, see the positive side of it. So it can be modified, I feel.
Okay, ma'am. Yeah, okay, ma'am says emotional intelligence can be modified. And if the moderators can read out any responses that have been posted. Okay, I'll go on then. It is believed that emotional intelligence is an ability-based skill, according to research work done by Zeder, Roberts, and Matthews in their article published in the year 2007, Can Emotional Intelligence Be Schooled? A Critical Review. They say emotional intelligence is an ability-based skill. And though it may be inherently present in an individual, it is an ability that can be taught, learned, and changed. It allows for training in specific competencies, the 4 competencies I mentioned earlier, and it is used to address the specific aspects of the doctor-patient relationship that are not working well. At times, self-awareness in a relationship may be working well, but the relationship management between the doctor and patient may not be working well. And teaching emotional intelligence should be a priority in the field of medical education in order to better facilitate this relationship in the future. Now let us see what is the anatomy of emotional intelligence. Emotional intelligence represents the ability of higher brain centers. You can look at the picture on the left. The neocortex is the rational brain, that is the prefrontal cortex. So the ability of the prefrontal cortex in order to monitor and direct more primitive emotional signals from a phylogenetically older brain structure. You can look at the temporal lobe in the brain picture, the limbic system, which is considered to be the emotional brain. So the prefrontal cortex can monitor and direct the amygdala or the hippocampus part of a limbic system in such a way that they are used constructively by the individual rather than destructively. This comes out of the research work done by Humphrey in the year 2007. The work also indicates that those individuals with higher levels of emotional intelligence are able to identify emotional states, not just in themselves, but also others, using these higher cortical structures. Now let's see how we can foster emotional intelligence competencies in medical education. Where in the basic medical science curriculum are we targeting emotional intelligence competencies currently? Do you think we are targeting or addressing emotional intelligence competencies in medical education? That too, basic medical science education? Well, we are all familiar with the new elements which are being introduced in CDME. So we have adaptive learning, which basically addresses self-awareness. Reflective writing, which we expect our students to indulge in after every teaching learning activity, where they need to write down what they felt during a teaching learning activity. So what that they feel it, and what is next. So they are thinking their thought process and feelings and jotting down in their logbooks or in their portfolio. So this is where we are addressing self-awareness. Early clinical exposure. This is where the students are going into the community or into the hospital setup, and they're not actually learning how to examine a patient or to diagnose a patient or give management. But they basically go and find out how different professionals, whether it's a nurse or a compounder or a ward boy, doctors, how they interact with each other. So they basically look at the relationship management. And of course, the ADCOM module. There are many modules, and the specific teaching learning method that has been advocated is a hybrid approach, problem solving approach, which basically targets the IQ. So where is the IQ involved? We'll take, for example, one of the modules of the first phase, that is the cadaver as the first teacher. What specific competency are we relating it to? That is emotional intelligence competency. Again, self-awareness. The student is becoming aware of the importance of the cadaver, which later they will interpolate to other subjects as well as to the patients later in life. Here I would like to just relate to you that our university, that is Vinayaka Mission's Research Foundation, we have value-added programs for MBBS students. And for the second MBBS students, since the year 2020, we have this value-added program called as Teamwork and Team Building. And during the course of this particular value-added program, we ensure that the social awareness of the students and relationship management improves. And this academic year, we have begun a new value-added program called as Values-Based Life Skills and Self-Compassion. And this relates to self-awareness, self-management, social awareness, as well as relationship management. And this has been developed by one of our psychiatrists, and he uses a particular tool to improve self-compassion and all the competencies of emotional intelligence, and that is called as loving kindness meditation. So how do you teach emotional intelligence? I mentioned earlier in ADCOM module, we follow a hybrid problem-solving approach, which actually targets the IQ rather than the EQ. Do we take lectures to teach emotional intelligence? Do we conduct workshops or seminars? I don't think these are the best ways to teach them. What we could do is establish communication skills lab, which are dedicated to imparting emotional intelligence skills. Now, there are some inventories, one developed by Ruven Baron, who developed a self-reporting test of emotional intelligence in order to assess a person's EQ inventory as a starting point to develop an individual's potential. This one has been developed by Stephen Steen and Howard Book, who have developed one called as EQI 2.0 assessment. How do these questionnaires or inventories help you to develop emotional intelligence? So what happens during this process is the emotional intelligence of individuals is scored. The development areas are identified and the relevant blind spots are targeted, whether it is personal competence or social competence. And once it is identified, remedial measures are employed for them. And what are these remedial measures? Well, mindfulness. Mindfulness is a process by which an individual actively observes his or her thoughts and feelings without judgment. Mindfulness has a foundation in Eastern meditation. Mindfulness, though it developed in the East, it has been accepted as a method for stress reduction in the Western culture. And research indicates that it improves all 4 competencies of emotional intelligence. Here, I would like to play a short video by Dr. Muthu Anand. He's a psychiatrist. He's a medical lead and in the adult community mental health services at Auckland in New Zealand. He's also Art of Living mindfulness practitioner. Let's hear him. I hope you can hear. I think it got stopped. 1 second, please.
Madam, the audio is not clear, madam.
Not clear, sir?
Yes, madam.
Sorry. What I'll do is, I've already told Dr. Ilan Kadir, I was a little skeptical about the video play. So I will post it to Dr. Ilan Kadir and he can post it to the participants through the email. Basically, he's a mindfulness practitioner and he's actually going to conduct a session on practicing mindfulness. Moving on, let's see what is a roadmap. How do we follow a roadmap for fostering emotional intelligence in medical education? So the first step would be to find champions who would identify emotionally intelligent faculty and practitioners with good communication skills, self-management skills, and healthy relationships. The second step would be to build a strong knowledge base, to engage knowledgeable experts to teach emotional intelligence concepts, competencies, and strategies to the participants. That's what I was trying to do today with Dr. Anand's video. And next is to create a vision for success. That is, how would you roll out a plan for introducing emotional intelligence into the course in your institution? And not just that, but how to sustain your initiative. We also need to ensure that there is a collaboration done by students, faculty, as well as administration. Everyone must be on board. And the institution must support development of emotional intelligence throughout the academic year and not just for short periods of time. Research tells us that to be effective in developing emotional competence, the approach needs to be, we need to connect the learner to the limbic system where the habits are developed. The training needs to be personalized and tailored to the individual, and it involves reinforcement and repetition over a period of time. The take-home message on my session on fostering emotional intelligence, a 21st century skill in medical education is: emotional intelligence is defined as a set of emotional and social skills that influence the way we perceive and express ourselves, develop and maintain social relationships, cope with challenges, and use emotional information in meaningful and effective ways. Emotional intelligence in medical education means it helps us to manage emotions and influence team-based care, supports empathy and improved communication with patients, promotes shared decision-making between medical professionals, and helps in conflict management. The emotional intelligence competencies as identified by Dr. Daniel Goleman are self-awareness, self-regulation, social awareness, and relationship management. Mindfulness is one of the tools which helps us to build on emotional intelligence. What is mindfulness? It is being in the present moment and be aware of where we are and what we are doing. Dr. Manju, the organizing chairperson, this morning mentioned that we, the basic science faculty, lay the foundation of medical education. So we need to champion the cause of fostering emotional intelligence in our students as well. We need to bring about the change that we wish to see in the world. I would like to conclude by quoting Warren Bennis, who has said that emotional intelligence, more than any other factor, more than IQ or expertise, accounts for 85% to 90% of success at work. IQ is a threshold competence. You need it, but it doesn't make you a star. Emotional intelligence makes you a star. Thank you. A threshold competence meaning it doesn't differentiate between superior and average performance, but emotional intelligence can. Thank you.
Thank you, ma'am.
Thank you, madam, for such an interesting and informative session. Actually, it gives us insight how we should look at it. We can implement it at the first year level. Now, the students have joined. So definitely, it has given us insight that self-directed learning and whatever we are giving them, that is also one way we are making them or training them for this emotional intelligence. So we will also like to, we will have a different attitude when we implement all the competency-based education. We will definitely use this idea as mindfulness, how it will reduce the stress level in the students. So it was really, really helpful. And one thing which I liked is it will connect learner to limbic system. So all of us are learners and we will it will connect us to our limbic system. Thank you so much. Session is open for questions.
Thank you, ma'am.
So, am I being seen? Good morning,
Yes,
madam.
Doctor.
Yes,
sir.
Yeah, that was a wonderful presentation. I feel there is a need of the hour because, as you rightly mentioned in the beginning, doctor fatigue and all those things happening in the today's world, including the pandemic and the pressure. I think that is a need of the hour. And we all know that the very fabric of our fraternity is empathy, right? Everything that is sympathy in action. So the medical fraternity grew and everything, all the discoveries and all the intelligent stuff which came up later, they're all based upon the need-based, basically, because of empathy. And the second thing is only what we human beings have got, which we do a lot, very few do a lot. That is a smile, which is the greatest gift I think our species has got. The best jewel which the nature has given, which outsmarts any diamond or any necklace. So these are the two things which I feel in the beginning stage, since we don't have a specific aptitude test as in like in other universities, we don't have the aptitude test. So just rightly the IMA, the Indian Medical Graduate, IMG, one of these criteria being the communication skill. As you rightly mentioned, the early clinical exposure will definitely help to keep a kickstart or to keep things rolling. Now, when it comes to this assessment of the EQ, or there is a scale for assessment. So can we really incorporate this objective assessment into our current curriculum? If we can do something about it, can you throw some light on that?
Thank you, Dr. Arun. You rightly pointed out about the smile that connects individuals with each other. So it improves relationship management. There may be, just terminology that we use. I'm sure all of us agree that smile connects us all. Coming to your question.
Only in the evenings when we're closing.
Can we mute the person who is speaking? Okay. Your question was about objectively assessing emotional intelligence. IQ has a lot of questionnaires. We also know about personality assessment by Myers-Briggs. That's been very popular. There are a lot of inventories, like I pointed out. There's been a study done in Chennai for postgraduates on assessment of their emotional intelligence. They have used a validated questionnaire, which was initially developed by Salovey and John Mayer. They are the pioneers of developing assessment questionnaires or inventories. And these people have modified it and validated it. And it has proved, successful. But we must understand that emotional intelligence is a new concept. It's come out very recently. So there's not much research work having been done so far. And we have begun to introduce emotional intelligence in our students. But the outcome can be measured after they pass out of the MBBS course. And like you pointed out, once they become an Indian medical graduate, I think that's the right place for us to gauge whether they have gained emotional intelligence.
Thank you. Thank you so much.
Thank you, Dr. Arun.
Thank you, ma'am. That's all we have. We don't have any queries in the chat box. That was a wonderful presentation, madam. Thank you, ma'am.
Thank you, sir.
It's time to honor our speaker today. We thank the chairperson. It's time to honor our chairperson, Dr. S. Sundrapandian, sir. Dr. Manisha, madam. Thank you, ma'am.
Thank you, sir. Thank you, Manisha, ma'am, and Dr. Sundar Pandian, sir.
Thank you, ma'am. Thank you for that illustrative presentation. So regarding self-awareness and social awareness, self-management and relationship. Of course, nowadays, what I am observing on the clinical side, there is no much interaction between the patient and the doctors, recent generation doctors. Interaction itself is not there. First, we have to motivate that. Then only we can assess all these things. So it is definitely need of the hour. But before introducing to the students, it should be taught for the teachers also.
Definitely, sir. Faculty development is the first
Yes.
step.
Yes, ma'am. Yes, ma'am. That is more important. Nowadays, that recent generation teachers also, they are like that. They don't have much interaction with the students. Another thing, throughout the course, we have to implement that. So now if you take yoga and all, for 20 hours or 30 hours like that we are doing, but we are not following it. So that is more important. Throughout the course, it should be there. So we have to monitor it, ma'am. That is more important. Yoga
So you're
should be there
absolutely
at
right. So
Yes,
you're
yes,
absolutely right. We have started that value-added program called as values-based life skills and self-compassion. It's a longitudinal program. It's by a
yes, yes.
psychiatrist who has begun in the first MBBS, and he is going to follow it up longitudinally till they finish final MBBS. You are absolutely right, sir.
Yes, ma'am. Thank you, ma'am. Thank you.
Thank you,
Nice
sir.
to see you.
Thank you, sir. Nice meeting you, sir.
Thank you.
Thank you, sir. Thank you.
Thank you,
sir.
sir.
Irangadir, sir. Thank you.
Thank you,
for
sir.
the opportunity.
Thank you, sir. Thank you. Thank you, sir. Thank you, ma'am. At this juncture, I also would like to welcome our Tamil Nadu Medical Council observer, Dr. T. Prasad, who has joined our session. Welcome, sir. Thank you, sir. Now I request the moderator of the next session to take over.
Okay, good. So, dear delegates, welcome back for the next session. And I would like to introduce the chairperson for the next session. It is Dr. R. Vinod, who is the professor and head department of microbiology, head of the virology lab, and vice principal of Sri Venkateswara Medical College Hospital and Research Center, Pondicherry. He is having 15 years of teaching experience and expertise in the field of microbiological diagnosis. And under his able leadership, Sri Venkateswara Medical College Hospital and Research Center obtained NABL accreditation for the BSL-2 virology lab. He's having around 20 publications and guided around 15 MD students, and he has many ICMR STS projects to his side. He is a question paper setter for many universities like Dr. MGR Medical University, Rajiv Gandhi University of Health Sciences, Vinayaga Missions Research Foundation, etc. He is a reviewer for many journals like JCDR, IJCBR, etc. Dr. R. Vinod, welcome to our session, and I really thank you for accepting this to be the chairperson for this session. Over to you, sir.
Thank you, Dr. Manju. Am I audible?
Yes, you're audible.
Good morning to one and all. I thank Vinayaga Mission University and BMSECON for giving me this opportunity. I thank them. And I would like to appreciate the speaker and the organizing team for thinking of COVID-19, SARS-CoV-2. Because it is slowly becoming a history. COVID-19 is becoming a history. There is no fear. Nobody talks about COVID nowadays. Nobody wears mask. Nobody wants to talk about a vaccine. So I hope this COVID-19 will remain a history like our demonetization. So with pride and immense pleasure, I would like to introduce our esteemed speaker, Dr. Kannan Vaidyanathan. Sir is presently the professor and head Department of Biochemistry, Believers Church Medical College Hospital, Tiruvalla, Kerala. Sir has done his MD in Biochemistry. He has also got his postdoctoral fellowship in microbiology and cell biology from Indian Institute of
Dr. Vinod, your voice, you're muted. Dr. Vinod?
Kochi.
Yeah. Please
From
continue.
2019 to 2022, he has headed the Metabolic Disorders Laboratory. He was a Deputy Technical Manager of Amrita Laboratory Services from 2006 to 2013. He has been the Professor and Head Department of Biochemistry and also was a Deputy Medical Superintendent in Pushpagiri Institute of Medical Science, Tiruvalla. His professional achievements and awards. He has gained Asia Pacific Federation and the Clinical Biochemist Silver Jubilee Scholarship in Beijing, Chennai, in China in 2007. He has also been awarded KP Sinha P.S. Krishnan Award for the best original research article in Indian Journal of Clinical Biochemistry. Along with the other responsibilities, he's got some more responsibilities. He is the Managing Director of Indian Journal of Clinical Biochemistry. He is the Executive Committee Member, Association of Clinical Biochemists of India. He is a member of Task Force for Newborn Screening, member PG Board of Studies (POAS), member of American Association of Clinical Chemistry, American Society of Human Genetics, European Association of Cancer Research. He's got a vast research experience. He has been a co-author for 3 textbooks in biochemistry, more than 85 publications, including 25 in PubMed Index journals, delivered more than 60 lectures in 5 continents. He has guided 6 PhD students and more than 50 postgraduate students. He has been examiner for MBBS, PDS, MD, PhD, and allied sciences for various universities in India. Currently, his area of research is inborn errors of metabolism, clinical chemistry, and molecular biology. We welcome you, sir, for your talk. And sir will be talking on biochemistry of SARS-CoV. Welcome you, sir.
Sir, for the kind introduction. Am I audible, first of all?
Yes, sir, you're audible, sir.
And thank you, Dr. Manju and the organizing team from Vinayaka Mission College to ask me to deliver this talk today. I'm really grateful for my being able to be able to present today.
Our pleasure, sir.
Because of 2 reasons. One, I couldn't attend the last session because I was not in station. And the second one, because last couple of days I was struggling with a bad health condition. And I was just came to the office today just to give this presentation. So
thank you, sir.
I hope I'll be able to convey what I want to tell. And so the other thing also, like I was hoping to have more students to listen to that. I don't know how many students are there, but it's okay. I'll so because lots of aspects are there regarding, like Dr. Vinod was telling in the introduction, what is the relevance of COVID today? Now, one of the things which I want to mention is that even though COVID is largely like gone from the universe as of now, as most statistics show, but still it's important that with pandemics like this, or it is the information that we gain from that should be used for the future prevention of further epidemics to come as well. So that is in fact one of the relevance of having this topic. So with that brief introduction, I'll go to the presentation. Is that visible now?
Yes, sir. It's visible, sir.
Okay, thank you very much. And I'll start with a brief introduction to the coronaviruses as I before going to the biochemistry of COVID. Now, there are a lot of things to be talked about regarding the coronaviruses as well as COVID and the biochemistry of COVID. So it is not possible to cover everything in the limited slot of 30 minutes because the topic is so vast and lots of research has been done. So I'll try to limit it to the basic things and leave the rest to any discussion or further interactions later on or some other time. So essentially coronaviruses, we all know it's a group of related RNA viruses, and it can cause diseases in mammals as well as birds. And they cause respiratory tract infections, which may be mild or even lethal, as in the case of COVID-19 in some cases. And mild illnesses can include some cases of common cold, and lethal varieties can also be there, like which cause the MERS as well as SARS and COVID. And in some animals, it causes some mild infection, mild diseases, like for example, cows and pigs that have caused diarrhea, while some other diseases have caused more severe illnesses in some other species. And that's the family and subfamily of coronaviruses, the subfamily Orthocoronavirida in the family of coronavirus, and the order and the etc. They are envelope viruses essentially, and positive and single-stranded RNA genome it has, and it has a nucleic acid with a helical symmetry. Now, I'll go more into the details of the genome later on, but essentially it is one of the largest among the RNA virus family. And the name is because of the characteristic spikes which are seen projecting from the surface, and which is likened to the solar corona, and that is why the name coronaviruses came. Now, if you look at the history of the coronaviruses, the earliest reports of coronaviruses came in animals in the in this century itself, and from North America, which have high mortality rates of 40 to 90%. And the virus was known as the infectious bronchitis virus at that time. And later in the 1940s, 2 more animal viruses were discovered, which were related to the now known coronaviruses. And the human coronaviruses were actually discovered only in the 1960s. And of course, the other human coronaviruses discovered include the SARS-CoV virus, and in addition to the SARS-CoV-2 virus, which was discovered in 2019, and the other coronavirus which caused the other infections, which I'll be coming to later on. But essentially, most of these infections have been seen. A lot of these infections have been associated with the animal coronaviruses, which have been discovered since the 1960s. And we know even in the case of the human coronaviruses, many of these infections originated in animals. Now, the structure, if you look at the general structure of the coronaviruses, they have a large, roughly spherical particle with unique surface projections. The size is highly variable with an average diameter of 80 to 120 nanometers, and even extreme sizes are also known. They have a high mass of 40,000 kilodaltons and enclosed in an envelope embedded with a number of other molecules as such. And they have the characteristic lipid bilayer envelope, the membrane protein, the nucleic acid, etc., which are characteristic of the coronaviruses. And the viral envelope especially has a lipid bilayer in which the membrane proteins, the envelope proteins, and the spike structural proteins are anchored. So that is inside. And the E and M proteins are the structural proteins, and this combined with the lipid bilayer gives a shape to the viral envelope, and it maintains a size as well. And the S proteins are essentially needed for interaction with the host proteins, and that is also important. It is pathogenic. And the human coronavirus NL63 is one which is peculiar because of its M protein, which is and not the S protein. So there are some variations in the difference in between the different types of coronaviruses. And essentially the M protein is a main structural protein and provides the overall shape for the virus. And the M protein is crucial during the assembly, budding, etc., as well as a pathogenic entry of the viral life cycle. And the E proteins are minor structural proteins which have high variability among the different species of the coronaviruses. Now, as I said in the beginning, the spike proteins are the most characteristic feature of the coronaviruses. And on an average, each coronavirus particle has about 74 surface spikes. and each spike, coming to a structural spike, is about 20 nanometers long and is composed of a trimer. The S protein in turn is composed of an S1 and S2 subunits, and essentially one of the important subunits is the what is known as a tempress protein, the transmembrane protease serine 2, which is essentially important for entry to the host cell. The S1 proteins are the most critical components in terms of infectivity, and most variable components are also there which are responsible for the host cell specificity, including the two major domains termed the N-terminal domain, the S1 NTB, and the C-terminal domain, S1 CTB, which all serve as the receptor binding domains. And the NTDs essentially help to recognize and bind the sugars on the surface of the host cell membrane. And the S1 CTD is the one which binds to the ACE2 receptor, and it is so important for the coronavirus 2, the COVID-2 virus. And there are also shorter spike surface proteins called the hemagglutinin esterase, which are important for certain species of coronaviruses, and they help in the attachment to and detachment from the host cell. And inside the envelope also there is a nucleocapsid, which is forming the multiple copies of the nucleocapsid protein, which are important for the various pathogenic features of the coronavirus. Now coming to the genome, the coronavirus contains, as I said briefly in the beginning, a positive single-stranded RNA genome. The genome size for the coronavirus ranges from about 26.4 to 31.7 kilobases, and it is the largest among the RNA viruses. The genome size is also the largest among the RNA viruses. It has a 5' methylated cap as well as a 3' polyadenylated tail, and open reading frames 1A and 1B, which occupy the first two thirds of the genome. And this encompasses a replicase polyprotein, or the PP1AB. And the replicase polyprotein can self-plate to form 16 non-structural proteins, which are known as the NSP1 to 16, NSP1 to NSP16. And the later reading frames encode the major four structural proteins and of the envelope and the membrane and the nuclear capsid. And interspersed between these reading frames, as you can see in the figure, are the reading frames necessary for the accessory proteins. That in general is the structure for the coronaviruses. And of course, the number of accessory proteins and their function is unique and depends upon the specific coronavirus, and that is the general structure of the coronavirus. You can see the spike protein, the envelope protein, which is there on the which encompasses the inside the nucleocapsid protein, the N protein. So now I won't go into much details of the replication cycle because of lack of time, but essentially, as you can see in the inset figure, the cell entry is the most important feature which starts the replication cycle, and the infection begins when the viral spike protein attaches to the complementary cell host cell receptor. And once it is attached, the protease of the host cell cleaves and activates the receptor attached spike protein, and depending upon the host cell protease available, and the cleavage and the further activation occurs by endocytosis or by directly combining with the viral envelope in the host membrane. And after that, you have the genome's translation. And once on entry into the host cell, the virus particle becomes uncoated, and then the genome enters the cell cytoplasm. The coronavirus RNA genome is directly translated by the host ribosome, and the host ribosomes can translate the initial overlapping open reading frames ORF1A and 1B, as I mentioned earlier, of the viral genome into two overlapping polyproteins, PP1A and PP1AB. And these polyproteins have their own protease, which cleaves the polyproteins at specific sites later on. And then the next important thing is the replicase transcriptase system of the protein. A number of the non-structural proteins coalesce to form the multi-protein replicase transcriptase complex known as the RTC. And the main replicase transcriptase protein is the RNA-dependent RNA polymerase, or what's the very important RDRP molecule. And it is directly involved in the replication and transcription of the RNA. And other RNA, the other non-structural proteins in the complex assist in the replication and the transcription processes as well. Now, one of the important functions of this complex is to replicate. Of course, the one replication is important, and the RDRP directly mediates the synthesis of negative strand genome from the positive sense genomic RNA. That is one of the important features of the protein, and this is followed by the replication of the positive sense genome from the negative sense genomic RNA. So it's essentially the replication which is the important function of the RDRP. And after that, the next important function is transcription. The transcription of the viral genome also occurs with the help of the RDRP. As you can see, it is the RDRP directly mediates the synthesis of the negative sense RNA molecules on the positive sense genomic RNA. And the transcription, this is followed by the negative strand subgenomic RNA molecules to the corresponding positive sense molecules. And finally, there is the assembly and release which occurs, and the replicated positive sense genome becomes the genome of the progeny virus, and by exocytosis it is released into the host cell, and then once released, the virus can infect other host cells. So that essentially is the entire thing which is happening once the once the virus enters into the host cell. Now, coming to the classification of the coronavirus. So the coronavirus essentially can be of 4 types: the alpha, beta, gamma, and delta. And alpha and beta are the ones which affect the mammals, and the other ones which primarily affect the other organisms. And that is the phylogenetic classification of the coronavirus. And the beta coronavirus is the one which encompasses the SARS coronavirus 2. And the human coronaviruses, there are 3 main coronaviruses which have been discovered so far, which have come out so far. One is the SARS coronavirus 1, which was discovered in 2003. Then you had the MERS coronavirus, which was discovered in 2012, the Middle East respiratory syndrome associated virus. And the third one is a COVID virus, which was discovered in 2019. And coming to the biochemistry of the COVID virus, it is essentially similar to what I had described so far. Now, COVID-19 is the third coronavirus outbreak in the last 20 years, so that it makes sense to think that there can be further things which can come later on. So including the SARS outbreak and the MERS outbreak, after that is the third outbreak which has come out. And the SARS-CoV virus 2 virus is a single-stranded RNA virus with about 30,000 bases, and it shares about 70 to 100% genetic similarity with the bad virus from which it has arisen, probably by recombination, as is the current concern. And one of the important proteins or molecules which has been important in its pathogenesis is, we all know, it's the angiotensin converting enzyme 2, or the ACE2 protein. And the ACE2 protein is expressed in high amounts in most of the human tissues, especially in the alveolar epithelial cells. And that actually is the how it is the diagram which describes how the angiotensin converting enzyme 2 is involved in the pathogenesis of the SARS-CoV-2 virus. And that's just another diagram which shows how the symptoms occur in the case of the COVID-2 virus. The ACE2 mediated binding with the TMPRSS2 protein, it mediates the release of the interleukin-6 and associated various other molecules related to the immune system, and it mediates the genesis of the cytokine storm and leading to various COVID-2 symptoms, including fever, cough, fatigue, dyspnea, shortness of breath, the sputum production, hemoptysis, etc. So most of the symptoms of the COVID-2 virus are related to essentially related to the cytokine storm which sets in. And that is another diagram which shows the pathogenesis of COVID-2 in more details. But again, due to the lack of time, I'm not going to more details. But essentially, it is similar to the entry of the coronavirus, which I described earlier, and the once the SARS-CoV-2 enters into the human cell, it mediates a lot of reactions related to the release of the cytokines and the cytokine storm, and this leads to the various symptoms related to the COVID virus infection. Okay, so what about the drugs against the COVID virus? We know that by now we know that hydrochloroquine does not prevent death or illness due to COVID virus, but it just helps to halt some of the severe symptoms related to COVID-2 virus. Neither does vitamins and minerals cure COVID-19, and antibiotics also cannot cure. Dexamethasone is actually reserved only for those with severe symptoms and should never be used for mild cases. And drinking alcohol does not protect and can be dangerous. And none of the other measures, like some of the jokes which came in between, including from the US president, like spraying and introducing bleaches into the body through other means, or do not have any protective effect. And the COVID virus can also spread in hot and humid weather, and exposure to sunlight or cold weather and snow also cannot kill the virus. So these are all well-known facts by now. So what are the proteins which are then, what are the drugs which are discovered? What are the drug targets which have been identified? There have been a few targets which were described, and this have been reviewed in some of the papers. And most of the drugs which have been against some of these, one or more of these 6 targets. One is a spike protein, that's a target 1. The target 2 is the ACE2 protein. The target 3 is the TMPRSS2 protein. The target 4 is a protease. The target 5 is the endosome, and target 6 is the RDRP protein. So these are the main proteins which have been targeted for the various drug discoveries related to COVID virus. So of course, lots of drugs have been experimented with, even though none of these have found a complete cure. Of course, drugs are there like remdesivir and all, which are essentially targeted against the RDRP protein. And what about the diagnostic test? Now, samples, as we all know, are drawn with a nasal or throat swab. RT-PCR is the most common test which has been used to detect the virus, even though other techniques are also there. For example, the NAT technique has been employed, as well as the LAMP technique, which has been employed in some laboratories. Serology testing techniques are also there, like lateral flow assays and ELISAs, which have been employed with different degrees of success. Now, what is the relevance of the rapid antigen tests? So even though they are cheaper and faster, they're less reliable and mostly have gone out of the market now. But rapid tests are done when the virus is in rapid circulation in the community or during waves of infection. And the antibody test or the serological test can also help to detect infection in the patient, even if the patient was asymptomatic, but it cannot detect the early stages of the infection. So if the patient has had the immunity to the infection, can be found out using the various antibody tests. So these are the various methods by which antibody tests can be performed, including the rapid diagnostic tests like rapid lateral flow tests and point of care testing, ELISA, which can be qualitative or quantitative neutralization assays, and chemiluminescence. All these things have been done for detecting the various antibodies. And what about the, it will be incomplete if I don't mention the other tests, or even though some of them may look like out of the sky tests, they're like sniff test, which is a 25% mixture of ethanol and water, which has been used. Imaging tests, of course, laboratory, when we talk about laboratory tests, we have also to look at the CT scan to give the lung findings. And serology tests are the saliva testing, biosensors. Breath tests have been introduced at some stage, including the corona breathalyzer, which can detect the aldehydes. But many of these have not found much utility later on to detect the coronavirus. And essentially, most of the tests have employed the RT-PCR or NAT or the LAMP testing has been done. And functional assays have also been introduced at some stage. So lots of tests have been introduced. And also, which has something which has come in between was the CRISPR-based diagnostic tests also, which have come in between. But many of these tests have not found have not been investigated probably further also, because at that time, by that time, our vaccines have become popular, and therefore there was not much need for further development of test program. So, but however, lots of diagnostic modalities have been experimented with for the testing of COVID. And coming to the biochemical monitoring of the test, we have also done some tests. In fact, I didn't tell at the beginning, we have done some in my previous institution, Amrita Institute of Medical Science, also we were doing the COVID testing. And in the present institution that believers we are doing, we have done some from the private sector. Pioneering work has been done on the COVID testing, and that is why I would consider myself to why I can present this topic. So coming to the biochemical monitoring, also we have done some work on that, even though it is not published yet. The inflammatory markers, like the cytokines IL-6 and TNF-alpha can be done for identifying the COVID-19 infection. And surrogate biochemical markers in inflammation are there, like ferritin, procalcitonin, CRP, and ESR. These have all been found to be elevated in COVID-19, but however, none of them are actually specific for COVID-19, and that is the problem essentially with the biochemical monitoring. Similarly, hematological findings include the lymphopenia, elevated neutrophil lymphocyte ratio, NLR, and platelet to lymphocyte ratio, PLR, but these have definitely prognostic potential, and that is the importance of many of these biochemical and hematological markers. And D-dimer elevation, similarly, is associated with worsening of disease and increased chances of thromboembolism, deep vein thrombosis, pulmonary embolism, and disseminated intravascular coagulation. Therefore, it is related, it is important in the prognostication of COVID-19 and not the diagnosis per se. There are other biochemical markers which inflammation can lead to multi-organ failure, and acute myocardial infarction is of course an important complication of COVID-19. And for example, you have cardiac biomarkers like troponin, the NT-proBNP, CKMB, prothrombin time, and myoglobin, which have been associated with cardiac biomarkers. And liver dysfunction is of course generally common in COVID-19 infection, and liver markers including AST, ALT, GGT, LDH, and total bilirubin have been estimated in COVID-19. Acute kidney injury is one of the major complications, and renal markers like serum creatinine and blood urea nitrogen are regularly used for the detection. And of course, you need to monitor the critical care biomarkers like blood gases and electrolytes, especially for those on intensive care and as well as those on ventilators. So these are some of the markers which are used, biochemical and hematological markers. And in fact, in the case of children, the children are equally or even more vulnerable because of the weakened immune system. And pediatric monitoring tools include the CRP, procalcitonin, and the lymphocyte count. And it has also been suggested that routine urine biomarkers like the blood specific gravity, pH, proteins, ketones, RBC, and WBC count can be useful for the identification and monitoring of COVID-19 infection, but however, these are not become very popular, even though they are non-invasive because of other tests which are now easily available. At some stage, there were suggestions of introducing these urine biochemical markers as well. So what about the testing protocol? There are lots of testing protocols which were developed during the course of the COVID-19, and these include the drive-through testing, home collection, pool testing, multi-tier testing, snapshot mass testing, as well as surveillance and population screening. All have been introduced at some stage during the control of the COVID-19 infection. Now, what is important, however, is to remember about these two basic things of any laboratory testing, that is sensitivity and specificity. Any test should ideally have the highest sensitivity and specificity before it can be introduced. Same is the case with COVID-19 also. So when we look at both of these, it becomes like a difficult paradigm how to introduce many of these tests into the routine thing. And of course, as with any other test, there are also the pre-analytical errors which had to be considered, and general pre-analytical errors as well as specific problems related to sample contamination and testing of patients, for example, who are receiving the viral therapy, etc., have also to be considered when we are looking for testing for COVID-19. And in addition to these analytical errors, problems can also contribute to error. These include testing outside the diagnostic window period, as well as various other problems related to the testing itself, including non-validated assays or lack of harmonization, instrument-related testing issues, non-specific PCR annealing, etc., can also be complications related to testing errors in the COVID-19. And essentially, to reduce errors, that is why it has been suggested that we always say that laboratory results should be checked along with clinical data, and of course, where necessary, repeatability or other use of quality control validation, etc., had to be done. And of course, training, etc., is also very important in the case of COVID. So I come to the last slide. What is the role of the private sector in combating COVID-19 and future pandemic? This is important in the present context because I personally come from a private sector, and also because there are lots of private sector institutions which are working today. Now, they can definitely assist government in diagnostic testing, especially the ICMR approved laboratories. Medical and paramedical support to the patients has been pioneerly done in the current institution where I'm working, that is Believers Church Medical College. The paramedical trained support has been provided, which can assist the government in many ways. IT related, we can do a lot of things, including creating and maintaining the databases, and manpower as well as resources sharing with government institutions. And of course, as in the various other developed countries, we can have the private-public partnership in policy making, which is as of now not much known in India, but this is something which can be done. The private-public partnership in policy making, but definitely we can provide guidelines. The results which we obtain and the experience which we gain can be helpful, providing guidelines for future pandemics. And of course, as is being done today, the public education through CMEs and general articles can go a long way in helping the public to understand about the pandemic and the ways it can be prevented. Not to mention the role of international collaboration and helping to get funding and future research. So that in short is what I want to talk about the biochemistry of COVID. I know there are a lot of things which I left out. Now, if you want to read more about the COVID, these are some of the references which I use for collecting some of the authorized data, which there are lots of information which is available on the internet also, but we should make sure that always that it should be credible information what we are looking at. And these are some of the sites where you can get some credible information about COVID-19. So thank you very much, and happy to take any questions. Thank
you. Dr. Vinod?
Thank you, sir, for that elaborate, clear and crisp presentation on COVID-19. Sir, do you have any experience in COVID-19 and diabetes mellitus in your during your tenure during the pandemic? Did you see any?
Yeah, there was of course association, that is well-known fact. But since the research work which I did, which I mentioned about, I did in the previous institution, and they are hoping to publish it. So I don't want to jump into that, because it's a faculty presentation. So I was associated with that. Actually, I was not the main author for that work. I was a co-author for that work. So hopefully you will see that there. But definitely there is an association, as has been found in other institutions as well. There is a strong association. In fact, hyperglycemia is one of the most important features.
Since your expertise is metabolic disorders, I thought you would have done something.
Yeah, definitely. It is unofficially, I could tell that there is a strong association. Yeah.
So, sir, I think there are no queries in the chat box for the time being, sir. So, thank you so much, sir, for accepting the invitation, and thank you so much for, in spite of your bad health, I didn't know, sir, for the past 2 days, you took all the strains and this thing to present for us, sir. And it was a very elaborate session on the letting us all go through the detailed structure of the coronavirus, the genomic variations that you see, the many myths that people have, you have clarified, sir, the target proteins of COVID viruses, and the various diagnostic tests, both microbiological, serological, biochemical, hematological findings, and their correlations, and the testing protocols. And the most important thing was the last slide, what you put, sir, that was the what are the measures to be taken by people, they can take it off, sir, for combating any future such similar. We hope such things shouldn't happen in the future, but still that slide was an excellent slide, sir. The measures that people can adopt, both the government, health agencies, everybody, to combat this. Combat any other pandemics shouldn't occur, sir, but if occurs. Thank you very much, sir. Now we would like to.
I have shared with the PDF of the presentation with you, madam, in case anybody wants.
Sure, sir.
You can share.
Usually after the conferences, they messages, sir. So at that time, I'll definitely share it with the delegates. It's an honor, sir. Thank you for sharing us the PDF of the presentations. Now we would like to first honor, though it's on a virtual mode, sir, we would like to honor the guest speaker, Dr. Kannan Vaidyanathan, sir, first, with a certificate and a memento, sir. Next, I would like to honor our chairperson, Dr. R. Vinod, with a certificate and a memento. Thank you, Dr. Vinod, for accepting the chairpersonship.
Thank you.
Thank you, both of you. And I think we'll wind up this session, and I'll hand over to the moderator of the next session. Thank you, sir. Once more, Kannan, sir, thank you. Thank you, Dr. Vinod.
Thank you.
Good morning, sir. We are back again. We are back again with our scientific session today. We have with us our esteemed chairperson for the scientific session, Dr. T. Sivakami, madam. We welcome you, ma'am. Yes.
Good morning, ma'am.
Madam is Professor and Head Department of Anatomy from Government Tanjavur Medical College, Tanjavur. Madam has completed her MBBS from Coimbatore Medical College in 1989. Madam has completed her MS Anatomy from Tanjavur Medical College in 1994. Madam has got a total teaching experience of 27 years for both UG and the postgraduate. Madam has served as Vice Principal from 2010 to 2017. Madam's professional achievements and awards include: Madam has been recognized as a PhD guide by Tamil Nadu Dr. MGR Medical University, has been resource person for various national conferences, has delivered guest lectures for more than 30 CMEs and conferences, has published nearly 23 papers in reputed national and international journals. Madam has also organized more than 20 CMEs, and these are the credits added to Madam. We welcome you, ma'am. Next, we have with us our second chairperson for today's session, Dr. Rashmi Avinash Patel. Professor.
Good afternoon, sir.
We welcome you, ma'am. Good afternoon, ma'am. Madam is from St. GS Medical College and Kane Hospital, Mumbai. Madam has received her qualification, completed MBBS in 2000 from Mumbai University, has completed her MD Anatomy in 2006 from Mumbai University, has completed her DNB course in 2008 from NB Delhi. Adding to her credit, the following are the professional achievements and awards. Madam is a recipient of Dr. Kulkatkur Memorial Award in MD Anatomy examination and has 4 best paper and poster presentation in various conferences. Madam has guided 3 famous projects. Madam is a member of Institute Committee for National Assessment and Accreditation Council, has published 12 publications in reputed national and international journal. Madam's area of interest includes gross anatomy, radiology, and medical education. We welcome you, ma'am.
Thank you, sir.
I request the chairperson to introduce our speaker today. Over to you.
Thank you. Yeah. Am I audible?
Loud and clear.
Yes. So very good afternoon to everyone here. It gives me immense pleasure to introduce to you a very socially and academically active, our own fellow anatomist and familiar, Dr. Kumar Satish Ravi. Dr. Kumar Satish Ravi has done his undergraduation from Muzaffarpur and post-graduation from Jipur, Pondicherry. Sir is a famous fellow from Manipal University and also a fellow of IMSA. He has done diploma in literature and currently he is designated as professor additional in the Department of Anatomy, AIIMS Rishikesh. Apart from his designated post, he has additional responsibilities as well. And he is an additional proctor and assistant controller of examination at his institute. Also ex-sub-dean in academics and ex-assistant dean academics. Formerly, he was AP and post director of head of anatomy, School of Medicine, Spartan Health Sciences University, St. Lucia, North America. Sir is a member of various national and international associations as well. And he is a recipient of Best Teachers Award in 2018, a Young Researcher Award in 2021, Best Researcher Award and Best Professor of the Year Award in 2021. Also, he has Best Paper Presentation Awards for 3 times. He has more than 75 publications to his credit. And apart from doing all this, Sir also is currently pursuing his PhD from his own institute. He has a ResearchGate score of whooping of 37.12. That itself shows how much he is involved into the publication and on. And also, last but not the least, he is editor-in-chief of National Journal of Clinical Anatomy, which we are very proud of. And Sir is the chief editor of Snell's Clinical Neuroanatomy, the South Asian edition. He's reviewer of Gray's Anatomy as well, the anatomical basis of clinical practice, the international edition. So I think this is very short to speak about Sir. There are many more things which we will obviously get to know from his presentation as well. A very apt topic on which Sir is speaking. That's it. Thank you.
Thank you so
Welcome,
much.
Sir.
Good morning, sir.
Good morning, ma'am.
Good morning, sir.
Thank you for the wonderful introduction, ma'am. I'm honored. And
Thanks,
I'll just share my slide.
Yes.
A small request to the participants. You can type your queries in the chat box speaker will be very happy to address at the end of the session.
Whether my slide is visible?
Yes, sir. Your slide is clear,
Yes, sir.
sir.
Okay. So good afternoon, one and all. Respected Chairperson, Dr. Patil ma'am, Dr. Sivkami ma'am, for the learned anatomist of the country, and Dr. Patil is well and known to me, very my colleague, in fact. Dr. Kami ma'am is very senior anatomist, and all the participants who are attending this conference. So first of all, I would like to congratulate and thank all the members of the organizing committee, including Dr. Manju ma'am, Dr. Lakshmi ma'am of AVMC, and especially Professor and Head of Anatomy and the Vice Principal of AVMC, Dr. Rajan sir, for the tremendous job what sir is doing by organizing the various academic events, you say, for the benefit of the preclinical fraternity. And apart from that, I also thank him for inviting me to deliver this guest lecture. I thank each and every delegate for attending this conference, because I always say that it's the participation of the delegates that makes any academic event a success, or you say the grand success. So today I will be talking on the topic which has been assigned to me, that is the technology to reach out the current generation students. I hope you will enjoy the talk. So before I start my talk, let me clear that I'm here neither to teach any newer technology nor to promote any of the technology. I will be just sharing my thoughts how this medical education, especially I'll be talking about the anatomy, which can be made relevant to the present generation by incorporating the various new technologies which are presently available globally, and some of them which are available presently in our country as well. So with this, the technology, because now when during this pandemic, when you say we are more towards the technology and the advancement in technology, we are witnessing, you say, the revolution in every aspect of life. And when we talk about the education is not an exception for this, right? So although this medical education, when we say, right, it is slowly seeing the digital impact in recent days, but the newer, whatever the newer technologies we are having, these are of paramount importance in reaching the present generation students, and that too very effectively, I can say. So before we proceed to know about the various technologies to reach out the current generation students, first we'll see briefly how the teaching has been, or you say the evolution of teaching, in particular to the you say the medical teaching. So when we talk about the history, right, in early Middle Ages, the doctors to be were not students. They were apprentices and taught something about the herbs and the surgical skills by the senior or the older peers, you say. So then came a transition at the end of the 10th century, and that witnessed the pre-academic teaching, right? So this was followed by the establishment of the institutions, you say, and apart from that, you say the enrollment of the students, or apart from that, we can say that there was the development of the pedagogy. So all this at the end of the 10th century we witnessed, right? And then when we see over here in this slides, so doctors were restricted to static, right? So those were non-improvable book learning, you can say. And when we talk about the dissections, these dissections were done to confirm. These dissections were not used to do, means to discover something like that. So when we talk about this ex cathedra teaching, which is certainly not flexible, but other didactic methods, you say, either you say the didactic lecture or the methods that gave this rational knowledge and its epistemology and academic dignity. So when we talk about this postmortem, apart from the dissection, the postmortem dissections were there, and they were no longer merely done to prove, you say, the Galen's words, right, but to scientifically correct them. Now, the diffusion of this printed texts and the drawings, whatever were there, that fostered the birth of the individual opinions, you say, right? And towards the end of the 16th or the 17th century, in addition to the books, the knowledge now rested on the observations, you say, and are measured on the, you say, the experiments which were performed with the new instruments. So then a new medical concept developed, and that we say barrier between the surgery and the medicine which were there was dismantled. And at the end of the 19th century, you say, the medical studies were studied par excellence, and you can say that the ideal mechanism for a respectable social promotion, and at the top of this aristocracy of knowledge, you can say that the doctors sat, right? So this is all about the history. Now coming to the present, even till recently, when we say, right, the teaching in the medical colleges were done basically by the chalk and board, you can say, which was gradually replaced by this overhead projector sheets. And I think nowadays in most of the medical colleges, we are using this PowerPoint presentations. Though I don't recommend as such the PowerPoint presentations, but definitely with the chalk and board, definitely we should use this PowerPoint presentations to make the teaching and learning process the more, you say, the emphatic or the good, you say. Now, when we see, talk about this current generation, right? So with this background, it is also essential to know what does this current generation students refer to. This current generation students, when we say these current generation students are referred as the Z students, you say, that is the Zoomers, or you say Gen Tech, or the post millennials, I generation. Today, the current generation, or you say the Z students, they account for the vast majority of the students, right? Now, like every generation, the generation Z has the very characteristic or the distinct characteristic features you will find, especially when it's come to the learning. Their classrooms, when you say, that will look different from than those were of the millennial or the previous generations. So they turn to the different sources of the information, you can say, than the whatever the sources the predecessors were having. So they consume that information and use it in ways that millennials or the, you say, the X generations never dreamed of, because these technologies or the infrastructures were not available those days. Now, when we talk about this generation Z students, right, these students show some trends that are particularly relevant in the classroom. Now, the current generation students are the digital natives, you say. Now, these students are the first generation to grow up with the internet access, you say, right? Now, playing on computers, or you say tapping on the smartphones, the iPad, or you say the tablets, and apart from that, some members can't remember a life without these smartphones, you say, or the iPad, right? So these technologies, it's simply part of the fabric of everyday life nowadays, you can say, rather than a tool what they use. So for them, this is little to no separation between in-person and the online experiences. Now, because this video chatting is there every day, they are in touch via the video chat, or the, you say, earlier, like we have only Skype, but now the various modalities are there, where various technologies are there, right? From the morning till evening, you can be online, you can be in touch with the person. So that's what I wanted to say, that there is no, or you say the little separation between the in-person or the online experiences you will be having, the present generation. Now, they rely on the social media to connect. They will be having 5,000 or the thousands of friends on the Facebook, or you have the Instagram or the Twitter, something like that. So they rely on the social media to connect, to watch, listen, or even to read, play, and share. So the most popular platforms, they can change and shift over at the time, or means anytime, you can say, because when we see, like earlier we had Orkut, now there is no Orkut, only Facebook is there. Right, so they can change. There will be a shift with the passage of the time. So the literature says that right now you can expect students in this generation to spend roughly 6 hours a day on, you say the Snapchat, a chat, you say, or the TikTok, Instagram, or the most importantly, you can say the YouTube. Now, they want in-person interaction, definitely, right? So they make tech-savvy students, and much of their social lives, when we talk about that, takes place online, right? But members of this generation also value I said that in-person interaction, or you say the face-to-face interaction, and apart from that, the collaboration, you say. So they extend that into the classroom, and you will find that the current generation, that is the 57% of the current generation students prefer in-person learning activities with the classmates. Whereas the millennials, when we talk about the previous generations, that number is just 47%, right? So what I wanted to say, that they expect personalized and on-demand experiences. When they want to watch a movie, there is a Netflix is there. When they want to buy something, there is Amazon, or you say the Flipkart. Then apart from that, Snapdeal. So many the platforms are there. So much of the current generation students' life is lived on demand. That influenced by the, you say, the algorithms that populate their news feeds, because now, because of the artificial intelligence, suppose at one photograph you stop your this mouse, right? The same kind of the advertisements you will be getting. Suppose you are seeing one ad of shirt on the Facebook, right? You stay over for a few seconds, you will be getting the plenty of ads, right, related to the various kind of shirts. So their life means, because of these new news feeds, the suggested contents and the recommended products, right? So these are the things, because of that they are more influenced, and they are because of the tech savvy, you say, that they have on-demand experiences. Now, when we talk about this current generation students, they have shorter attention spans. Why say? Because the research anyway, which measures the average current generation students, the attention span, it is just 8 seconds. When we talk about the current generation students, the attention span is only 8 seconds, you say, compared to that of the millennials. When we compare, right, who clock in, you say, the 12 seconds on average. So what I wanted to say, that the current generation students, they have shorter attention spans, right? Now, the possible explanations maybe for the, you say, because of the drop, include the pervasiveness of on-demand services, and you can say, apart from that, the smartphones, the iPads, the tablets, the computers. These are the reasons, because of the reason for the short attention spans. Now, the current generation students, they are practical also. They value self-reliance and, you say, the independence. Particularly when we talk about the self-directed learning, they are likely to search a video on YouTube to learn a new skill also. Whatever the lectures we are taking in the classrooms, right? They will go to the hostels, they will try to find those lectures on the YouTube, and they will try to learn those subjects via the videos on the YouTube, or there are the different platforms, like we have the Najib's lecture and all. So there are different platforms via that they will try to learn the subject, or you say even the new skill that will be explained via these videos. Either you say the YouTube or the different videos are there. They will be explaining the new concept, or the, you say, the subject, right? So their pragmatic attitude extends to the matters of the money, you say, and the social issues as well. So now, coming to the learning preferences, when we see before that, so the students in the classroom, there may be some of the students in the classrooms that will differ quite widely from the Z generation students, right? Because of the availability of the infrastructure to the some of the students, because there are students, those who might not be exposed to the iPhone, or you say the different computers, the laptops. So there will be the variety, right? Now, what I wanted to say, that millennials were raised with technologies too, but there was the key difference was there. They were not so much dependent on the technology, right? But nowadays, we are more pro towards the technologies, right? They were not always surrounded by these stuffs, you say, the technologies, be it the smartphones or the computers or something like that. They were not so usual. Now, they straddle a time between, to say, the analog and the digital. So their classrooms were dominated by the textbooks and the chalkboards, unlike the current generation students who prefer the tablets, or you say the smart boards. Nowadays, the smart classrooms are there. So let's take a look at the methods that resonate with the Z generation students' characteristics, and this make teaching the Z generation students easier, right? So Z generation students, a generation born into a hyper-connected world, prefers a training strategy that attracts them toward the learning, and the micro learning fits the bill, you can say. Now, when we go through the survey, through the literature, what we find that the current generation want to tackle the challenges in a fully immersive environment that lets them conduct their own research, you say, or let them make their own decisions and take the actions, you say. So not only do they find hands-on learning to be more effective, but this current generation students also say that it helps them make learning more fun and the interactive as well. Now, there is we will not be surprised that the 64% interactive classroom discussions and the 60% working through problems as the most helpful tools for the learning, you say. Compared to that, just of 38% prefer learning by seeing, I mean to say, by reading course materials, and the 12% you say value or learning by is listening. That is, I mean to say that learning by the classroom lectures. And when we talk about the present, this competency-based medical education, this current competency-based medical education also stresses on the acquisition of the skills, starting from the very first MBBS, which adds to learn better by the practical knowledge, you can say. Now, when we see over here, close there's whatever the textbooks which we are having, right? Because today's students are overwhelming, as I said, turning towards the video platforms like YouTube for learning. Now, only not only this current generation spend a significant amount of time on YouTube every day, maybe up to, you can say, 3 to 4 hours or more than that. To be exact, you can say that 59% of the students, they say that it is their preferred learning method, right? In fact, video is already a prominent in teaching current generation, with 55%, you say, reporting that YouTube has contributed to their education, specifically when we talk about this pandemic in the COVID, during the COVID period. So this has contributed towards their education, or you say learning, or up to the extent even to the personal development. So it also satisfies their desire, as I said, for on-demand content. Right now, suppose even though the neuroanatomy lectures are going on in the you say the college, medical colleges, but if they want to revise this upper limb, immediately they will click the YouTube and they will find the lectures of the brachial plexus or the upper limb, you say. So that is on-demand content available is there, and they are the tech forward, you say. They prefer learning on the video. So during pandemic, we have seen many teachers also, the faculty of the anatomists, they have uploaded their lectures like anything. Every day we used to see on the WhatsApp group or on the social medias that the faculty members are uploading their each and every lectures on the YouTube, so that the students, even sitting at their home, they can learn through these video lectures, right? Now, just for an example, I'm playing one of the faculty's video.
This is a brief overview of the embryological rotation of the midgut. Arterial blood to the gut tube is supplied by the abdominal aorta. The gut tube is composed of the foregut with blood supply from the celiac artery, the midgut with blood supply from the superior mesenteric artery, and the hindgut with blood supply from the inferior mesenteric artery. During the 5th week of development, the midgut starts to loop ventrally, herniating into the umbilical cord. This growth process creates much of the resulting length of the intestines. The cranial limb of this midgut extension will ultimately form the distal duodenum, jejunum, and part of the ileum. The caudal limb of this midgut extension will ultimately form the distal ileum, cecum,
So
appendix,
what I wanted
ascending-
to say that when we teach this, suppose this midgut rotation by chalk and board, and then by playing this animated videos, right? Definitely when we compare the learning with the chalk and board and with these animated videos, the students' response will definitely be very positive because it will have a great learning impact. So that is what I wanted to say, that along with this chalk and board, these technologies we can
This is a
use.
brief overview.
Now, when we talk about this social learning, the collaboration counts, right, for this generation. And that seeks to engage, either you say to share the knowledge, you can say, or you can co-create with the from others online, or you can say the offline. So their social learning networks could include their classmates, it may be the friends or even the family and even the peers from around the world, right? Different parts of the country or the world, they can involve their peers or the friends, and then this social learning will allow students to learn from each other, either you say through observation or through the participation, discussion, or different ways of solving the problems faster than learning by own, you can say, right? So these are the different ways. When we talk about this, the preference, right? They prefer to study, then if you see this social learning, means in the current generation students, the 80% will tell that they prefer to learn with the friends. Even we teacher, we say to our students that try to learn anatomy with your friends, try to discuss whatever the topics you are studying, try to discuss with your friends, and definitely that way you will learn better. So 60% of the students, you can say, they're happy to share their knowledge online with other their colleagues or the friends, you say. Now, apart from this social learning, when we say we have the personalized learning. Now, when these classrooms are there, right, this classroom activities and the instruction will be there, that will involve the multiple formats, like the different levels of the challenges will be there. And apart from that, we will have the different options for the assessment learning. It can be, you say, the tailored for each other students' individual needs. So what I wanted to say, that adapting learning is an example of personalization in action. So it depends on the students, the different various students. So the involving students in learning, you say the decisions and direction can help the students in their personalized experience without overburdening the teachers as well. So personalized learning prefers to an individualized form of learning, which can be programmed. If you see the personalized learning, this figure shows there are different important components of the personalized learning, like we have this integrated digital content. Apart from that, we have the targeted instruction, right? And the data driven decisions are there, student reflections and ownership will be there. So what I wanted to say, that due to differences in the individual students' learning style and the innovative changes in the technologies, this personal learning has become a recent approach to deliver a student-centered teaching by the educators, or you say the health educators, right? So when we see this social learning or the personalized learning, we have another way of learning, that is the hybrid learning. Now, this current generation students transition smoothly between online and in-person interaction, whether it is the way they socialize with each other, right, or the way they learn. So hybrid learning is all about the blending the traditional classroom, what we can see in the diagram over here, with the methods of the using the e-learning. And the better news is that for this generation, the technology has a huge role to play when teaching these generation students. So you can teach them in the class, and immediately you can assess using some of the apps, like when we talk about the Kahoot app, right? So this Kahoot app can be a platform that lets the teachers and the students create and use different kinds of the multi multiple choice questions, or you say the clinical vignettes in a simple way, through the you say the online or even in the classroom, they can be assessed. So these are the various ways which can be used. And apart from that, we can focus on the cross-disciplinary alignment. So what I wanted to say, that with this cross-disciplinary alignment, right, the current generation students, they are classroom friendly. So consider building these aspects into your curriculum mapping and lesson planning processes. Like when we talk about, when we are teaching this anatomy, right, connect and promote learning across several subjects. Like anatomy, when we are discussing anatomy, when we can discuss the pathology, after discussing this normal structure, we can discuss about the abnormal structure. Then accordingly, we can discuss the medicine and the surgery. So we can follow this horizontal, or you say the vertical integration, and this will not only serve to keep the students engaged, but it also provides the opportunities for making the concepts the interesting, right? So this cross-disciplinary alignment also we can follow. Then apart from that, the student informed learning. The students' opportunities means whenever we give the students opportunity to get involved in their own development, right, that will offer more choice in how they want to consume the classroom materials, or you say the complete assignments, or you say they receive the assessment or the access resources. So we should make it more relevant when we involve the students. Apart from that, there are the different technology, like we have this integrated technology. So don't leave those iPads or the tabs at the front of the classroom, but find ways to include them in your lessons apart from leaving those. So teach means these technical instruments, the equipments can be our friend when it comes to engaging these present generation students. Like when we, there is a study which has reported that the common medical this applications used by the students, where when we talk about when we teach, or when they learn anatomy, where the medical dictionary in the first MBBS, whereas when we talk about the second MBBS, they were using this medical dictionary. Apart from that, the Medscape and the Google or the Wikipedia, right? Similarly, when we talk about this third MBBS students, they were using this Google or the Wikipedia, and apart from that, the prognosis or the diagnosis apps are there. So more than 90% of the students were there. They were using some of the applications or the technological skills to use these smartphones, right? So what is happening, that these smartphones for the medical students can be used as a learning aid for the various medical applications, which is rapidly advancing, right? I think we are short of time. We'll try to finish over here. So apart from that, there are the visual aids are also there. Like when we say visual aids, that means you say the visual, audio, reading, and the kinesthetic. So for example, when we talk about anatomy, we use more of the visual aids to provide better understanding. Similarly, when we can use stories or the different case scenarios when we discuss the physiology for understanding the different concepts, right? Now, there are the general preferences are there when we talk about the recent technologies in anatomy. So anatomy teaching or the anatomy education that merely started with the background method has evolved through the overhead projector, the PowerPoint, you say the presentation, we have the 3D models, the virtual dissections, and now online teaching, you say the 3D virtual dissections are there. So where there are different models are there by which we can teach them. We will skip, right? So apart from that, we have the web-based learning. Then apart from that, we have the different, you say the computer-based educational programs are there, right? Then apart from that, we can see over here that virtual classrooms are there, anatomy studios are there, right? Then we have this artificial intelligence, the humanoid robots are there, the various technologies are there. Then apart from that, we have this cloud technology, then the 3D stereoscopies are there. We have this virtual dissection. It is very common nowadays because even the NMC, when we talk about this National Medical Commission, they have this virtual dissection table they have recommended in all the medical colleges, right? Now, when we say even in our institute, we have the 5 virtual dissectors. So during this pandemic, most of the medical colleges, they were using this virtual dissection table because of the scarcity of the cadavers, and this the classroom teachings were off. So they started depending on the various technologies, right? Now we have this high fidelity simulators are also there. So there are different technologies are there which the people are using to teach and train the students. Apart from that, we have different imaging modalities are there, right? Then apart from that, we have the haptic technology or the immersion. In this, you can see the virtual reality will be there, which will be apart from that will be associated with this augmented reality. So what I wanted to say that there are different technologies which we can use to teach and train the students. Apart from that, even the 3D printing technologies are there, by which you can see that we have at AIMS Rishikesh, we have prepared the different models, right, which we cannot see by the naked eyes, like you can say even the ear ossicles are there. These can be prepared by the 3D printing technologies, right? Apart from that, we have the different social medias, right? These social medias are also being used to teach and train. There are the different WhatsApp groups are there. With the help of the WhatsApp group also, we provide the different teaching materials, and we discuss the different problems we try to solve on the WhatsApp groups. So these social medias are also being used to teach and train the students. Now, these are the different literatures you can go through, right, what we have worked on. So this will be the further thoughts you can go through, that what are the different technologies nowadays we are using to teach and train specifically the anatomy, right? So we have published this integration of this innovative educational technologies in anatomy technology, the new normal in anatomy education. Similarly, you can see over here the potential scope of the humanoid robot in anatomy education, and even the artificial intelligence, whether in anatomy, what kind of role it will play. So these things you can go through and you can learn. So what is the, you can say, the take-home message of today's, what I wanted to say, that the continual integration of the technology into education is crucial for the improvement of the learning outcomes and addressing the cognitive load associated with the volume of anatomy education and training, because we have limited time, and in the limited time, we have to give so much of information right to the students. So the certain traditional, you can say, the practices are almost synonymous, which are being used, because you say the cadaveric dissection cannot be replaced, right? With the help of the, apart from this cadaveric dissection, we can use the different technologies. So the traditional methods will be there. These traditional methods were facing challenges during the pandemic because of the scarcity of the cadavers. But when we say this, if the pandemic lasts for several years, suppose if it would have been continued, right? So it would have been impossible to teach the students in the traditional ways. So technology remains, you say, the dependable means to guarantee that the students do not have to bear the deficits which are resulted because of this, you say, the pandemic, right? Whatever is not available. So there is no chances that we should only be dependent on the cadaveric dissection, but we can use the different technologies to teach and train the students. So we should, there should be the judicial use of these technologies, and creative adaptations should be there in the need of the hour, because there may be things are changing. So accordingly, we should change also. We should not stick to the traditional methods, and we should be open to the different technologies which are coming up. So you can refer to the various articles, and this is all about, I wanted to say that we should be open to the technologies what we are getting nowadays. So because of the scarcity of time, we couldn't cover much, but what message I wanted to give, I've given. Thank you so much.
Thank you, sir. Sivakami, ma'am.
Sir,
Yes,
good afternoon, sir. Dr. Ravi, sir.
Yes, ma'am.
Can you hear me?
Yes, ma'am, I'm audible.
Yeah, sir. As usual, you rock the sessions
Thank you, ma'am.
with your inputs, and I don't know much. I don't want to say much about it. And so, as you said, anything is the cadaver is the best means of the teaching, and with little hybrid. Yeah, I am for hybrid learning, sir. That's the thing.
Why? Because, ma'am, see, when we talk about this, why cadaveric dissection is still relevant and it will remain relevant, right? Because
Yes, sir.
it cannot be technology based. When you have to feel the artery, when you have to feel the nerve, right?
Yes,
When
sir.
you're operating on the table, you should have
Yeah.
that. By feel only, you can differentiate that. Okay, this is the artery, this is the nerve,
Yes,
right?
sir.
And in the technology, that empathy will not be there, ma'am, right? So
yes, sir. Yes, sir.
when we are in the dissection hall, right, not only we give the subject material, we also teach them the different, you say the sympathy or the empathy, different things we teach, right? They learn how to deal with people.
Yes,
Right? So those things
yes,
are required. We should not be completely dependent on the technology.
Yes, sir. Sir, actually, I want to tell you a feedback. One of our house surgeons, she finished the course and she came to anatomy department and she wanted, ma'am, I want to see the heart again. And I want to recapitulate all the structures and the parts and the course of the coronary arteries and the heart. She came after finishing her course. So that is what, see, the one thing is this, the tactile sensibility which we provide in this cadaveric section, and moreover that is more prominent in the cadaveric workshops also, sir. That's what I wanted to say.
Right, ma'am. Thank you.
Yes, sir. Yes, sir. Thank you so much, sir. Thank you for your wonderful and excellent speech, sir. Thank you so much, sir. Thank you, Dr. Ilangudi, sir, for giving me an opportunity. Thank you so much, sir.
Can I comment?
Yes, ma'am. Yes.
Hello. Yes, Dr. Satish Ravi.
Yes, ma'am.
So, yeah. So it was an excellent presentation. I think that definitely we all anatomists would agree that we cannot replace dissection. So dissection is going to be there as a part and parcel of our curriculum and as well. What I feel is probably as per your topic, because it was technology to reach out to the current generation. And as we all know, they are all those alpha generation now, which is coming. Probably it's time for us to change because COVID has taught us. Maybe it was the right time where we learned probably we should tune to our students. So I feel because that generation is more into technological aspects rather than what we are probably. So probably all these programs and all this technology, a part of it, probably we should know. This is what I feel. I may be wrong, but I don't say that cadaver is totally outdated. No, it will never be because it is the one which is required. This is something as aided, as you also mentioned in your session, that it needs to be aided.
Right.
My question was, you mentioned that, yes, NMC has incorporated that each institute should have the anatomy table and all. It has mentioned, but then I just wanted to stress upon that still major institutes do not have basic requirement as internet connection as such. So using Kahoot app and other apps to make our session technologically great, it is good, but then this basic amenities need to be provided. Probably the institutions, if that is a guidelines or that is one of the criteria, it becomes a mandate. Probably institutes would work on it.
Exactly.
I belong to a municipal corporation institute, a government institute, and there probably we had issues during COVID because we never had this stable internet connectivity. COVID times we could manage with somehow or the other, but then if it has to come from an institute with a stable source to cater to so many.
I think there is some network issue.
Network issues, sir.
So,
am I audible?
Yes, ma'am. Yes, ma'am.
Sorry. So I probably feel somewhere that measures need to be taken as well. So that has to be there, and more stress has to be given on peer teaching.
Right, ma'am.
Because peer teaching is one probably which can help our students. They have incorporated SDLs, self-directed learning. but somewhere peer teaching should also be included. This is what I feel.
I fully agree, ma'am. Whatever is there means what I would like to say that there should be appropriate amalgamation of the technology, right? We should not be dependent, and still this means you say that strong educators are required by the current generation students, right? For the learning and the development, you say. Though they need this strong means the leading educators, right, to train them. And I fully agree with you that there are most of the institutes they do not have these virtual dissection tables still at present, even though this NMC has recommended. NMC has not made it mandatory, but they have suggested that
over a course, that's what I'm saying. Over a course, they may procure it. But what I'm trying to say, the basic amenities needs to be there in place.
Exactly.
Rather than having such things, because the cadaver is the main thing which we should have probably. During COVID, we had dearth of cadavers. We were not supposed to embalm and all those things. So that was so maybe table is good, but it is still not to the absolute mark. It cannot ever replace cadaver. That is what I feel.
We don't get fund also, especially when we talk about the basic departments. We don't get, even in the medical college, means we don't get funds. I fully agree with that. But whatever the technologies are there, what I wanted to say that we should be open to that, right? Whatever the possibilities are there, we can always work on that.
Yes, sir.
Can I speak, sir?
Yes.
Yes, ma'am. You are in line. And we don't see any queries in the chat box, sir. If it is there, we will forward to you, sir. You can just answer them. We'll distribute to the participants.
Dr. Ilangadar, 1 second.
Yes, sir.
Just to say hi to sir.
Sir,
how are you, sir? Thank you so much, sir, for joining with us.
Yes, sir. It's always pleasure to be. And I really appreciate the way you organize. I see you as a man of academic events, sir. The way you organize the conference, it is extremely good. So many things to learn. Today also, I was watching everything, how to organize the conference on the this online platform, right? You say the even lamp lighting ceremony and all, then national anthem, everything was done as we follow in the, you say the physical conference, right? So nothing you have missed, sir, in the online conference. And I really appreciate, I'm grateful to you that you give me an opportunity to deliver the talk. I would have got more time to discuss in depth, but because of the scarcity of time, I couldn't discuss in detail. No problem. It's some other day we'll discuss it.
Yeah, we'll meet in other platforms, sir, physically.
Thank you.
Thank you, sir. Thank you, ma'am. Swami, ma'am, Sarla, ma'am.
Thank you. Thank you. Hello, sir. How are you? Thank you. Thank you. Thank you.
Okay,
Bye-bye.
Thank you. Thank you so
Thank you,
much.
sir. Thank you, ma'am. That was a wonderful presentation, sir. Now it's time to honor our speaker with a certificate and memento. We also would like to honor our chairperson today, Dr. T. Sivakami ma'am, with a certificate and memento. Followed by, we would also like to appreciate Dr. Rashmi ma'am for being chairperson for the scientific session today.
Thank you, sir.
Thank you, sir. Thank you, ma'am.
It's my honor. Thank you, sir.
Thank you, ma'am.
Thank you so much, ma'am. Thank you, sir.
Thank you, sir. It's time for the next moderator to take over. I request the participants to stay online. The next moderator will join you shortly.
Good afternoon, everyone. The next talk is on unraveling the epigenetic mechanisms. We have with this Dr. Arun Kumar Dayanand. He is Associate Professor of Biotechnology, Pondicherry University. This session will be chaired by Dr. S. Ravi Kumar, who is Associate Professor and Assistant Director of Research, Multidisciplinary Center for Biomedical Research at Arupadi Veedu Medical College. Dr. Ravi Kumar completed his PhD in Biochemistry and Molecular Biology at Pondicherry University, India. He has worked for more than 9 years in South Korea as a postdoctoral fellow, as a research professor, assistant professor. His research interests lie in the area of diagnostics, pharmacogenetics, genetic engineering, evidence-based medicine, bioinformatics, nanotechnology. He has also published more than 50 research articles and has received a patent. He has presented many lectures and oral presentations as keynote speaker at various scientific meetings. Sir, we invite you to chair the session.
Thank you, Dr. Aarti. So today we have eminent scientist, Dr. Arun Kumar Dayalan. I'm very happy to introduce him. He's an associate professor in the Department of Biotechnology, Pondicherry University. Dr. Arun Kumar Dayalan did his PhD in biochemistry at the JEX University, Germany. After finishing his PhD with a special distinction, he has also completed his postdoctoral work at the same university. And Dr. Arun Kumar Dayalan has been received the Innovative Young Scientist, Young Biotechnologist Award from DBT, the Government of India. And also he received the UGC Research Award from the Government of India. And he was being awarded 9 times consecutive years as a Best Teacher Award at Pondicherry University. Currently, he's heading a research project with a budget of 3.6 crores sanctioned to him by DPT Wellcome Trust Indian Alliance. So only the few scientists and few professors have received this fellowship. Actually, it's a great honor to him. Actually, he has completed and Dr. Dayalan, he has completed several projects with a total budget of 2.39 crores from different funding agencies. And he also published 39 articles in the reputed journals with a cumulative impact factor of 227 with H index of 19, I-10 index of 26. And he is also an associate editor in the research journal PMC Biochemistry, and also edited a structural activity of functional of protein methyltransferase in the Life impact factor 3.8. Now I call upon Dr. Arun Kumar Dayalan for its topic in epigenetic mechanism.
So, good afternoon. Good afternoon, all of you. Am I audible to the?
Yes, Arun, you are audible.
Right. All right. So it's in fact it's time is exactly at 1 o'clock. I don't know whether it's the right time to talk about science for a long time. Maybe I'll reduce my talk for 35 to 40 minutes. Try to finish within that. And before going to the talk, I would like to thank Dr. Ravi for inviting me to deliver a lecture in this wonderful e-conference. I also thank the organizers and the AVMC Institute for hosting such a wonderful conferences, and it is indeed a pleasure to deliver a lecture in this conference. So this talk, what I have designed this talk is a little bit different than my usual ways. So we usually tend to present a lot of research data and new advances from the lab. But this time I have decided, since Dr. Ravi told me that a lot of clinicians are attending the conferences, so I was thinking maybe I should not do that, and I will do it in other ways so that we will appreciate some of the epigenetic signaling mechanisms which is going in the human systems. Okay, so that's what I'm going to do this. Let me share the screen. Is my presentation is visible? The screen is visible to you?
Yes, sir. Yes, sir.
Okay, all right. So we know that all the human cells carry the same genetic information, but yet they differentiate into different cell types and tissues. So the genetic information in the human cell should be expressed at the right time and right place. So the regulation of this gene expression in different tissues are brought about by various epigenetic mechanisms. Okay, so the term epigenetics itself can be defined as a change in phenotype that is heritable, but that does not involve the change in the DNA sequences. On the one hand, these epigenetic signals are stable and heritable. On the other hand, they are reversible. That's the beauty of this epigenetic signaling system is concerned. Whereas if you have a genetic mutation, you had it for your life. You cannot change it. But epigenetic signals can be written, erased, and rewritten, depends on the environmental cues, whatever the cell is
fission. So in the higher eukaryotes, even in lower eukaryotes, for that matter, the chromatin, the fundamental structure of the chromatin, exists in two distinct structural and functional conformation. One we call it as a euchromatin, which is a transcriptionally active and silent state of the chromatin. The other one is highly condensed state of a chromatin, which is transcriptionally silent. So the switch between these two different structural and functional states of the chromatin is mediated by various epigenetic mechanisms. And the major ones are listed here. The major ones, which includes the post-translation modifications which are taking place in the N-terminal tails of the core histones, and the addition of linker histones and the DNA methylation, ATP-dependent chromatin remodeling complexes. They can switch any of the structure from heterochromatin to euchromatin or euchromatin back to heterochromatin. Okay, so they are controlling the chromatin structure, and the chromatin structure in fact decides what all the genes needs to be expressed in particular point in time and space. And this from book, we know that standard information, the contour length of the DNA of a human cell is 2 meters, but this 2 meter DNA needs to be packed in a size of a nucleus, which is less than 10 micron in the size, right? So this means this DNA is extremely compacted up to 10 to the power 6-fold in an organized way inside the nucleus. So the DNA, the DNA forms a chromatin structure. The fundamental unit of a chromatin is a nucleosome, which is made up of a histone octamer, which is wrapped with the DNA, and the histone octamer consists of 2 copies of 4 different types of histones, H2A, H2B, H3, and H4. And this histone octamer is wrapped with your DNA, and that forms the basic unit of the chromatin. This is your typical beads on a string structure or 11 nanometer fiber, or which we classical terms we call it as euchromatin. And again, this 11 nanometer fiber tends to fold to form a higher order structure, which is a 30 nanometer fiber. And 30 nanometer fiber is your typical heterochromatin structure. And all the DNA dependent process, whether you talk about the DNA replication or a transcription or repair, everything happens at this level. If it folds into 30 nanometer fiber, the DNA dependent processes are not possible. Okay. Then the 30 nanometer fiber further coils to form a loops form a rosettes, and with the help of scaffold protein, finally form a full chromosome regular structures, right? And if you look at this basic unit, this nucleosome, as I told you, this histone octamer, which is wrapped with the DNA. If the diameter of the structure is 11 nanometer, that's how we come up with the hypothesis 11 nanometer, the typical euchromatin structure. And what is most interesting is this is a single nucleosome, and the inside you see this histone proteins. There are 4 different types of histone proteins are available inside this nucleosome, and each one is present in 2 copies. And this is the DNA which is wrapping around the histone octamer. What I would like to point out is the interesting phenomena is the N-terminal tails of this histone proteins are protruding out from the nucleosome structures. Okay, so they are part of the nucleus. The histone proteins is a part of a nucleosome, but if you see the tails which are coming out from the nucleosome structures, and these tails are totally unstructured, completely unstructured. They are just like a peptides which are hanging out from the nucleosome structures, and these peptides undergo a lot of modifications. That modification decides whether the chromatin should stay in a heterochromatin structure or euchromatin structure. And again, the assembly of the histone octamer is not a random process. So first you have this H3 and H4 histone should form a dimer, and 2 of this H3 and H4 dimer should interact to form a H3, H4 tetramer. And similarly, H2A and H2B forms a dimer, and 2 of the dimers forms the tetramer. And these 2 tetramers then again interact and forms the histone octamer, which is wrapped with the DNA to form a typical nucleosome structure. And all these processes are not random events. These are guided process. There are a lot of chromatin assembly factors, the protein factors which are involved in this process to make a proper nucleosome structure. And as I told you, the essential portion of your nucleosome structure is occupied by the histone proteins. The interesting aspect is the N-terminal region, the first 30 to 40 amino acids in the histone tails, the histone protein as such is unstructured. They do not form a secondary structures, but these unstructured tails, which comes out of the nucleosome structure, and they're protruding out from the nucleosome structure, meaning that these tails are accessible for various enzymes to do a lot of modifications. If an enzyme has to access an amino acid which is present at the core of the protein, which is difficult, but if it is presented in the form of tail which is protruding out from the common structure, then it is easily manipulatable. Right. So as I told you, the tails undergo a lot of post-translation modifications, unstructured post-translation modifications, such as you have acetylation, methylation, ubiquitination, ADP ribosylation. Name a post-translation modification, you will find it in the histone tails, phosphorylation, everything, all kinds of modifications are available. And each modification have an influence on the chromatin structure. There are certain modification which promotes the euchromatin structure. There are certain modification which promotes the heterochromatin structure. For example, if you have an acetylation modification in the histone tails, that definitely forms your euchromatin structure, 11 nanometer fiber. So then the transcription is possible, gene expression is possible. But if you have some other modification like a methylation at K9, so these are the different lysines and other amino acids which have got modified by different enzymes. For example, if you have a H3 tail, if the K9 is methylated, then it forms the heterochromatin structure. Whereas if K4 is methylated, it forms a euchromatin structure. For acetylation, we have a clear-cut signal. All acetylation promotes the euchromatin structures, and the absence of acetylation promotes the heterochromatin structures. But if we talk about the methylation, the functional outcome is totally different. Depending upon the position of the lysine or arginine which is getting methylated, the functional outcome may vary. For example, as I told you, if the methylation happens at K4, it promotes the euchromatin structure. If it happens at K9 or K27 of H3, that promotes the heterochromatin structure, which is going to suppress the gene expression. And we have to also understand that each lysine can be methylated at 3 different degrees. Either they can undergo for a monomethylation or a dimethylation or trimethylation. Similarly, arginines can also be methylated. They can undergo a monomethylation or a dimethylation. And arginine dimethylation comes in 2 flavors, whether they can undergo for asymmetric dimethylation or symmetric dimethylation. These are the small post-translation modifications which are present in the histone tails, and these combinations of this different modification decides whether the chromatin should stay in the heterochromatin state or a euchromatin state. Suppose if you want to express a gene, then the heterochromatin should melt into euchromatin structure, then only the DNA is accessible for your transcriptional machinery like RNA-pol. Right. Again, I showed on the previous slide, different modification brings about a lot of different outcomes on the chromatin structure. For example, I told you the K9, if it is methylated, it forms a heterochromatin. If K4 is methylated, it forms a euchromatin structure. How the small methyl group addition brings about the large structural changes in the chromatin? This is done by a set of proteins known as the reader proteins or effector proteins. These are the proteins which could recognize this modification and translate this modification into function. For example, if K9 is methylated, this is recognized by a special reader protein called heterochromatin protein 1, which is the heterochromatin protein 1, if it binds, then it tends to multimerize among itself, thereby it brings different nucleosomes close to each other and forms a strong heterochromatin structure. Similarly, if you see this H3K4 methylation mark, this small methylation mark, how can open up the chromatin structure? This is because the methylation mark is again recognized by a special protein known as a BPTF. Once the BPTF binds to this methylation mark, and this protein do not bind to the histone tails if these residues are unmethylated. Only if it is methylated, it can bind. So if a H3K4 trimethylation, if you have, that invites the binding of your BPTF protein factor, and BPTF protein factor is going to bring the chromatin remodeling complexes, because BPTF can interact with the chromatin remodeling complexes, and the chromatin remodeling complexes utilizes ATP and tries to melt the hard heterochromatin structure back to euchromatin structures, wherein the transcription is again possible. Right. And just to illustrate that, different tails are there. You have H2A, H2B, H3, and H4. Each of them present in 2 copies, and all the tails undergo different various types of modifications, and major modifications are happening in the H3 and H4 tails. So this is just to illustrate. I don't want you understand what is going on here, just to give an overview of the pictures, what types of post-translational modifications are possible with this histone proteins. And as you can notice, this a lot of modifications are possible. Okay, so for example, arginine 2 can be methylated, K4 can be methylated, again R8 can be methylated, K9 can be acetylated or methylated, S10 can be phosphorylated, K14 can be acetylated. Different modifications are possible, just to put it in a nutshell. Okay, and the combinations of this different modification decides the chromatin structures. So this is in case of H3, and this is in case of H4. Again, a lot of modification, and H2A, H2B relatively small modifications, and H2A and H2B also undergoes ubiquitination. And this ubiquitination is a mono-ubiquitination. Don't be confused with a polyubiquitination, which is a mark for proteasomal degradation. This ubiquitination is a PTM, which provides a certain signal for the chromatin structure. So to summarize, most of the modification promotes the formation of heterochromatin. For example, especially the methylation. If a methylation happens in the K9, K27 of H3, or K20 of H4, or K36 of H3, that promotes the heterochromatin structure. Again, sumylation promotes the heterochromatin structure. Okay, whereas the methylation, if it happens at K4, different lysine residue in the same histone protein, that promotes the euchromatin structures. Acetylation, all acetylation in general promotes the euchromatin structure. Okay, so deacetylation represents your heterochromatin structures, and phosphorylation also promotes your euchromatin structure. And ubiquitination is so special. If it happens at H2A protein, it promotes the heterochromatin structure, whereas if it happens at H2B, then it promotes the euchromatin structure. So these are the different modifications. All the modifications are possible in the histone tiles. At any given point in time, what are the modifications which are present in the histone tile? That we call it as a histone code. It's a kind of a sign language, code language. This PTM forms a code, and this code decides what are the modifications are there, what modifications are there, whether these modifications promote the euchromatin structure or heterochromatin structures. Based on that, the chromatin goes to the 30 nanometer configuration or 11 nanometer configuration. Based on that, the gene expression is possible. Okay, so if it stays in the heterochromatin, there is no expression is possible from those regions of the chromatin is concerned. Right, so to move from euchromatin to heterochromatin, you also need a linker histones. This is called H1. This is not part of your nucleosome structure, but the two nucleosomes are connected with a DNA called a linker DNA, and the linker DNA should be associated with the H1 to form a 30 nanometer fiber. So the linker DNA means the linker histone serves like a glue, because if you have two nucleosomes which is supposed to stack with one another, there is an electrostatic repulsion comes from the phosphate backbone of your DNA. So you need some positively charged protein which is present between to allow the stacking of the two nucleosomes to interact with each other, and this is safely done by the linker histone. So linker histone is essential to go for the heterochromatin structure. So this is just to give an overview. So from 11 nanometer fiber, that is euchromatin, to 30 nanometer fiber, that is heterochromatin, is possible, and this is guided by the protein factors as well as the PTMs which are present in the histone tail, as well as the DNA methylation. DNA methylation promotes this structure, heterochromatin structure. So absence of DNA methylation promotes your euchromatin structures. Okay, so generally a melting of heterochromatin to the euchromatin is done by ATP dependent chromatin remodeling complexes, and mobilization from 11 nanometer to this is done by our H3K9 trimethylation modification, which is recognized by HP1 proteins and so on and so forth. And H1 is, of course, it is needed to move this direction. And this PCC represents the polycomb group of proteins, and polycomb group of proteins is going to introduce this H3K27 trimethylation modification that is very, very essential to move the chromatin from euchromatin state to heterochromatin state. All right. So I just give some of the impact of different modifications. First, we will start with the acetylation. So as I told you, in general, the modifications, histone acetylation modification promotes the open chromatin structure, that's the euchromatin structures, wherein the transcription is possible. If you don't have acetylation modifications in the chromatin, the histone tails, that helps in the condensation of the chromatin, that is going to block the gene expression is concerned. So then once you know this aspect, then many transcription factors, many transcriptional activators are found to be associated with histone acetyltransferases, the enzymes which introduces the acetylation modification. So in order to do the transcription, not only you have to assemble the pre-initiation complex at the promoter, but you also also has to open up the chromatin, making the DNA template available for the RNA polymerase to do the transcription. Okay, so for melting of the DNA, often many transcriptional transactivators recruits histone acetyltransferases. Okay, and opposite is true for your transcriptional repressors, because the repressor binds to the repressor elements and often recruits histone deacetylases, which is going to remove the acetylation modification, puts the chromatin in a condensed state and thereby inhibiting the gene expression. So I think histone acetylation, methylation, the presence of this modification is discovered in 1964, and I think it took about almost 30 years to identify the first histone acetyltransferase. This is done by David Ellis group. In the next year, histone deacetylase has been identified again by Schreiber group. Then followed by, so then once they identify the enzymes, there are many groups which are working on the transcription factor complexes. They identified all the activators, most of the activators recruits this histone acetyltransferases, and most of your repressors tend to recruit the histone deacetylases. As a part and parcel of your transcription process, you need these enzymes to open up the chromatin, and the part and parcel of your regulatory suppression process, you have to close the chromatin with the help of heterochromatin with the help of histone deacetylases. And one group of histone deacetylases, one class is called, so we have different classes of histone deacetylases. As I told you, histone deacetylases are going to remove the acetyl group and acetylation modification in the histone tail, thereby promoting heterochromatin. One class of histone deacetylases are called serotins. Okay, so this information comes from yeast, then it was found in the humans also. We have 7 different types of serotins, and the serotin proteins are so special. And this serotin is a histone deacetylase. This removes the acetylation modification from the histone tail by using a very complicated reaction mechanism which utilizes NAD plus as a cofactor to remove the simple acetylation mark. Because usually the acetyl group can be, the enzyme can simply do the hydrolysis to remove the, you can do the acid-base hydrolysis to remove the acetylation modification, but somehow this enzyme does very complicated way of a reaction mechanism to utilizing NAD plus to remove this acetyl mark. Because initially people do not have any clue about it. Later they found that these enzymes are present for the purpose. Okay, for example, during a calorie restriction or when you're in a fasting state, what happens is your NAD plus level goes up and NADH level goes down. Okay, if NAD plus level goes up means then NAD plus level, the higher NAD plus level activates the serotins, and the serotins, if you have a sufficient NAD plus as a cofactor, that is going to deacetylate many regions of the chromatin, and many regions of the chromatins are put under the heterochromatin state, especially the rDNA region, which is supposed to code for the rRNA genes. So if you silence this rRNA expression, what is going to happen is you silence the translation, the global protein synthesis you put down. If you go down with the global protein synthesis, then your metabolism decreases. If your metabolism goes down, then you have lesser and lesser reactive oxygen species, lesser and lesser damage to your DNA. As a result, you delay the aging process. So calorie restriction is many studies connected with delaying in aging, but the molecular connections are understood with the help of serotins, because in yeast and other model organisms, they have shown that if you knock out the serotins and even if you do the calorie restriction, between the control knockout and this knockout of serotin, you don't see the effect. So partly the effects with calorie restriction longevity is kind of mediated through the serotin pathway, because serotin during your calorie restriction or fasting, you increase the NAD plus level, which is going to activate the serotins, and serotins are going to remove the acetyl mark. So that's the idea. That's what they shown. And again, as I told you, there are the SYN3 and NORD CoREST and NCOR are different, well studied repressor complexes. Once the histone deacetylase has been identified, a lot of these complexes are tend to have the histone deacetylase as a part of their complexes, meaning that they are not only blocking the transcription, but also they are condensing the chromatin, making them to heterochromatin, making the transcription is not possible. Right, and this picture just to tend to say this is a collection of genes, almost 100 genes. These are the genes which are expressed in low quantity, and these are the genes which are highly transcribed, means highly expressed. And what they have found is this is a transcription start site, and this is your proximal site to the transcription, and this is a distal site. And you have a protein coding region is shown here. There is a 5' end, you have a 3' end, and this is a mid end. Okay, and throughout the genes, this 100 highly transcribed genes and the 100 low transcribed genes, and they profile the histone acetylation modification. And what they have found is all the highly transcribed genes are enriched with the different histone acetylation modification, whereas the genes which are transcribed at low quantities lack histone acetylation in many different regions. So this is again put it in a global context that the presence of histone acetylation modification promotes the open chromatin structure, which in turn facilitate the expression of the genes. All right, so again, if you come to DNA methylation, and DNA methylation is also one of the major modification which promotes the heterochromatin structure. And the DNA methylation happens in mammals only in the CG dinucleotide context. Okay, so in plants, the CG can be methylated, and again, CNG can be methylated, and CNN can be methylated. But in mammals, this happens exclusively with the CG dinucleotide context, and the C is methylated at its 5' positions. And you have a methylated DNA in the adult differentiated tissue. So each time when a replication happens, means before the cell division, the replication proceeds in your S phase, right? And during this during the DNA replication, what happens is the methylated, here there are 4 CG sites are shown here, 1, 2, 3, and 4. Among these 4 CG sites, 3 CG sites are methylated, and there is 1 unmethylated CG site. Right. So during replication, you should copy the methylation pattern to the DNA. Right. So during methylation, after replication, the DNA becomes a state called as a hemimethylated state, wherein because the DNA undergoes a semi-conservative replication, one of the strands is world strand, which carries the methylation pattern, and the newly synthesized strand lacks this methylation pattern. Right. And this methylation newly synthesized strand, the methylation pattern is reintroduced by a special enzyme known as a maintenance methyltransferase, which we also call it as a DNMT1. The DNMT1 enzyme works like a photocopier machine. So whatever the methylation pattern which is present in the old strand is copied to the new strand. For example, if this CG is methylated, again, that will be methylated. If it is unmethylated, that will not be methylated by DNMT1. So DNMT1 is a maintenance methyltransferase which copies the methylation pattern from the old strand to new strand after each round of replication. Okay, so that's how you preserve the methylation pattern. And this methylation pattern is very important for the tissue identity. So if you take a hepatocyte or a myocyte, they are hepatocyte because of their transcriptome, because of their proteome, and their transcriptome is shaped by the chromatin organization, whatever present, and the chromatin organization is shaped by the PTMs and the histone tails and the DNA methylation patterns. So DNA methylation pattern is very, very essential to maintain the tissue specificity, right? So that is taken care. That's why you get when a hepatocyte divides, you get a hepatocyte because the methylation pattern is preserved by the maintenance methyltransferase enzyme. Right. So you this is a typical situation in the adult cell. So you have a DNA which is fully methylated. Then after a round of replication, it goes for a hemimethylated stage. Then you have a maintenance methyltransferase DNMT1, which brings back the hemimethylated state to the fully methylated state. But what happens during gametogenesis is when you form the gamete, which type of methylation pattern will you put it in the gamete? Whether we will put the methylation pattern which is present in the myocyte or neuronal cells, we cannot do this, right? So in general, what happens during gametogenesis, there is a global erasure of the methylation pattern. You completely remove all the methylation pattern during gametogenesis. Then the gametes do not have a methylation pattern. And when you form a zygote, then when you form an embryo, during embryogenesis, then the methylation pattern is recreated with the help of a de novo methyltransferases DNMT3, 3A, and DNMT3B. So this enzymes, so DNMT1 maintains the methylation patterns in the differentiated tissue, and DNMT3A and DNMT3B, which are de novo DNA methyltransferases, which are going to introduce the methylation pattern during embryogenesis, which helps in the differentiation of the different tissues. And in context of the gene expression regulation is there. If you have a methylation, the black dots represents a methylation, and the circles with the hole without black dot, which represents the unmethylated CG. So majority of the human genes are preceded by a CPG island in their promoters, and if these CPG islands are methylated, then it forms a heterochromatin structure in this promoter region, and there is no transcription is possible. So the presence of methylation at the promoter region, especially in the CPG islands, blocks the transcription of the downstream gene. And if there is no methylation, transcription is possible. Okay, so the presence of methylation blocks the transcription, but the absence of methylation do not say anything about it, because the absence of methylation does not guarantee for the transcription, because you need the transcription factors and RNA polymerase 2 pre-initiation complex, mediator complexes. Many things are required for the proper transcription to happen. Only thing is the absence of methylation says that there is no inhibition from the DNA methylation point of view. I think I'm running short of time. Okay, so maybe we will skip many of these things because I don't have a time. Only 4 minutes are left. This is not so good. Right. So then, before ending my talk, I would like to. This is a slide again showing that I told you about the H3K9 trimethylation marks the heterochromatin, right? So this is the experiment which proves that this trimethylation modification. What they have done is they fix the cells and look for the different modifications using a monoclonal antibodies which are specific for different modifications. And this is the DAPI staining. DAPI staining is shown in a green. DAPI, you know, it stains your nucleus if you add tons. But if you add a limited quantity of DAPI, which stains only the heterochromatins within the nucleus. Okay, so it does not bind to all the DNA. If you add ample amount of DAPI, it will bind the entire nucleus, including RNA. Okay, but if a limited quantity of DAPI has been added, that stains only the heterochromatin spots, and these are the heterochromatin spots. And if you see, there is a co-localization between the heterochromatin spots and the modification. What we found is the H3K9 trimethylation modification is perfectly co-localizes with the DAPI dense heterochromatin spots, suggesting that this is the mark which mediates the heterochromatin formation. And we also have a lot of other data to prove that how the K9 trimethylation modification converts the hue chromatin to heterochromatin. I think I cannot have the time to go through that. Maybe before ending the talk, I will tell you a small story, then we will end the talk. And this, you know, right? This is a honeybee, social insect. So there are 3 types of honeybees: drones, you know, queens, and worker bees. And for today's discussion, we will leave about the drones. We will focus only on the queens and worker bees. Okay, queen bee lives up to 4 years, whereas worker bee lives only 45 days. And queen bees are fertile, worker bees are sterile. Okay, so there is a huge difference. 45 days is the lifespan of a worker bee, 4 years is the lifespan of queen bee, and queen bee being fertile and the worker bee is sterile. And worker bee on top of this has to do all the donkey works, which is supposed to maintain the hive, bring the nectar, and so on and so forth. A lot of different works are assigned to worker bee, and they live only 45 days. But if you compare the genome of worker bee and queen bee, there is no difference. Absolutely no difference. The genome of worker bee and queen bee is exactly same. In fact, when a larvae hatches out from the egg, it is not decided whether it should become a queen bee or a worker bee. So the larvae which comes from the egg starts feeding a special type of food known as royal jelly. Okay, in fact, all the larvae feeds this royal jelly. Some of the larvae feeds this royal jelly very extensively, and those larvae which feeds this royal jelly very extensively will become a queen bees. Okay, and those larvae which eats less of royal jelly will become a worker bee. A small diet, a simple diet, which changes the bee as a worker bee or a queen bee, 45 days or a 4 years lifespan. There's a dramatic difference. Okay, and what people found is, then there is no difference in the genome. How does this worker bee as a worker bee and queen bee as a queen bee? And the difference lies in the epigenome. What they found is the presence of DNA methylation in the worker bee, which is largely absent in the queen bee. Okay, so there is a DNA methylation pattern which happens in this larvae that happens in a different manner between your worker bee and queen bee. There is an enzyme called the DNMT3, the one which we have seen, de novo DNA methyltransferase, which is also, we have a homolog in the human systems. Okay, so this DNMT3 enzyme, which is responsible for putting a methylation pattern in the worker bee, is inhibited in the queen bee. So the queen bee, if you take the genome and profile the methylation pattern, and worker bee, if you take the genome and profile the methylation pattern, worker bee has a lot of methylation pattern, whereas queen bee has a very less methylation pattern. The enzyme is present, DNMT3 is present here as well as here, but only thing is the DNMT3 is inhibited by the extensive intake of royal jelly. Perhaps royal jelly, they have some inhibitor which inhibits your DNMT3 enzyme, which blocks the methylation pattern. As a result, that it becomes a queen. And this is the experiment. This is a science paper. You can understand that this is in a control situation, a regular situation. Majority of the larvae develops into worker. Only very few larvae which develop into queen. But if you inhibit DNMT3. So this is a RNA. So if you add a siRNA, means it's a small chemical RNA which can knock down this DNMT3 enzyme. Then if you see, majority of the larvae which develops into queens, only very few larvae develop into workers. So this suggests that a small difference in diet, which makes a change in the epigenome pattern, not in a single base change in the genome, which brings about totally different phenotype from worker B to queen B. This happens through DNA methylation, totally epigenetic phenomena. Okay, so I think I will end my talk here because the time of the symbol is coming often. All right, if I have any questions, I'm happy to answer.
Thanks, Dr. Arun. As usual, you have explained in a very detailed mode. I hope our research scholars and the faculty members will benefit from your talk. The simple chemical reaction like acetylation and methylation as doing a great job. We know the basics, but you have explained in a very detailed manner so that each and every faculty member is able to understand in a clear way. So my question to you is that what are the major challenges in epigenetic studies to the development of biomarkers?
Development of biomarkers for different diseases?
Yeah, different diseases.
Okay. So this is,
basically I'm a biosensor lab. So I just asking whether this kind of studies can be for any kind of disease biomarker, we can able to develop those things.
Lot of biomarkers have been identified. The aberrant epigenetic signaling has been identified in a lot of diseases, starting from cancers, diabetes. Name a disease, you will find some apparent epigenetic signal, because majority of the cancers nowadays you don't find a mutations, only the epigenetic silencing. Many people do not have a P53 or KRAS mutation, but their expressions are either elevated or downregulated just by epigenetic mechanisms. And now we have a lot of enzymes. We identify several enzymes which does this modification in a different context. And if you inhibit this epigenetic enzymes not to do this modification, okay, then you don't silence the tumor suppressor gene, or you don't overexpress the oncogenes, for example. Okay, so this is like a balance. So this balance is created by this modification, and these modifications are introduced by these enzymes. But problem is, if some of these enzymes are misregulated, okay, so then you do the over modification, then you suppress the expression of tumor suppressor gene, or you do the less modification or wrong modification, then you bring about the expression of oncogenes. Okay, so then then the disease results in, or disorder results in, for instance. So these enzymes can be a potential target. So there is a drug therapy called epigenetic drug therapy. A lot of drugs are in clinical trials already, which targeting different DNA methyltransferase, histone deacylases, and histone lysine methyltransferases, PRMTs, protein arginine methyltransferases. Different epigenetic enzymes are hard target for the different disease therapies, right? So this is there. You can use this enzymes as a biomarker, but problem is many times these enzymes and marks are elevated for many different reasons, not only for the gene expression. So maybe we may not discriminate this modification. The aberrant modification is the cause or the consequence. Sometimes that confusion will come.
So what will be the practical difficulties will be faced by a researcher when during this process?
Difficulty is sometimes, if you want to do the chromatin modification profiling, you need quite a bit of tissues to do this. Okay, so many genetic studies you can do with PBMC blood cells, because the genome is same everywhere, right? But epigenome differs from tissues to tissues, right? So to collect the sample, tissue sample from a patient, you get it from cancerous patients, but for many other diseases it's difficult, right? So that's the problem. Because if you want to study the association of a polymorphism, for example, genetic mutations with any disease, it is easy because genome is same everywhere. You can collect the blood samples. It's like, very easy to get the samples, and you do the DNA sequencing, or you do the profiling of the particular SNPs, and you can correlate with the disease. It's very simple. But here, epigenome differs from tissues to tissues. I cannot take a blood samples to study a disease in a myocyte. That's not possible. That's the problem.
Okay. And you said
Limitation,
that
not a problem, limitation perhaps.
okay. And you have said that the factors affecting the epigenetics, no, like a royal jelly you have been talking about, which gives you the, I mean, the diet will plays an important role in methylation and the process.
Yes,
So
in
there are
bees,
several,
yes.
there are several environmental factors affecting, I mean, day to day, which is not present in earlier situation.
Yes.
So this contract the evolution, no, the does epigenetics contract the evolution?
No, it is on par with, in line with evolution.
In
Yes,
line
you
with
have to
evolution.
adapt it in line with evolution, of course. Because now one Nature neuroscience paper in which what they found is the pups, the pups which are delivered from the mice, which were some of the pups were allowed to stay with mother, some of the pups were separated from the mother. Okay, but otherwise they are providing nutrition, everything is same. Exactly same. Only the pups which stays with the mother gets all the hugging, grooming and licking, all this, warmth and all these things from the mother. That's the only portion which is missing in the pups. And if you see that behavioral pattern, that's completely different. And the pups which stays with mother is very, very responsive to the stress, and they are very resistant to the stress. And what they found is there is a lot of DNA methylation pattern changed in their glucocorticoid receptor promoter between these two muscles. Okay, two pups. So this means something like a touch and a hug. All these things can change something fundamentally in the chromatin modifications, which can have a phenotype. That's very interesting.
Okay. And in morning when I was been browsing, I found that it is a ghost in our gene. What is your comment on it?
The gene?
Yeah, ghost.
No idea. I'm sorry. No, I don't know in what context they are.
No, when I was just browsing the epigenetics, I found that this line, the epigenetics is a ghost in our gene.
Not a ghost, it is a adaptability of features. Okay, so it is adaptability. I would consider this as adaptable signals. Okay. So because for different situations you need a different proteins and different transcriptome, and this is possible by the plasticity of the epigenetic signaling. Okay, so you can introduce modification to silence something. Okay, so if the situation changes, you can bring back the same expression back. Okay. And this is the plasticity.
Yeah, and you have been related the aging with epigenetics. Whether this royal jelly can be given for our
yeah, no clinical trials, no studies on that. And people were trying to find even a factors which inhibits the DNMT3. I think there's still now no paper I found.
Okay.
No support, no literature support, no scientific support, no scientific support so far. But the calorie restriction, that process is known, very well studied, well documented.
But these royal jellies have been sold in China as well as in Korea.
Okay, no idea. Not properly supported by scientific literature.
Okay, I think there is one question from Dr. I. Ganesh.
Yes.
It was an informative talk. Thanks for it. Here, I would like to know the role and usage of highly condensed heterochromatin as it is not expressed like a euchromatin.
The role of heterochromatin is just puts the chromatin in a stable, because your genome is filled with a lot of transposons, retrotransposons. Okay, so if it is if the genome is not packed in the form of heterochromatin, what happens is transposons starts moving. Okay, so the transposons, in case if it hits an essential gene, then it is going to lead to a lethality. Okay, so heterochromatin is a way to put the chromatin in a silent state. Only it is converted to euchromatin if and when it is needed. Okay, so otherwise it should stay as a heterochromatic. Okay, so this is a situation. Even I told you during gametogenesis you have a global erasure of a DNA methylation pattern, right? That time the transposons starts moving. So the organism developed a specialized pathway called a piRNA mediated pathway. Have you heard about piRNA? piRNA is a special RNA which is expressed exclusively in germ cells, and they are supposed to silence the transposons, because the transposons starts moving in during gametogenesis, because there is no DNA methylation, there is no heterochromatin section. That's the problem, right? So the organism evolved for a different pathway to silence this. This provides the genomic stability. And if you put all the genome in a euchromatin states, most of the genes are expressing all the time, which you don't want. You want to regulate the expression because there are genes which need to be silent and should be expressed whenever it is needed. How do you do this? You have this chromatin arrangement.
I think Dr. Arun has answered for Dr. Ganesh. Is there any questions?
I think people are waiting for lunch.
Yeah, I think.
If any of the participants have questions, they can post them in the question box, and Dr. Arun Kumar would be very happy to answer your queries. So,
yes, of course.
So thank you very much, sir. We would like to honor you with a certificate and a memento.
Thank you.
We would also like to honor our chairperson for the day, Dr. S. Ravi Kumar.
Thank you, Aarti.
Thank you all. Thank you, sir, for the very interesting and insightful talk. So thank you for agreeing to be a part of BMSECON this year. And thank you very much, sir. We thank the chairperson.
Thank you for the invitation too. Yeah.
Thank you, Arun.
So we'll close the session for now. And the oral presentations and YRS presentations will take place shortly. So we have given you links in the groups. Please follow the links and join the correct groups. So the presentations will ensue from 2 p.m. onwards. Thank you. Will be started up. Oh, let's check whether all the.
Unmute, ma'am, please. Please unmute your mic.
Yes, sir. 1 minute, sir. 1 minute. We'll start, sir. We are just waiting for a judge to join. 1 minute. Dear delegates, just give us 2 more minutes. We are just waiting for one of the judges to join. So we'll start the presentations within 5 minutes. Please note, Dr. Revant will be presenting first because of a special request by the judge from physiology. Revant, please be ready. We are giving you off. Oh, it's by the Revant. Dr. Revant, are you there?
Yes, ma'am, I am there.
Okay, can you just check whether you have the privileges to share your screen?
Yes, ma'am.
You have. Okay, please wait. Please wait. Don't share your screen. We'll just let you know. We're waiting for one more judge to come. After I introduce the judges, you will be presenting first.
Sure, ma'am. Thank you, ma'am.
Okay, be ready. Yeah. Thank you. They will only, No, ma'am, you have to enter as a panelist, ma'am. That is the issue. You just, no, you ask him to put it in the panelist. You have to message Sudhir. 1 minute, ma'am. I'll add you in this thing, ma'am. 1 minute. Idile put up Sudhir, MNM Sudhir. Please add AIMS in the panelist. It's not going. Ma'am? Ma'am? Lakshmi madam, Sudhir sir, Sudhir.
Now I can see you. I don't know whether you can see me. Ames, it's coming as Ames.
Yes, ma'am, you are in panelist.
Okay, right.
Good afternoon.
The management physiology. Okay, just tell the names of the three. No. Good afternoon, everyone. We are about to start the YRS sessions for the faculty. I take the privilege in introducing our judges for the evaluation today. We have Dr. Vidya, CS with us, Professor of Anatomy, JSS Medical College. Dr. Arti Sood Mahajan, Professor and Head Physiology, MAMC New Delhi. And we have with us Colonel Dr. Mithu Banerjee, Professor and Head of the Department Biochemistry, AIMS Jodhpur. So before we start, there are a few points that I want to insist on to the participants. Please keep your introduction as brief as possible and adhere to the 7 minutes of presentation. 3 minutes will be given for discussions. Okay. And kindly mute when the other candidates are presenting. Thank you. Now we will begin with the first talk. We have Dr. Raymond. Sir, you can start sharing your slides. You have been made a panelist.
I've shared my slides. Is it visible?
Yes.
Can I start?
Yes, sir.
A very warm greetings to one and all out there. I am Dr. Revandar, Senior Resident from the Department of Physiology, All India Institute of Medical Sciences, New Delhi. Today I am here to present my research work titled Vasosensory Reflexes Elicited by Chemical Mediators of Inflammation in Anesthetized Rat Models. To begin with, what are these vasosensory reflexes? Let us consider a peripheral blood vessel with blood flowing in a particular direction. Now, whenever a nociceptive agent is instilled into the blood vessel, the algogen remains in a segment of peripheral artery and activates the perivascular sensory nerve endings. These perivascular afferents, once activated, carry the information of local tissue damage and inflammation to the pontomedullary centers of the brain, which modulate the cardiorespiratory parameters in a reflex fashion. Now, these reflex cardiorespiratory alterations elicited by the presence of nociceptive agent in a blood vessel are termed as vasosensory reflex responses. Now, the objectives of the present work was to study the nature of such vasosensory reflex responses elicited by intraarterial instillation of an inflammatory mediator, that is histamine, in urethane anesthetized rats. Further, the study was also aimed to delineate the afferents, efferents, and peripheral receptors that are mediating these responses. To do this, adult male albino rats were procured and they were anesthetized with an intraperitoneal injection of urethane. Under adequate anesthesia, first tracheostomy was made to reduce the respiratory distress to the animal. Then the area of right femoral artery was dissected to isolate the femoral artery from its surrounding structures. Once the femoral artery has been isolated, the artery was cannulated with a 24-gauge double-ported cannula, which was designed in our laboratory. Now, the speciality of this cannula is that it had two ports, a vertical and an horizontal port. Through the vertical port, we were able to instill the histamine into the femoral artery against the direction of blood flow. And through the horizontal port, we were used to record the blood pressure continuously. Now, this is the overall experimental setup showing the blood pressure recording here using the double-ported cannula. We recorded the ECG using the standard limb lead 2 configuration using needle electrodes, and the respiratory excursions were recorded using a force transducer connected to the chest wall. This method of retrograde cannulation of femoral artery, we were able to publish in the Elsevier journal Methods X for the first time. Now, coming to the results of the work, first, we needed to find out an optimal dose of histamine which could elicit the vasosensory reflex responses. So from preliminary experiment, we chose 3 doses, 1 millimolar, 10 and 100 millimolar. And it could be seen that histamine elicited vasosensory reflexes in a dose-dependent fashion. The vasosensory reflex were in such a way that there was transient immediate hypotension, bradycardia, tachypnea, and hyperventilation. Next, we decided to trace the pathways, the afferents and efferents, where they are located for these reflex responses. For this, in one group of rats, the experiment was repeated after vagal nerve sectioning, and in the other group after ipsilateral sciatic and femoral nerve sectioning. And it was seen that in both groups, the histamine-induced reflex responses were attenuated. With local lignocaine pretreatment also, the responses were attenuated, showing that the responses originated from the femoral vascular bed. This part of afferent tracing, we were able to publish in Springer Nature Journal of Scientific Reports with an impact factor of 4.4. Next, we tried to identify the peripheral receptors that could mediate these reflexes. For this, we chose 4 blockers, a capsaicin TRPV1 blocker, phenyramine, which is a histamine receptor blocker, ondansetron, which is a serotonin receptor blocker, and diclofenac, which is an inhibitor of endothelial cyclooxygenase. And it was seen that the histamine-induced responses were inhibited in all these groups, showing the role of TRPV1, histamine receptors, cyclooxygenase, and serotonin receptors in mediating these responses. This we were able to publish in the Bentham Sciences Journal recently. Next, we tried to explore the heart rate variability modulation by this histamine-induced responses. And we were able to observe that both the time domain as well as the frequency domain heart rate variability parameters were modulated by the histamine-induced vasosensory reflex responses. And these responses were significantly attenuated in the vagotomized groups, indicating the role of vagus nerves in producing these histamine-induced HRV modulations. This HRV modulations and its role in inflammation, we were able to publish in the Journal of Basic and Clinical Physiology and Pharmacology with an impact factor of 1.5. Lastly, we tried to extrapolate the results, whether it is true only for the chemical inflammatory mediators or is it true for the thermal nociception also. So for this, we repeated the experiment. Instead of histamine, here we used saline of different temperatures. And it was seen that both warm saline and cold saline produce similar nociceptive responses. And surprisingly, these responses were inhibited by TRPV1 blockers and histamine receptors, indicating a role of histamine and TRPV1 receptors in thermal nociception also, similar to that of the chemical nociceptive responses. Now, summarizing the results, whenever a chemical or a thermal stimuli is applied to a blood vessel, it produces reflex cardiorespiratory alterations, which are inhibited by vagotomy and sciatic nerve sectioning. And a group of blockers also attenuated these responses, indicating their roles in producing these reflex responses. These were the publications that we were able to get from this research work. Thank you for this wonderful opportunity.
Revan?
Yes, ma'am.
You're from which college?
I am from Banaras. I did my MD from Institute of Medical Sciences, Banaras Hindu University. Presently, I am working as a senior resident in All India Institute of Medical Sciences, New Delhi.
Okay, in the results part, you should emphasize on what your findings, like in statistical work, that you have to depict in the results.
Yes.
That is more important rather than introduction or anything.
Revant, I have a question for you.
Yes, ma'am.
Did this you use the blockers and you checked that they, what is the translational impact of this? How could this, what you have determined, how could this be translated into a bedside,
The study, the research work was aimed in understanding the role of peripheral blood vessel in cardiorespiratory disorders. Like when there is a vascular inflammation, say in acute vasculitis or a chronic vasculitis, or even diabetes, which affects the blood vessels, the peripheral blood vessels. So these, this present work, this vasosensory reflexes gives a novel insight how these changes in the peripheral vascular system affects the cardiorespiratory parameters. So in the HRV study, we also demonstrated that if we see the pattern of the parameters, there was an increase in the parasympathetic impact on the heart and a decrease in the sympathetic impact, as it was shown in the presentation. So this shows that in conditions of acute stress, acute inflammation, the parasympathetic impact on the heart is increased and the sympathetic impact is decreased. Thereby, it is having a protective role on the protective effect on the cardiovascular system.
So would you then, if this was to be translated into clinical practice, what would be the next experiment?
We should try with, because this dose of histamine and bradykinin that we used was comparatively high for human in vivo. So we plan to microdose it so that we could apply it to a patient settings.
Right. Thank you.
Thank you, ma'am.
If there are
sorry, ma'am, I can't hear you.
Ma'am, you have to kindly unmute, ma'am.
Now, can you hear me, Dr. Raven?
Hi, yes.
Okay. I also want to ask you, since you've just mentioned that the dose of histamine that you have used are in a higher concentration than what would be normally expected. Okay. Yes. And you have used a lot of blockers. First of all, your abstract, I think, did not mention your complete work that you did. You know, the abstract was less. You should have mentioned other things that you have done also. But you have spoken about them, but not mentioned them in your abstract. And nevertheless, you have done them and even published them. Now you tell me, how is it that your experiments, did you understand and think about the normal chemoreflexes that take place when any chemical for that matter enters the blood vessels? What is the normal chemoreflexes that take place? And how is it that your histamine produced, is it the response similar to the normal chemoreflex? Is it different? Is there a variation between the two? And is this variation related to the dose of histamine, or just it could be an experimental observation? No, I cannot see him.
Dr. Raven, are you here?
Thanks.
Dr. Raven?
I think he got disconnected.
Okay.
I think ma'am can put the question in the chat box and we can answer when he logs in. And can we move to second presentation?
Yeah, sure. Ma'am, we will forward your question to Dr. Raymond, ma'am. Okay. So we started with physiology. So we are moving with the next presenter in physiology. We have Dr. Rupesh.
Yes, ma'am. I'm here, ma'am. Dr. Sri Raman.
Good afternoon, ma'am. Am I audible?
Yes, sir.
Okay.
Now Dr. Rupesh is presenting. Dr. Srihari, you please be on hold. You can present next. Now let's continue with Dr. Rupesh.
Good afternoon, one and all. Now I'll be here presenting an abstract entitled "Does Administration of Psychological Questionnaires Induce Stress in Young Healthy Adolescents?" The work was carried out in AIIMS Mangalgiri. The current presentation will be taken care under these headings. To start with, stress can be defined as a discrepancy between the current or anticipated perceptions and the expectation perceptions of the individual, depending upon either internal or external environment. And it is very much important for the survival of an individual along with the animals. And in many studies, it has been noted that it is strongly related to diseases as well as disorders. A study conducted by Saho and Cass in 2010 has found that the prevalence of stress in the world is about 20%. It is expected to more by 2030 by 30%, which is a very alarming situation. And this flowchart explains that whether it could be either psychological stressor or physical stressor, there is a response from the body either through hypothalamus pituitary adrenal axis or the sympathetic adrenal axis. The mediators are released. The mediators could be CRH, ACTH, that is cortisol, catecholamines, and vasopressins, and many other. And they will bind to the specific receptors and to bring about adaptations, which could be either physiological or behavioral. With depending upon the time of exposure of these stress factors, either it could be a negative or it could be positive, that is eustress or distress. Coming to the stress markers, whether you can see the brain activity, which is related to these alterations in the emotional perception or changes in the higher cortical areas, that is prefrontal cortex or paraventricular nucleus and other areas. Also, we can go for those hormonal assay of these mediators, galvanic skin response, and as well as a heart rate variability. So, as we can go for the assessment of hormonal assay, that is the cortisol assessment. In the current study, we have chosen the salivary cortisol. Why is the salivary cortisol? It is a non-invasive procedure, stress-free and easy to collect, and it is directly proportional to the concentrations of serum cortisol. Generally, once the cortisol is released into the bloodstream, it takes almost three minutes to reach the saliva. And the cortisol which is present in the saliva is the unbound form of cortisol. It could not affect any higher mental function, that is cognition. As this adolescent period is a chaotic emotional period where we'll be searching for a purpose. And as the studies also mentioned that the people will in this age group will be in depressive, anxiety, and stress-related disorders. Because of these assessment of these questionnaires, which result in self-thinking, which could result in the emotional stress because of the bringing of the old autobiographical memories of an individual. So with this background, we try to assess the effect of psychological assessment on systemic stress by evaluating the salivary cortisol in young healthy adolescents. In the current study, we recruited 40 participants after obtaining the ethical clearance from the Institution Ethical Clearance Committee with the following inclusion and exclusion criteria. After the subjects were recruited, the procedure was explained, informed consent were taken, the first sample was collected, and questionnaires were administered, which includes WHO quality of life, Beck's depression inventory, perceived stress scale, as well as a mini mental state examination. Followed the administration of these questionnaires, after 5 minutes, we have collected the second sample. After the collection of samples, they were stored in -20 degrees centigrade, and centrifuge was done at 3000 RPM, and the standard protocol was followed as mentioned by the vendors. Based on the optical density value, the concentration of the cortisol in the samples were calculated and they were plotted. For the statistical analysis, SPSS 20 was used, pair test was used for the assessment of, that is the change in the cortisol levels from the pre and post assessment of the questionnaires. P-value less than 0.05 was taken as statistically significant. This table shows the socio-demographic data in which the mean age is like around 19.5 years, whereas the years of education for the participants is almost 14 years. Their scores of WHO quality of life, the various domains, mini mental state examination, perceived stress score, scale, as well as the Beck's depression inventory. The main part of the current study, that is like, is there any alteration in the cortisol levels? Yeah, in the current study, we could see that there is significant increase in the salivary cortisol level after the assessment through the questionnaires for depression, quality of life, anxiety, and stress in the study participants. This tells that the mini mental state examination scores were more than 27 in the population, which indicates that the cognition level is normal. That means there is no disturbances in their cognition performance. The Beck's depression inventory score says that there is no depression, whereas all the domains that we have tried to assess through the WHO quality of life questionnaire, that is physical health, psychological health, social relationships, and environment, they indicate that their quality of life is good, and perceived stress scale scores indicate low stress. So overall, we can say that the psychological questionnaire assessment indicate that the subjects are free from stress and depression. They lead a good quality of life. However, higher cortisol values are represented, which include the acute stress, leading to the emotional processing in the individual because of the one's self-awareness. How does this happen? So when we are thinking about ourselves, the questionnaires include like, what are you doing now? Do you have any past experience with any bad experiences like that? Or how was your life 1 month back? How is your physical health? What are your social relationships? How you are good with your family members? How you are good with your friends? How is your social life in the working environment? This makes us to think like what is happening with us. This increases the higher activity in the prefrontal cortex, increasing the activity in the emotional areas, that is amygdala. Apart from that, it could affect the autonomic nervous system by activating the sympathetic system. Depending upon the amount of stress that is taken by the individual, whether this stress can be either eustress or distress. So that's like in the introduction slide, I have told about the temporal factor. That is a duration of this exposure to these stress factors, either it can be converted into distress or eustress. Whereas in the current population, we could see that understanding or analysis of the self, that is about myself, the subjects they're thinking about themselves could lead to the mild stress as indicated by the increased levels of the cortisol. So from this, we can say that the psychological assessment through the questionnaires could induce the acute stress. So overall, we can summarize and conclude that the psychological questionnaire assessment lead to the self-thinking in various aspects, resulting in the activation of emotional cortical areas, and by activating the stress pathways, could be responsible for the stress acutely in the healthy young adults. So in the future, we would like to see that what are the cortical areas that is involved in these self-thinking during this questionnaire person per se actually, and also what could be the changes when we give the different types of questionnaires longitudinal after 2-3 months and 6 months and 1 year. Also, we would like to see that what are the changes of the physiological and behavioral adaptations in animal models. I would like to thank all these people for the smooth conduction of the study. This is a reference that is related to the particular current study, and thank you one and all.
Over to the judges for questions.
I think I'll start first, Dr. Rupesh.
Yes,
Did you have any control group for this?
Ma'am, we didn't have any control group because taken apparently healthy individuals only. Actually, we wanted to recently have come across a paper in that they are saying that the assessment of this depression, stress, and quality of life in young healthy adolescents is like must. So we thought of doing that. Apart from that, during that brainstorming session only, we got this like, what could this can induce some stress in them, because self-thinking and analysis could induce some mild stress in us. Like, am I going in the right way or not? Because recently this medical education is also recommending in order to assess these kind of stress, depression, and quality of life in even UG students in order to give them a better performance in the life. So
suppose, I mean, how do you say that it is just the questionnaire which is giving the stress? If you had included just a suggestion, a control group, giving them some other kind of activity, then you can probably say that, and suppose their stress level had not increased because of that activity, then you can say, so it could be answering these questionnaires, or it could be doing any kind of activity which is producing a stress in them, so how could you like compare?
Yeah, ma'am, I got it, ma'am. But in the current study, we don't have any control group, but it was already proven and stated that whenever a person is involved in some cognition task, like just the visual potential or like minor checkerboard task or like oddball paradigm, anything is like, it could induce mild stress in them. They could have that there is increased levels of cortisol, that is salivary cortisol, as well as the HRV parameters also. Like when we are involved in any task actively, there is always a change in this stress that induces stress. So we wanted to see that, because whenever we go for any evaluation for a patient, we start with questionnaires. What is their quality of life, stress, and because that itself might induce mild stress. That was our hypothesis actually.
Yeah.
So
life is a stress itself.
Yeah, ma'am. Yeah.
Yes.
The question is whether it is eustress or distress. That is the thing.
Yeah, I'm glad to see that your mean age was about 19. Because, these days what we've noticed is, you must have noticed, and that 18 is the cutoff for pediatrics. So we always advise everybody here to go a little beyond 18 when you are choosing your, otherwise you'll have to take consent from parents also, because now the pediatric age group is also kind of increased. So,
yes, ma'am, that's why in the inclusion criteria we have taken 18 to 30. Because
Yeah.
less than 80, we have to have the assent form for the pediatric population.
Yeah, and one more thing, that's
Yes,
my
ma'am.
last thing, then the other people can ask. Did you time the, how much time they took to answer the questionnaire, so that that could be one of the parameters? Suppose you're giving one questionnaire compared to 3 questionnaires together, does that have a effect on the stress level? Because the
Ma'am,
time.
that can be done, because in the current study, we didn't do that. Like questionnaire 2 and 3 and 4. But simultaneously, we have started and given like all the 4 questionnaires. It took almost 15 minutes. Done with the questionnaires, we have given 5 minutes of time. Then I have collected the second sample, because the cortisol, which is released in the blood serum, it has to the saliva also, right? So that's how we did. But this is a wonderful idea, ma'am. I think we can plan in future, like how the stress could be there for one questionnaire, 2, 3, and 4. We can see like, depending upon the duration of the stress exposure, whether it can alter the levels or not. Because that is initially I mentioned, like temporal factor. The exposure of the duration of the stress could direct it to like positive or negative, eustress or distress.
Okay, now I think the other judges can also ask you.
Thank you, ma'am.
One thing I wanted to suggest, you could have done pre-test and post-test, like before giving the questionnaire to the same patient and after giving questionnaire to the same patient, could have checked the levels of cortisol.
Yes, ma'am. We have checked pre and post, ma'am.
Yeah.
Pre, there is increase in cortisol levels post questionnaire assessment.
Post-test. Okay, fine.
Yes, ma'am. Yes, ma'am. The pre values are around 1.9, ma'am, whereas the post values are around 2.7.
Usually, mini-mental state examination will be doing for cognitive assessment of all the dementia cases.
Yes, ma'am. Because the more than 27, the score is more than 27 indicates that they are oriented to the place and time. I wanted to see that whether they are oriented to the place or not. Whereas with respect to depression, we have used Beck's depression inventory and stress with the perceived stress scale and quality of life, WHO quality of life breath questionnaire.
Okay, thank you.
Because we don't have any cognitive affection. Sorry, ma'am. Yes, ma'am.
I have one question, Dr. Rupesh. So in this 19-year-old age group, especially with graduates, MBBS graduates, there are a lot of smokers. Did you exclude the smokers? Because smoking as such can give rise to a raised cortisol. What was the inclusion and exclusion criteria?
Yes, ma'am. Ma'am, in the current study, we have made sure that the person who is non-alcoholic, they don't have any family history of.
You didn't mention that. That's a very important criteria that you should have mentioned. Which all subsets did you exclude? Because there are a lot of false positives for cortisol.
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Yeah. Secondly, the type of questionnaire that is being administered, that will also have a impact.
Yes, ma'am. Yeah. We have maintained.
In COVID, we've all been answering n number of questionnaires, some detailed, some not so detailed. So that itself, the quality of questionnaire will also determine what kind of stress it is inducing.
Ma'am, the study was conducted 1 month before in the campus itself with the various working population here, like DEOs and multitask staff and all. And we have recruited, and the test was done in the evening, ma'am, around 5:36 p.m. So as per the standard values, the value should be around like 0.6 to 2.5 nanograms per deciliter of saliva. So the p-value is around 1.9, which is in the limits of the prescribed standard values. Whereas the post is like the minimum value is like 2.8, and it went up to 6 nanograms per milliliter of deciliter of saliva. So which could indicate that considering all the patients were recruited at the same time and test was done at the same time, their baseline values are same, which is in the normal limits at the standard. But after doing the questionnaires, the values were increased.
And the good part is you did it in the evening because cortisol are the highest in early morning, between 4 to 6.
Yes, ma'am.
So that thing has been obviated because you've done the whole thing in the evening.
Yes, ma'am.
Right. Thank you from my side.
Thank you.
Thank you, ma'am. Thank you, sir. We'll now move on to the next presenter. We have Dr. Srihari. So you can start sharing your slides.
Okay. Can you see my presentation now?
It's actually blank.
No, blank slide. Yeah.
Yeah, yes, ma'am. Yeah, yes, ma'am. A very good afternoon to one and all present here. Recent lifestyle modifications have made the general population more prone for lifestyle diseases. And one such lifestyle disorder is prehypertension. And globally, studies have shown that the prevalence of prehypertension is increasing among adolescents than adults. But there is a dearth of study regarding its prevalence and effects. So the topic of my presentation is effect of prehypertension on cardiovascular health among school-going adolescents in Chennai. And myself, I'm Dr. Srihari, Assistant Professor in Physiology from Sri Ramachandra Medical College, Chennai. As per the Joint National Committee, prehypertension is defined as systolic blood pressure between 120 to 139 millimeter of mercury and or diastolic BP between 80 to 89 millimeter of mercury. And it has been identified as a leading potential and preventable cause of morbidity and mortality. Studies have also shown that adolescent prehypertension has very worse and detrimental effects than adult prehypertension. Prehypertension among adolescents has been found to be associated with very early left ventricular hypertrophy, left ventricular diastolic dysfunction, arterial stiffness, early occurrence of organ damage, endocrinal abnormalities such as increase in cortisol and thyroid hormone, decrease in growth hormone, insulin and serotonin, and also has been found to be associated with early development of metabolic disorders. Prevalence of hypertension has been found to be more among
Sir, just a moment, sir. Whoever has kept your speaker unmuted, kindly mute it. We're getting a lot of background noise. Thank you, sir. Please proceed.
Yes, ma'am. So the prevalence of prehypertension among adolescents has been found to be more throughout the world, but there is a dearth of studies regarding its effect. So the aim of my study is to study the effect of prehypertension on cardiovascular health among school-going adolescents in Chennai. The study is a cross-section study initiated after obtaining permission from the Institutional Ethics Committee. School-going adolescents between the age 15 to 19 were recruited, and the sample size was 664, consisting of 370 males and 294 females. Unwilling participants and participants of unwilling parents were excluded from the study. So what we did was, the Chennai city is divided into 3 zones: North Chennai, Central Chennai, and South Chennai. So we took the list of private schools from the website of Greater Chennai City Corporation, and using a random computer software, we chose one school randomly from each part of the Chennai. So we went to the school in person, we met the school authorities, we explained the protocol and benefits of the study, and after obtaining written permission from the school authorities, we initiated the study. So coming to the methodology, their basic demographic details and their anthropometric measures were obtained. BP was recorded using sphygmomanometer. The participants were asked to relax for a span of 10 minutes, and 3 readings of BP were taken with interval of 5 minutes, and the average was taken as the final BP. So coming to cardiovascular parameters, their autonomic function was assessed using heart rate variability. Their arterial health was assessed using pulse wave velocity, and their salivary cortisol was also measured. So this is the apparatus using which we measured their heart rate variability and pulse wave velocity. So it has ECG leads. It's a validated instrument devised by one of our professor, and it has ECG leads to record the HRV and pulse transducer to measure their pulse wave velocity. So HRV, we used it to measure their autonomic function. So the heart rate variability is recorded. The HRV, it has a parameter called as LF-HF ratio. So LF is an indicator of sympathetic activity, and HF is an indicator of parasympathetic activity. So as per the task force, if the LF-HF ratio is going to be less than 2, that means the person has good sympathovagal balance, indicating normal autonomic function. If the LF-HF ratio is going to be more than 2, it indicates autonomic imbalance. So HRV was used to measure their autonomic function, and pulse wave velocity refers to the velocity at which the pulse travels in an artery. So it was recorded using the apparatus, and normally the pulse velocity among adolescents should be less than 5.15 meter per second. And even their salivary cortisol was estimated, and their stress was assessed using perceived stress scale, and their sleep hygiene was assessed using Epworth Sleepiness Scale for children and adolescents. And the data was tabulated and analyzed using SPSS version 80. And coming to the results, in our study, 22.3% of the adolescents were found to be pre-hypertensive. So according to the previous studies have shown that prevalence of pre-hypertension is increasing among South Indian adolescents than other part of the country. And even our result is concurrent with the previous studies, which shows that prevalence of pre-hypertension is increasing among South Indian adolescents. And females were found to have more prehypertension than males, which could be due to the female sex hormone estrogen, which is associated with stress, anxiety, and depression. And adolescents by themselves, they have their own adolescent stressors, such as their academic stress, family and relationship factors, and our own Indian social culture factors. So all these could have been the cause for adolescent females having more prehypertension in our study. So coming to the association between prehypertension and cardiovascular parameters, prehypertensive adolescents were found to have increase in LFHF ratio, that is increase in HRV, indicating autonomic imbalance, and the p-value was significant. And they were found to have more amount of pulse velocity, indicating their arterial stiffness, more preponderance for arterial stiffness, and even their salivary cortisol level was found to be high, indicating increased amount of sympathetic activity, which shows that prehypertension has negative impact on cardiovascular health among adolescents in our study. So what could be the probable pathophysiology? Prehypertension makes an individual more prone for vascular endothelial injury and dysfunction, increase in sympathetic activity, and chronic low-grade sympathetic inflammation. So increase in sympathetic and low-grade systemic inflammation causes increase in HRV, indicating autonomic dysfunction. Increase in vascular endothelial injury and dysfunction increases the pulse wave velocity, leading to arterial stiffness, and increase in sympathetic activity and low-grade chronic systemic inflammation increases the cortisol level, leading to endocrine imbalance among adolescents in that study. And we also looked for their psychosocial performance, and prehypertensive adolescents were found to have increase in stress level, and they were also found to have poor sleep hygiene, and it was statistically significant. And also we found prehypertensive adolescents to have less academic performance, that is less marks and poor attendance, but it was not statistically significant. So what could be the mechanism? So prehypertension is associated with increase in pulse velocity, increase in HRV and cortisol. So increase in HRV and cortisol indicates increase in stress, and increase in cortisol level causes repeated stimulation of the reticular activating system, leading to sleep disturbances. And increase in stress and sleep disturbances would have reduced their academic performance. So prehypertension also has negative impact on psychosocial performance among adolescents. So in our current study, students identified with prehypertension were referred to adolescent clinic of Sri Ramachandra Hospital if their prehypertension was found because of their lifestyle modification. So the adolescent physicians, so they diagnosed them. They were
Dr.
referred for
Srihari,
counseling.
kindly
Yes, ma'am.
wind up as quickly as possible because
Yes, ma'am. Yes, ma'am. Yes, ma'am. So if their prehypertension was found because of some secondary etiology, they were referred to departments such as endocrinology, sleep medicine, psychiatry, and physiotherapy for their follow-up, and the follow-up is in progress. So in current study, the prevalence of prehypertension was found to be more among school-going adolescents in Chennai, and it has been also found to affect their cardiovascular and biopsychosocial health. Hence, early identification and management of prehypertension will help in improving the health status of adolescents, as they are the pillars of our country. I would like to thank my funding agency, Mamta Health Foundation, New Delhi, for funding my study. Thank you.
Over to the judges for questions.
Dr. Srihari, I have a question for you.
Yes.
That you proved that there is a chronic inflammatory state, and you did it with the help of cortisol. So if you have samples left, please also do high C-reactive protein, because that correlates directly with risk of coronary artery disease. In fact, that helps in stratification of coronary artery disease. So if you have still samples left, I would certainly tell you to get the high sensitive C-reactive protein done.
Okay, ma'am. Actually, C-reactive protein is also a part of our study, ma'am, and I am not included in this presentation because of time constraint. Yes, ma'am. In our major study, we have included C-reactive protein.
Not C-reactive protein. You should include the high sensitive C-reactive protein, because these are all pre-hypertensive.
Okay.
So unlike in a hypertensive, full-blown hypertensive, where you'll get very high C-reactive, but it'll be low. So your detection has to be able to pick up low levels.
Okay, ma'am. Okay.
Thank you.
Yes, ma'am.
Srihari?
Yes, ma'am.
Yeah, I would like to ask you, first of all, when you've put pre-hypertension or say, what classification you mentioned? Joint National Committee 2000? 2003. Are there more recent ones also there? I think 2008 also I have seen, no?
With the recent literature search, we were able to get only the 2003 one, ma'am.
Acha.
I think in the community textbook you would have cross-verified, I think, no?
Yes, ma'am. We actually verified from Park initially and also from the articles, then we took this one.
Acha. So because when you write the paper and all that, you see whether it is according to the most recent classification of that. And secondly, one thing, did you consider obesity as one of the factor? And so did you, was that a co-factor, confounding factor, something like that?
Yes, ma'am. Yes, ma'am. Yes, ma'am. We considered their BMI, their body weight, and even their family socioeconomic status, and even about their health status, their other substance abuse, all those things also were also included in the study.
Okay, so there was nothing related to BMI or obesity?
Yes, ma'am. Yes, ma'am. There was a direct relationship between obesity and development of prehypertension among adolescents, ma'am, especially among females.
Yeah, because you have mentioned that the incidence was higher in females. That's why I'm asking you.
Yes, ma'am.
And
Yes, ma'am. There was a
and especially this period of adolescence for the females is a, there is a drastic change in the body weight and all that compared to the males. And again, you've chosen 15 to 19. I would have preferred 15 to 18. So because then you are sure, I mean, you're clear cut. Otherwise, you are on the border of adult and because the definition of adult will begin from 19 onwards, 18 plus. Pediatrics has changed till 18 years now.
Okay, ma'am. But as per WHO definition, adolescence is the period between 10 to 19, ma'am. So
okay, 10 to 19.
Yes, ma'am. So what we did was we got around 12 students who were at the age of 18 and 2 at the age of 19, but they were in their plus 2. So we took on, that's why in the title I mentioned school going adolescents.
Yeah. And then you must have you are presenting a portion, you must have done other hormones and all also. You must have done.
We also did salivary amylase, ma'am, and even that was found to be more among the prehypertensive adolescents.
Okay. And what about did you consider estrogen or progesterone females and all that? Like, I don't know how big is the study and how much you're presenting here,
No, ma'am.
So,
We didn't include the female sex.
Okay, but did you relate it to their kind of menstrual cycle or something like that?
Yes, ma'am. Yes, ma'am. Even during recording HRV, we made sure they are not in their bleeding phase.
Okay.
Because bleeding phase doesn't have any direct relationship with HRV, but the pain it induces that will alter their sympathetic activity, so that may alter their HRV. So during that phase of menstrual cycle, we didn't include the female participants.
Okay, because even it's not only that phase, the secretory phase also there is kind of edema and that also influences the stress levels. Anyway,
but task force says that change, the minimal change of hormone that takes place during the other two phases will not affect the HRV value much, because as HRV is a power spectral analysis, so they say it will not affect much.
Okay. Thank you so much.
Thank you. Thank you so much.
Thank you, sir. Thank you, ma'am. We'll move on to the presentations from Anatomy Department. We have Dr. Praveen Kumar. So you have been made the panelist. You can start sharing your slides.
Is my screen visible?
Yes, sir.
Good afternoon, everyone. Myself, Dr. Praveen Kumar. I'm here to present my research topic on redefining the tail of pancreas based on the islet microarchitecture and inter-islet distance and immunohistochemical study. We all know pancreas is an exoendocrine organ in which islets are scattered throughout. In that, particularly the tail region, the islets are densely populated. This may be due to two theory. That is, one is the increase in size of islet. Another one is by increasing in the number of islets. But when we gone through the previous literature, we found out that the islet size is almost same, or the maximum islet dimension is kept within a limit from the smallest animal like mouse to the largest one, blue whale. Only the insulin secreting capacity is altered by changing the islet architecture. That is the microarchitecture, intermingled arrangement of alpha and beta cells. So the increase in islet size may not be the reason. So the increase in islet number is the reason, and many studies are supporting the same finding. And the tail, apart from having the more number of islet, the insulin secreting capacity of the tail region is also more because of this intermingled architecture. Despite its importance on the tail region, there are very few evidence which is available regarding the demarcation of tail region from the body. There are several guidelines which is dividing the tail region. So one such is, after dividing the neck region, that is by using the portal venous landmark, the remaining part of the pancreas is considered as a body and tail, out of which, as per the classical anatomical textbook description, the part of distal part of tail or the distal part of the pancreas, which is present within the fold of splenorenal ligament, is considered as a tail region. And many researchers who has worked on the histology of pancreas, they have considered two equal parts as a body and tail region. Okay, after dividing the head, the remaining part of the pancreas is divided into two equal parts as body and tail region. Let us consider this as an anatomical tail. Then the American Committee for Joint Committee for Cancer, they have divided the pancreas left to the aorta as a tail region for all the surgical purpose. Okay, so there are several demarcation which is given. So in our study, we want to determine the tail of the pancreas, which is almost related to the functional tail, because we are seeing the based on the islet density where it start rising or significantly different from the other part of the pancreas based on the inter-islet distance, that is a sign of crowding of islet, and endocrine area proportion, that is nothing but the increase in the islet and beta cell density by using the large scale computer assisted analysis. So we have collected 9 adult human pancreas from the Indian population. All are non-diabetic and without any previous illness, and the BMI range is within the normal limit. And the age group is between 30 to 40 years. Most of the case which we have taken is from the road traffic accident, so that there is no any chronic diseases which is altering the condition. Then based on the previous guidelines, we have divided the head by using portal vein as a landmark. Then the remaining part of the body and tail is divided into two equal halves as described by the previous studies. Then we also divided based on the American Joint Committee on Cancer surgical guidelines. We have divided the remaining part of the body, which is just left to the aorta, as a another segment. So the labeling has done like head, B1, B2, and T. So we will concentrate on B1, B2, and T, and where the islet density is started crowding first. Then after fixation, all the blocks, all the tissue were grossed by complete representative coronal and transverse section. Roughly around 40 tissue from each pancreas has been made. All are processed, embedded in paraffin block, and 4 micron section from each block has been taken and screened for autolytic changes. Then further, the immunohistochemical staining was done in the serial section by using anti-cyanotophasin and anti-insulin antibodies, which is specific to identify the islet and beta cell area. Then the whole slide image were captured and analyzed by using images software, and data were categorized into proximal part of body, B1, that is right to aorta, and distal part of the body, B2, which is left to aorta, and the tail region. So this is one representative block from single pancreas, which is stained by the anti-cyanotophasin antibody. So all the brown region represents the islet area. By using the images software, we have subtracted or extracted the tissue area and the DAP positive area. From that, by using formula, we have derived the total islet area and beta cell area respectively. Then apart from that, we have calculated the inter-islet distance. So that is the nearest islet distance in between the two nearest islets. And the results are islet and beta cell area progressively increasing from head to tail region. That is the expected finding. And apart from that, the inter-islet distance was significantly reduced in the tail region. Then when we see the B1 and B2 segment, there is a significant decrease in B2 when compared to the B1. And when we compare the B1, that is the distal part of the body, and the anatomical tail region, there is no significant difference in the inter-islet distance. So the crowding of islet, what we have seen is almost similar to the distal part of body, similar to the anatomical tail region. So we observed significant reduction in inter-islet distance in the part of pancreas distal to the aorta. There is no significant difference in the inter-islet distance between the distal part of the body and anatomical tail. That's suggesting the crowding of islet begins in the distal part of anatomical body, which may be the beginning of functional tail of the pancreas. So this understanding helps us to preserve the islet-rich part during surgery. Apart from that, nowadays the islet harvesting, everything is happening. So in all these procedure, we can able to select the islet-rich part for the islet harvesting also. So these are all my references. Thank you for the opportunity.
Over to the judges for questions.
Dr. Praveen, what was the sample size?
Sample size we have taken is 9, ma'am.
9.
Yes, ma'am. 9 adult human pancreas, ma'am. From each pancreas, roughly around 40 blocks will be coming. So 2 immunohistochemical staining we have done. And we have analyzed the whole slide image. So each image will be more than 1 GB like that. So the workload behind this will be the more, ma'am. In the previous study where they have done the large scale analysis of the human pancreas, almost 10 to 20 they have opted.
What is the inclusion and exclusion criteria for your study?
The inclusion criteria is the patient mainly from the road traffic accident without any history of diabetes and any previous history of other metabolic disorder. The autopsy should be done within 12 hours of death. So from there we have taken, and whenever we have seen some congenital anomaly like portal ulnar pancreas, we have seen those things are excluded, ma'am. Then after that also, we have screened the block with the H&E staining in the beginning so that we can exclude the autolytic changes. So this is the organ which goes for autolytic changes soon after death. So we have excluded those pancreases.
Okay, fine.
Okay, if there are no more questions, we'll move on to the next presenter. Thank you, sir. Thank you, ma'am.
Thank you.
We have Dr. A. Anbarasan. So you have been made a panelist. You can share your slides. Yes, sir.
A very pleasant good afternoon to respected judges and dear president. I am Dr. Anbarasan from CMC Vellore. Here I am presenting about the position of human fetal liver with special histochemicals and selective histochemical stain. The study was conducted in the AIIMS Bhubaneswar. The theme of the present study is when death become life, which we will discuss subsequently. So I will start with the day of discussion in the as a hepatic diverticulum, it goes cranially towards the septum transversum. This hepatic diverticulum contains the endodermal foregut cell. This endodermal cells become the hepatoblast. It is having clonogenic property with bipotential differentiation. So it becomes the hepatocyte and cholangiocyte. So the fetal liver is in transition from hematopoietic to metabolic organ with changes in the vascular system like hepatic artery and central vein changes, maturation of the hepatocyte, and the appearance of the drainage of the bile system. So this will be the essential for understanding the alternate source for liver transplantation and harvesting the hematopoietic stem cells from for various blood disorders and to know the mechanism of neonatal jaundice in the preterm baby. So the usage of multiple staining method in immunochemical method in the present study allows to document the appearance and the organization of fetal liver precisely. So the aim of our study is to provide detailed picture of liver incidences with special stain and with the help of immunohistochemical marker at various patients. So our study, cross-section study, we got the sample from aborted fetus, and the inclusive criteria includes spontaneously aborted stillborn fetuses. Exclusion criteria was gross or microscopically autolyzed, and the fetus with the GE anomaly excluded. The sample size was 20 fetal. And just change the hemotoxin, then we change this, use the special stain in the immunohistochemical marker. Then the image will be captured and analyzed with the help of images software. Then the data will be analyzed. So, and in the sample collection, we have made the sample to two groups. The group 1 contains 14 to 24 weeks, and the group 2 contains 20 to 43. So, after we just change the hemotoxin reaction, the good microstructure will be same with the 3 special stains like Mason cyclone to look for the portal tract and the vessel wall, reticulin stain for the reticulin fiber touching the space of the organ of the hepatic plate, and the periodic acid stain for glycogen deposit in the hepatocyte. And also we have done the immunohistochemical antibodies like CK8 antibody to look for the hepatocyte and bile duct, and CD34 antibody for the hematopoietic stem cell marker in the endothelial cells in the hepatic filtrate. So coming to the result, the hepatocyte organization, this showing the 14th week, the Mason cyclone stain shows the hepatocytes are arranged as a cluster, but in the 15th week, here the CK8 antibody shows the hepatocytes are arranged in 2 cell layers. So coming to the appearance of central vein, the central vein was observed in the 14th week, and it is immunopositive the CD34 antibody. The diameter of central vein was 225 micron, the first group, that is less than 46, and second group, the diameter was gradually decreases around 175 micron. The diameter will be measured with the help of images software. Next, we have observed the portal tide formation. On the 15th week, the structure in the portal tide was formed. It was immunopositive in the CD34 antibody. The Mason cyclone stain also clearly shows the structures of vein, the hepatic artery, and the bile duct. The bile duct was immunopositive in the CK8 antibody at the 19th week, and the reticulin fibers also noted around the portal tide. Coming to the appearance of sign set at the 15th week, here the Mason cyclone stain clearly shows that sign set that don't communicate with the central vein, and here the reticulin stain showing the reticulin fibers are present in the space of this, and the CD34 and the CK antibody shows there is immunonegative for the sign set, that is white in color. Coming to the hematopoietic blood, the 14th week of the Athenian stain and the Mason cyclone stain shows abundant hematopoiesis increases around 1.52% to 0.379%. So coming to the final result, the central vein hematopoiesis was observed at the 14th week. The sinusoid, hepatocytes, and the portal tide was observed in the 15th week. Bile duct was started appearing in the 17th week. So previous studies have documented the appearance of structures by using either special stain or with this histochemical marker. But in this present study, we have used both special stain and the actual stain. So in the portal tide and central vein was observed in the early week compared to the previous studies. And the previous one exception, and the hepatocyte organ was well organized in the 15th week, and it is somewhat later compared to the earlier studies. The hematopoiesis was similar in the previous studies, like peak at the 24th week, then it gradually decreases. And the sinusoid was more or less similar to the previous studies up to the 16th week. So the percentage of hematopoiesis was peaked at the 24th week. So during this period of gestation, fetal liver can be used as a source of transplantation for hematopoietic stem cells for various malignant and non-malignant blood disorders. So hepatocytes also will organize around fission film. So this timing will help to generate hepatocytes from human-induced pluripotent stem cells and human embryonic stem cells. So it will be used to treat the various hepatic disease and the hepatocyte transplantation. So in this study, we observed that hematopoiesis in the central vein was the diameter of central vein was increased in the first group, that is less than 24 weeks, then the lateral group. So it indicates central vein was draining the large group of blood volume during the hematopoiesis in the early age of the fetal liver. So one of the previous studies also showed that fetal liver graft tissue from the 16th week of gestation was used for transplantation in the adult axillary region, showing that the fetal tissue was pre-immune and hypoimmune nature. So the post-transplantation microscopic feature of the tissue show there was no sign of ischemic damage to the graft, and there was no feature of acute pathogen rejection. So the fetal tissue was superior to the adult tissue because of the rich source of primordial stem cells that could proliferate faster. So the level of histocompatibility and lesion with fetal tissue was increased. The graft. Hence, the aborted stillborn fetal liver tissue can be used for active adult liver transplantation it will meet the demand for organ availability in the proper timing for the liver histopathology. So the better understanding of the human fatty liver histopathology will help the future research activity in liver transplantation and hepatocyte transplantation. The source from the aborted or stillborn fetal liver during the post-ischemic time is contains the aborted pluripotent stem cells. These are the references. Thank you.
Thank you, sir. Over to the judges for questions.
Hello, sir. My question is, were the whatever the hematopoiesis or the developmental aspect was not revealed before, or any new invention by your study?
No, it is all already published in previous studies, but I have used the images of that how much percentage of hematopoiesis present in the early weeks and compared to the later weeks of this question. So in the early weeks, it is 1.5% percentage of hematopoiesis was present. In the later weeks, it is around 0.3% of hematopoiesis present.
No, I think it has been already published in the books, in the surgery books. Because the liver transplantation is now it is very vastly done even in the India, isn't it? So what is the novelty of your study?
No, because the both that is also immunohistochemistry, CK8 and CD34 to confirm that.
You're not clear. Can you repeat it? I'm not able to hear.
So used to some special thing along with the immunohistochemical strains like CK8 and CD34, we further confirm that success are present that particular timing.
Dr. Anbarasan, can you please keep your mic a little bit closer to your mouth so that we can understand better? Thank you.
What are you doing?
Yeah. Dr. Aarti, ma'am?
Just one thing, have you observed that your findings about the central vein slightly different from the other studies that you have seen? That was the finding, isn't it? 15 weeks?
No. Timing also changes with previous studies.
Yeah, no, but there was a difference between your, see, most of the things were similar, but I think the first parameters, the central vein, slightly different. You found that development taking place slightly earlier than the other studies that, so that is a very important thing that you must highlight while you publish this, because you see now you have to keep in mind what is the period of legally allowed abortions also, that, and if during that period this changes and growth is occurring in the liver of the aborted fetuses, so that is a positive finding of yours, which you should have highlighted more, that you can use that tissue for transplantation compared to, so there are more chances if abortion does occur at that age, that time, so you can use the tissue for transplantation. Did you consider that finding as an extrapolation of your study? Hello? Did you consider that?
Yes.
You understood?
Yes, understood.
And because now too they are talking about 24 weeks also, there was some Supreme Court ruling or something, the age of abortion has increased, so your finding, you can, when you start writing the paper, it has to have relevance, why you're doing this. And if your finding is different from other studies, then what is the importance that you found earlier development of the central vein compared to the other studies? So you should use that knowledge which you have gathered from your observations.
Okay. Thank you, ma'am. Thank you, sir. We'll now move on to the next presenter. We have Dr. Mahi Nazir. Ma'am, you have been made panelist. Kindly share your slides. The slides are visible.
Good afternoon, everyone. I'm Dr. Mahi Nazir, demonstrator anatomy from GMC Srinagar. Today, my topic of paper presentation is CT-based study of deviated nasal septum and anatomical study. I'll be presenting my paper under these outlines: introduction, why this study, aims and objectives, material and methods, results, and conclusion. Coming to the introduction, the nose is the part.
Mahi, make it as a slideshow.
Okay, ma'am. Is it clear now?
Please click on the slide viewer.
Ma'am, is it clear now?
Slideshow.
Ma'am, it's on the slideshow only.
Isn't, you see the lower end, there are 3 dots here. And just before that 85%, there's a slideshow wala. Press that.
Ma'am, just a second.
Right side lower bottom.
Right side lower bottom. हाँ, आपका 85% आ रहा है उससे लेफ्ट साइड पे स्लाइड शो का. हाँ, इससे थोड़ा लेफ्ट देखिए, ये स्लाइड शो का बटन.
Yeah, that's the icon, the third icon.
हाँ, थर्ड को click करो.
ठीक है मैम, it's going back on.
मैम नहीं तो आप टॉप पे देख सकते हैं, तो होम आएगा, इंसर्ट आएगा, डिजाइन, एनिमेशन, स्लाइड शो. वो स्लाइड शो पे फ्रॉम बिगिनिंग.
Ma'am, just a second. Ma'am, it's going back by itself. Just.
Ma'am, you have use rehearse timings. Please remove that use rehearse timings. Then it will come properly, ma'am.
Ma'am, it's already on slideshow on my screen.
Ma'am, could you please close the screen and restart sharing?
Okay, ma'am. Okay, sir, just a second. So is it visible now?
Ma'am, please continue, ma'am.
Ma'am, is it visible?
Yeah, it's visible, ma'am. Continue.
But it is not in slideshow.
So, I'll be presenting my, coming to the introduction. The nose is the part of the face which enhances beauty. The perfect nose is considered with appropriate size and dimension. The face loses its beauty if the balanced nose is not in harmony with the other components of the face. The nasal septum comprises of bony cartilage that separates the nasal cavity into right and left sides. Small amount of deviation is present in most of the cases. The ideal nasal septum is one which is straight and at the center of the nasal cavity. This type of nasal septum is difficult to find. So the nasal septum, it's formed of septal cartilage, vertical plate of the ethmoid bone, and vomer. The nasal septum or deviated nasal septum is a physical disorder of the nose involving a displacement or deflection of the nasal septum. Some degree of displacement is common, affecting 80% of the people unknowingly.
Slides are not moving.
Ma'am, but
slides are not moving. We are just in the first slide itself.
Dr. Mahin, could you?
Yes, sir.
Could you please go to the up top? Can you see the slideshow on the top? Please click that. Yes.
Sir, on the
next to the animation,
top,
slideshow.
Sir, wait a
Next to
second.
the animation. Next to the animation, please. Yes.
Sir, wait. Yes, sir.
Please click that. There is used rehearse timings. Please unclick that. You have selected that. Yes. Use the rehearse timing. Yes. Please unselect it.
Okay, sir.
Yes.
Sir,
now can you click it from beginning? On the left, it is there from beginning. In the slideshow, can you see that the first icon of slideshow is from beginning? On the top, can you see from current slide from beginning?
From beginning, yes, sir. I
Yes,
can
yes.
see.
Please click from that.
So is it visible now? Can you
Ma'am,
see?
it is not visible. When you're reading, can you please move to that each slide? You can remove from the slideshow. Please move the next slide when you are reading that particular slide.
So
ma'am.
like this, can you see this slide?
Yes, yes, like that we can see. So
Okay,
when you're
sir.
reading
Okay,
that
sir.
slide,
Okay.
please click on that slide. Thank you.
Okay, sir. So I'll be going on with slide now. The slide which I was reading.
Yes, yes.
Okay. So the nasal septum comprises of the bony cartilage that separates the nasal cavity into right and left sides. Small amount of deviation is present in most of the cases. The ideal nasal septum is one which is straight and at the center of the nasal cavity. This type of nasal septum is difficult to find. So the septum is made up of septal cartilage, vertical plate of the ethmoid bone, and vomer. Nasal septum deviation or deviated nasal septum is a physical disorder of the nose involving a displacement or deflection of the nasal septum. Some degree of displacement is common, affecting 80% of the people unknowingly. Incidence. DNS can involve any age and sex. Males are affected more than females. 80% of all nasal septum are off-center or generally not noticed. Etiology. It can be due to trauma, developmental, as in birth molding, high arched palate, unequal growth between skull base and palate, mass in opposite nasal cavity, racial factors, and hereditary. The clinical features include nasal obstruction, headache, sinusitis, epistaxis, external deformity, and middle ear infections. These are the type of the deviated nasal septum which we encounter usually. Why this study? The nasal septum plays an important role in both the appearance and function of the nose. Deviation of the nose is common and correction requires a focused anatomically based treatment. Reconstruction and support of the septum is a necessary component to a straight nose. The nasal septum may cause dysfunction and cosmetic deformity, potentially having an impact on many functions of the nasal cavity. The aims and objectives were to look for normal bony structural variations in nasal septum on CT scan in patients attending tertiary care hospital. The material and methods were that it was an observational cross-sectional study conducted in postgraduate Department of Anatomy in collaboration with Department of Radiodiagnosis and Imaging of GMC Srinagar for a period of 1 year. A total of 200 eligible subjects of age 20 years and above were included in the study. Informed and written consent was taken from all the subjects. A brief history and physical examination was done to exclude various pathological conditions. The Siemens Emotion 16 slice multi-detector spiral CT scan was used for scanning. Data was acquired in axial plane. Inclusion criteria. The in and out patients of either sex who after routine clinical evaluation were to undergo CT nose and PNS, whose CT was labeled as normal by an experienced radiologist. Exclusion criteria. Age below 20 years, any pathology distorting normal anatomy in nasal region, any history of trauma in nasal region, any history of previous surgery in nasal region. This is the CT image showing a deviated nasal septum. Here we can see the septum is deviated to the right side. Results. In our study of 200 cases, 60% of the cases were males and 40% of the cases were females. 63% of the cases had bony DNS, 1.5% of the cases had cartilaginous DNS, 20% of the cases had both bony and cartilaginous DNS, and no bony or cartilaginous DNS were present in 15.5% of the cases. The 47.93% of the cases had right-sided deviation, 43.79% of the cases had left-sided deviation, 1.18% of the cases had right to left-sided deviation, and 7.10% of the cases had bilateral deviation. Conclusion. The goal of this study was to gather this knowledge in an effort to reduce the rate of complications in endoscopic sinus surgeries. References, thank you.
Was this your thesis topic?
Yes, ma'am. It was no, ma'am. It was not my thesis topic. It was basically I had conducted this study for a period of 1 year, as as I had my friend in ENT department ENT department. So we kind of I collaborated with her. So we conducted the study for a period of 1 year.
But what is the novelty of your study?
And basically in Kashmiri population, we have more of this respiratory ailments, like respiratory, there is more of the respiratory problems here. And here almost 80% of the people, they suffer from this DNS with symptoms or without symptoms, mostly without symptoms. So it is because of this DNS, deviated nasal septum, that the respiratory ailments are more common. So our study was just to find the normal nomograms, like ma'am, the normal, whether it is of right or left-sided deviation, and also which gender is affected more, whether males are affected more or females are affected more. So for this, just for the respiratory ailments, we did the study so that we come to know the conclusion.
What is the incidence of DNS in Indian population?
In Indian population, it is about 60 to 70%. It's more in Kashmiri population. Our study was more, but in the data, whatever data we found, it was about 60 to 70%.
Any intervention was advised for your patients?
Ma'am, it was just a normal study, just to see the septal deviation, bony deviation or the cartilaginous deviation. So all the patients who had any pathology, they were excluded from the study. It was just the normal CT imaging was done. For those who were referred to this department for the CT nose and paranasal sinuses.
Okay, Maheen, can I ask you one thing?
Yes,
you said referred. Why were they referred if they were normal? That is one question.
They had any other nasal pathology, any for like as in ma'am, they were referred from the neurology department. They were referred from the they had migraine or somewhere referred from the medicine department, like as in case of migraines and all. So due to the neurological problems, they were referred for the CT nose and paranasal sinuses. Only those CTs were included in our study who were labeled as normal by an experienced radiologist.
So CT was normal, and so
yes,
you did the DNA.
Yes,
then you looked for nose and paranasal.
Yes, ma'am. We looked for the nose, basically at the this septum.
You did you obtain ethical clearance for your study?
Yes, ma'am. It was ethical. It was cleared by an ethical committee, which was conducted by the James Srinagar.
Because multi-slice CT you are doing,
yes,
no? For them.
Multi-slice 16 Siemens emulsion slice. We used that detector.
Yeah. So, how does that change the treatment profile now? What your study has found? Does it change anything for the ENT surgeon or otherwise?
Yes, ma'am. Now for this. For operative planning, identification of DNS is important. Even though nasal anatomy varies significantly from patient to patient, there are some specific variations that occur repeatedly within the population, as in we are talking about here Kashmiri population. It is to be pertinent for the surgeon to be aware of these variations, especially if the patient has to undergo surgeries like functional endoscopic FES, functional endoscopic sinus surgeries, so he knows like if it is bony or cartilaginous, whether it is right or left. So he knows the space he has to operate on.
Okay, thank you, Ms. Maheen.
Thank you, ma'am.
Thank you, Dr. Maheen. Thank you, judges. We'll move on to the presentations from biochemistry. We have with us Dr. Sachin Dominic. So you can start sharing your slides.
ಇದು ವೈಆರ್ಎಸ್ ಮುಂದೆ ಡಿಪಾರ್ಟ್ಮೆಂಟ್ ವೈಆರ್ಎಸ್
sir, you have a login with two device.
Yes, yes. Actually, my laptop, it doesn't have the mic option.
Sir, then there is a sound issue. Then please log out from one device.
You're not audible, sir. Please unmute.
Exactly because of the Dell. Actually,
I would like to, I mean, can everybody hear?
Yes, ma'am.
Yes, ma'am, you are
Yeah.
audible, ma'am.
No, I mean, Dr. Sachin, can we hear him?
Sir, unmute me, please. Yeah. Sir, your mic is not working, sir. Sir, your mic is not working.
Dr. Sachin, we are not able to hear you. Can you please sort out this issue while we move on to the next presenter? Please sort out this issue. We'll go to the next presenter. We'll be back. Dr. Yuvraj, sir, are you ready? You can start sharing your slides.
Ma'am, can you hear me?
Yes, we can.
Ma'am, I'm ready, ma'am. Can I start my presentation?
Yeah, please.
Please
Yeah.
start your camera, please. Your camera is off.
Dr. Yuvraj, your camera is off. Kindly turn it on.
Now? Now? One second. Is it on now?
Yes, yes. Continue.
Yeah. Is it like a slideshow or it is showing
Yuvraj,
like a
share
slideshow?
your screen. Dr. Yuvraj, share your screen. Then you can start your PowerPoint presentation.
Yeah. Yeah, one second. Is it fine now?
Please proceed, sir.
Yeah. Good afternoon, one and all. Today, I'm going to present an important topic for the community. The title of my presentation is Association of Vitamin D Levels with Disease Severity in Newly Diagnosed Pulmonary Tuberculosis Patients. NTEP, National Tuberculosis Eradication Program, sets a target. By 2025, it has to eliminate tuberculosis. We all know that India has the highest incidence of TB, 26 lakhs, but out of which 10% is multi-drug resistant tuberculosis, which is quite high. So we need a biomarker to predict the outcome, whether it is successful or unsuccessful, so that to manage them appropriately. And also we need to find out newer therapeutic or neoadjuvant agent to combat such tuberculosis. Vitamin D, we all know vitamin D is having diverse effects in the body. Recently, its immunomodulatory property of vitamin D is gaining importance. Several studies have indicated vitamin D levels are lower in tuberculosis patients. So the aim of the study is to study the alteration in 25 hydroxy vitamin D levels in newly diagnosed sputum smear positive pulmonary tuberculosis. So the objective of my study is to assay serum 25-hydroxy vitamin D levels in newly diagnosed sputum smear positive pulmonary tuberculosis patient, and to compare with agent 6-match healthy controls, association of serum vitamin D levels with different grades of sputum smear positivity. This study was approved by JIPMER Institute Ethics Committee. All subjects who are registered under NICSHI portal were recruited from pulmonary medicine as well as medicine OPDs. The subjects were recruited into study groups based on the inclusion and exclusion criteria. Written informed consent were obtained from everyone. So the inclusion criteria for the case is newly diagnosed sputum smear positive pulmonary tuberculosis patient. So the case definition, new case, the patient who have never received treatment for pulmonary tuberculosis or have received anti-TB treatment for less than 1 month. For control agent, sex matched apparently healthy subjects. These are my exclusion criteria. That is extrapulmonary tuberculosis, alcoholism, smoking, malabsorption, liver and renal disorders, the drugs which can alter vitamin D levels, HIV infection, diabetes, immunosuppressive treatment, severe protein energy malnutrition. These are the parameters studied. Serum vitamin D by ELISA, IPTH by chemiluminescence method, serum calcium, phosphorus, glucose, total protein, bilirubin, AST/ALT and creatinine by auto analyzer AU400. Statistical analysis, sample size was estimated with the expected difference in vitamin D deficiency between healthy population and the tuberculosis patient as 20% with 5% level of significance and 90% power. Using the statistical formula, the sample size required for the study is estimated to be 65. The statistical analysis were performed using SPSS program. Normally distributed data were described as mean plus or minus standard deviation. Normally distributed continuous data were compared by independent student t-test. Normally distributed continuous data for sputum grading were compared by ANOVA. The association between vitamin D levels and sputum grading were analyzed by Pearson correlation test. P-value less than 0.05 was considered statistically significant. Coming to the results, this table shows the comparison of biochemical parameters between the control and the cases. Vitamin D, we can see, though it is less both in cases and control, it is not significant when compared. Whereas IPTH, we got significant because of dysregulation in calcium and phosphorus metabolism. These levels are significant. This is the table showing comparison of age and biochemical parameters among the sputum, different sputum grading, grade 1, 2, 3. Here we found significant difference in vitamin D. That means as the grade increases, that is infectivity increases, vitamin D level decreases. So we can see as the grade increases from 1 to 3, vitamin D level were drastically reduced to 13.1. We did Pearson correlation coefficient. We found significant negative correlation between vitamin D and sputum AFB positivity with R value of -0.34. Discussion. In this study, we found overall lower vitamin D levels both in cases and control, which is consistent with previous several studies. There is no statistically difference in vitamin D levels between tuberculosis patient and healthy controls, whereas significant difference was found in among the different grades of tuberculosis. There is significant difference in IPTH, which can be explained by dysregulated calcium and phosphorus levels. The inverse relation between vitamin D and the severity of tuberculosis indicates vitamin D reduces the severity of tuberculosis. The studies have confirmed vitamin D induces
So kindly wind
antimicrobial.
up quickly as we are running short of time.
Vitamin D induces antimicrobial peptide synthesis, which may be the reason for the inverse relationship. So, to conclude, 25-hydroxy-vitamin D levels are decreased in tuberculosis patient, and vitamin D level decreases with increasing in sputum grade. So we published this study in Tuberculosis and Respiratory Disease Journal. So antimicrobial peptide, we found vitamin D induces serum cathelicidin. So now association of serum cathelicidin with the treatment outcome in newly diagnosed tuberculosis patient. This I have put as intramural project in AIMS Hyderabad, and it got sanctioned with 3.6 lakhs with the motto to end the TB by 2025.
Okay.
These
Thank
are
you,
my
sir.
references.
Over to the judges for questions.
I think you said, Yuvraj, that the vitamin D levels were not significantly different.
Yes, ma'am, it was not significantly difference between cases and controls. Whereas if you take in case with the sputum grading 1 + 2 + 3+, it is significantly difference among the different grades.
Yeah, but
which
in
is
your
directly proportional to the infectivity.
Okay, so more infective it is, the lower vitamin D is. Okay.
Yes, ma'am. Yes, ma'am. Inverse relation.
Right. But between cases and control, there was no difference.
Yeah.
There is no difference.
Yeah.
Okay, so do you you know vitamin D? If we see all the research, everywhere they say it's less.
Yes.
So even in your controls.
Yeah, ma'am. It is less.
How did you? What is the data that you took to even say that this is the normal level? Did you take Indian population data or did you take a Western population data?
Yes, ma'am. Ma'am, actually, vitamin D, the normal level for Indian population, we have to define it. Till now, we are following only the abroad, whatever they are telling. And there is no definite cutoff for Indian population. In the ELISA kit, whatever kit pamphlet, they will tell this is the normal level. I am following that only. So if we have our own criteria, it will be, yeah, I think it is the time we have to define.
Yes. And in fact, there were 1 or 2 studies, don't remember the authors as so, but 1 or 2 studies have been published in India. But of course, the sample size is not so significant so as to come into the national data.
Yes,
but
yes. Yeah, that is the problem.
Yeah. But nevertheless, it is published. 1 or 2 studies are there. So in future, whenever you are coming to a conclusion,
Yes,
you please
sure,
reference to, because ideally speaking, we are all deficient in vitamin D.
Yeah, ma'am. Yeah.
Yes. Yeah. So, but one more thing is that if you think later on of giving a replacement and seeing whether the patients of tuberculosis can show further or faster improvement.
Yes, ma'am.
Yeah. Thank you.
Thank you.
I have a question for you. In your exclusion criteria, did you exclude patients with malnutrition or cachexia? Because most TB patients have cachexia or their BMI is very low. So what was the status of the BMI? most of them with multivitamin deficiencies, because first their economic strata is low. So it's not just vitamin D. So what was the status in your inclusion criteria or exclusion criteria? Have you looked for this confounder?
Ma'am, I don't know whether I can show my slide, but yeah, ma'am, we in exclusion criteria, we have excluded the patients with low BMI. And I don't know how to go back to the slide.
So since you have excluded patients with low BMI, that is probably the reason there is no significant difference between cases and controls. If you had included patients with low BMI, you would have got a significant difference, because the deficiency in those with low BMI will be more pronounced.
Yes, ma'am. Exclusion, yeah, here malabsorption. We can see.
Not malabsorption.
Can you able to see, ma'am?
No, we are not able to see.
Oh, share. I will share the screen now. Yes, ma'am.
You can just read out, no problem.
A malabsorption is one of the exclusion criteria we kept.
Yeah.
Yeah, ma'am.
And I can also see that there is severe protein energy malnutrition is also there.
Yes, ma'am.
Included. If these people would have been included, you would have got a significant difference.
Yeah, ma'am, we can
In
get
these people, but then again, this would be a confounder. Whether it is to be attributed to the pathology or not, that would not be very, very clear.
Yeah.
Extra pulmonary tuberculosis. Why did you exclude extra pulmonary tuberculosis? Even in extra pulmonary tuberculosis, the immunology of vitamin D interface with MTB would be similar. So what was of extra pulmonary? In fact, you would have got a richer data set.
Yes, ma'am. Extra pulmonary tuberculosis, the problem is that pulmonary tuberculosis patient within 1 month, we can able to get the number of us we needed. But extra pulmonary, I don't think I can able to get it. So we have not included.
No, so you don't have to exclude them. You don't have to exclude them. Whatever is coming your way, you take them. Be it TB meningitis, be it pleural effusion, be it intestinal tuberculosis, you just include them. You don't have to exclude them, right? The vitamin D and its interface with MTB will remain similar in extra versus compared to pulmonary tuberculosis. There is no requirement. Also, remember that when you are, if suppose in your study you are showing that it is very significantly related to the severity of TB, right? When there is plus, it is very low. If you think of supplementation at a later date, do remember that vitamin D can lead to toxicity. So so that needs to be studied, and there are a lot of studies which have correlated certain polymorphisms with vitamin D levels.
Yes, ma'am.
Which lead to increase in absorption of vitamin D. So those would be cases which should be high risk for vitamin D supplementation. You cannot give them vitamin D because they will go into toxicity. So that has to be kept in mind.
Ma'am, the future of my study is like, I want to show vitamin D is less. The pathogenesis behind vitamin D relating with the disease severity may be because of vitamin D induces antimicrobial peptide. So recently I found the antimicrobial peptide is cathelicidin, serum cathelicidin.
It is studied. It's a well-known fact. It's been published, cathelicidin.
Yeah, ma'am. Now in AIIMS Hyderabad, I have proposed that study and it got sanctioned also. So almost 80% is over. So I will, with that result, we can go for either peptide or proteins to combat the tuberculosis.
Right. No, so what I was saying that you should know based on polymorphisms in which
Yes,
patient
ma'am. Yeah, yeah.
vitamin D, that's at a later stage. And in
Yes, ma'am.
not to give vitamin D.
Yeah,
Right?
ma'am. Yeah, ma'am. Yeah.
That has to be kept in mind whenever public health strategy of supplementation, if and when that does happen. Because there are certain people in whom it will be high, certain people it will not be so high, right?
Yes, ma'am. Yes, ma'am.
Patients, you've got this project and I hope you will get good outcomes.
Okay, thank you, ma'am. Thank you.
Are there any more questions from judges? Okay. Vidya ma'am, would you like to ask him questions? Okay. Thank you, sir. We'll move on to the next presenter. We are now moving back to Dr. Sachin.
Am I audible?
Yes, sir.
And is it visible, my PPT?
Yeah, your presentation is visible.
Okay. So shall I start?
Yes, sir.
Yeah. Good afternoon, everyone. So the title of my study is Role of NT-proBNP, hsCRP, and ferritin in predicting the functional outcome in stroke patients. There's some issue with the sharing. Some other participating is sharing it. Since. Hello.
Okay, we can see it.
No, but I'm not able to. Okay.
So we are sharing for you.
Okay. Okay. Next slide, please.
We are moving. Yeah, please intimate
Okay.
us.
So cerebrovascular accident or stroke is the third leading cause of death and is one of the most common preventable life-threatening neurological problems worldwide. It is associated with significant severe functional impairment and grave disabilities. Hence, early identification of stroke patients during the window period is important so that survivors who are at high risk for poor outcomes could potentially benefit from more aggressive therapies and rehabilitation. Next slide, please. Yeah. The aim of my study was to investigate the association of serum NT-proBNP, hsCRP, and ferritin concentrations with stroke severity as well as functional outcomes at discharge in acute ischemic and hemorrhagic stroke patients. Next slide, please. Okay. The study was conducted in the departments with the combined efforts of departments of neurology and biochemistry in NIMS Hyderabad, and it was approved by the Institutional Ethics Committee. It is an observational case control study wherein we included 30 patients who had been diagnosed with stroke, who had presented with stroke with symptoms in the first 48 hours of onset. And we also included 30 age and gender matched controls. The exclusion criteria was that patients who had severe neurological impairment, which rendered them incapable of comprehending the study procedures, were excluded. And those who had concomitant somatic or psychiatric disorders were also excluded, and those who were pregnant or lactating. Next slide, please. Okay. Once admitted, the patients underwent a clinical assessment by the neurologist and imaging either in the form of non-contrast CT scan or MRI brain with laboratory studies. Proper history was obtained regarding all the risk factors, past history of both cardiovascular as well as neurological disorders, and the functional status before the onset of stroke using a scale called as modified Rankin scale. Now, the feature of this particular scale is that greater scores indicate a greater disability. Then blood samples were drawn, and it was serum concentrations of NT-proBNP was assessed using ECLIA method, ferritin and hsCRP using immunoturbidimetry. All the study patients were evaluated by a neurologist for the severity of the stroke symptoms using another scale called as Scandinavian stroke scale. The feature about this particular scale is lower scores indicate a greater clinical severity. And the patients were treated in the ward, and at discharge, again, the patients were evaluated for their functional outcomes using the modified Rankin scale. Next slide, please. Yeah. Coming to the results. So this table is showing the baseline characteristics. The cases were divided out of two types. One is we took ischemic stroke 15 cases and hemorrhagic stroke 15, and there were 30 controls. This is the gender and age-wise distribution, and what we found was that there was no significant difference between the cases and the controls. The mean age in the cases was around 60, and in the main controls it was 59. Using the radiological investigations, we found that most, as far as ischemic stroke was concerned, most of the cases, the blockade or occlusion was in the middle cerebral arteries. As far as hemorrhagic stroke was concerned, mostly it was the capsulogangliar bleed. These also show the MRS score, that is before the onset of stroke, they were all fully functional with a score of only 1, but at discharge, obviously post-stroke, their MRS score had increased to 4. So they had more disability. Then the SSS score, which shows the severity, was around 35 in ischemic stroke and 16 in hemorrhagic. Next slide, please. Yeah. So now we have compared our biochemical parameters between the cases and the controls. So as you can see that NT-proBNP, HSCRP as well as ferritin. So NT-proBNP was 713 versus 72 in controls. HSCRP was as high as 17 compared to 1.4 in controls. And ferritin was 169 in cases versus 90.5 in control. So all three parameters were significantly elevated, as you can see the p-value. Next slide, please. Okay, so in this slide, this table, what we have done is, again, we have divided the cases. As I mentioned before, we have ischemic stroke, hemorrhagic stroke, and controls. Now, again, the three analytes. Now, what we see is that among the two groups, but like while comparing the ischemic stroke with hemorrhagic stroke, the p-value for all the three parameters is not significant. Whether it is NT-proBNP, HSCRP, or ferritin, there is a difference, but not significant. But when all three of them were compared together using Kruskal values, there was significant difference. So together, in both ischemic and hemorrhagic stroke as a whole, they were much higher than controls, but in between the two groups of ischemic versus hemorrhagic, there was no significance. Next slide, please. Okay, so then we tried to look at the association between this the two scoring systems which we had done initially with the biochemical parameters. So in the table which you see above, we have taken the severity score, that is Scandinavian stroke scale, to look how severe it is. How it is correlating, how the biochemical parameters are correlating with the severity. Now, what I mentioned over here is that lower the score means greater is the, more is the severity of the particular stroke. So we got a negative correlation between all the three parameters when they were correlated with your Scandinavian stroke scale. So that means if the values of these particular markers is high, that means that the patient is having more severe disease or more severe disability during the admission. But even though we found a negative correlation for all the three parameters, it was only HSCRP which was significant, p-value of less than 0.05. The table which is below, it is comparing again the three parameters with the MRS score, okay, which is for the functional ability at the time of discharge. So here, like I mentioned, for MRS, greater the score, more is the disability. So we found a positive correlation with NT-proBNP and HSCRP when they correlated with MRS. That means higher levels of proBNP and HSCRP correlated with more functional disability. Again, the only one out of the three which was actually significant was HSCRP. Next slide, please. Okay, so what we have found is greater serum concentration of all the three parameters in cases when compared to control, which is significant. Coming to HSCRP, the higher serum concentration of HSCRP was associated with both greater clinical stroke severity as well as at the time of discharge a worse functional outcome. So what could explain the increase in the level of HSCRP in stroke is that patients with what happens in stroke is that there's a greater, those who have a greater immune system activation, those patients, they'll have much more damage, and that causes a poor stroke outcome. Next slide, please. Coming to the next parameter, that is NT-proBNP. Yes, we found a significant difference between cases and controls.
Please wind up quickly, sir.
Yeah, sure.
We are running out of time.
Yeah, sorry. So yes, we did find a significant difference between cases and controls, but there was no association with the stroke severity as well as the functional ability. Next slide, please. Okay, and again with ferritin, there was significant difference between cases and controls with respect to your ferritin levels, but no association with the stroke severity. Next slide, please. So what we concluded is that in acute stroke patients, elevated is associated with worse functional outcomes at discharge, and it is associated with greater clinical stroke severity. So thus, estimating HSCRP levels in acute stroke patients at the time of admission will help predict who will develop more disability and worse outcomes. So such patients can be treated more rigorously from the beginning. Thank you.
Over to the judges.
Dr. Sachin, I have a question for you.
Yes, madam.
In the study, you included 15 ischemic stroke patients.
Yes, ma'am.
And I think you have included them in your study within 48 hours. So
Yes.
to analyze how many of them were thrombolized, how many of them were not thrombolized, because that is going to be a major confounder, which is going to be affecting the levels of ferritin as well as HACRP. I think you should have analyzed this separately with a subgroup which has been thrombolized and those which have not been thrombolized. That be a major confounder. Without the history of thrombolysis, there is all your statistical tests will be offset. You have
Madam,
how many of them are thrombolized and how many are not?
Madam, I would just like to interject that with respect to ischemic, with respect to the, ma'am, I have compared the parameters. I've collected the sample before treatment was initiated, one thing. Secondly, I have compared them with two scales. Of course, what you told about is the MRS scale, which is at the time of discharge. So if a patient was not thrombolized, maybe his outcome was poor, but the Scandinavian scale was for the severity at that particular moment. So when the patient is presented, so whether he's thrombolized or not at that particular time, how severe it was, so that correlates with the biochemical parameters.
So
I mean,
one scale will get slight offset because of absence of data on thrombolysis.
Yes, madam. Yes.
Right. Then secondly, you could show that, did you rule out all patients, exclude all patients with any kind of cardiac abnormality?
Ma'am, we tried to, but some of them had previous history of myocardial infarction too.
But then NT-proBNP could be a confounder in such patients. You take NT-proBNP as a diagnostic marker when all cardiovascular diseases have been excluded.
Yes, madam, that is true.
Right. One was that. Then your HSCRP levels could be, you could do one association study to the thrombus burden on CT scan. They can actually tell you on CT how many millimeters of thrombus. So if bigger the thrombus size, does it correlate well with HSCRP values? So that can also be done. They will have the CT, you will have all the CTs, right? You just have radiologist and tell them, ask them what is the size of the thrombus or the infarct, and then do the correlation. So just by in centers, what will be the spin-off from this? The spin-off will be that if you get a good correlation in centers where CT scan is not present, HSCRP level should be able to predict the size of infarct. If a lot of data sets are available, it might be able to predict the thrombus size.
Okay, ma'am.
So that is another thing that can be studied with the data that you already have.
Okay, thank you, ma'am.
Thank you.
Dr. Sachin,
Yes, ma'am.
actually, we have done a similar study in another group of patients, just got completed, but slight differences were there. One thing is we used only ischemic stroke patients, not the hemorrhagic, because in fact, why did you use both? Because there is a slight difference in the outcome also of the patients. And
Madam, actually, already many studies have been done in ischemic stroke. So we wanted to, I mean, some novelty had to be there, so we included hemorrhagic as well.
Okay. And you've mentioned at the time of discharge and entry, but all of them were discharged. You did not lose any.
No, actually, there were more number of patients, but 30 were the ones who survived. We took around 41 patients, 11 of them had not survived.
Okay, because in our study also we lost 2 patients, so we could not do the parameters at discharge for those 2 patients, you know.
I did not mention about those patients who had not survived.
And did you consider any other inflammatory marker? Acha, you did not mention about those. Yeah, yeah. But then a part of your thing will be that, na? Anyway, fine, whatever you have done. And did you at the time of discharge also mention measure the HSCRP, and did you find any variation between entry and exit?
No, madam. We only took one-time measurement at the time of admission.
Okay, fine.
Thank you.
Thank you.
Any more questions from judges?
I think both of them have covered whatever I wanted to ask.
Oh, thank you, ma'am.
Okay. Thank you, sir. In that case. We are actually coming to the end of the virus presentations. One candidate, Dr. Ashi, she is unable to present, so we will skip this candidate. Thank you all the presenters for your participation, and we also thank our judges for your valuable time. Thank you all.
Ma'am, 1 second. Ma'am, 1 second. Aarti ma'am, just can you please hold on?
Can we leave? Can I leave?
Yes.
Can I leave?
Hello, ma'am.
Yeah,
Yes,
can I
hello.
Dr.
leave?
Aarti, ma'am.
Yes, yes.
I am myself Dr. Lakshmi Jatia.
Hello, how
Hello,
are
ma'am.
you?
How are you, ma'am?
I'm great. Yeah,
Okay, ma'am.
I'm
Nice
glad
to see you. Yeah.
Yeah, me too.
Okay,
Yeah,
ma'am. Thank you. See you sometime when I come to Delhi.
yeah, yeah. Sure, most welcome.
Yes, ma'am.
Mulana Zad will look forward to meet
Yes,
you.
ma'am. I am an alumnus of BMSECON, ma'am.
Yeah, yeah, that's what you told me. We are looking
Yes.
forward to meeting you.
Yes,
You know?
ma'am. Sure, ma'am.
Yeah.
Thank you,
And
ma'am.
you've done an excellent presentation. What about the results? How do we give you on WhatsApp?
Yes, ma'am. You can take a picture and send us
Okay.
on WhatsApp. We will
Yeah.
consolidate the results here.
Yeah. Okay.
Which picture? Which picture do we have to take?
Ma'am, the evaluation sheet picture.
Have you emailed it?
Yes, ma'am.
Yes, yes.
Okay,
Yes, ma'am.
okay.
Yeah.
Okay.
Aarti ma'am, I will be sending to mail only. I've already
Okay.
consolidated and sent to mail.
Okay, ma'am. Whatever way you can send us to in our mail, or you can WhatsApp, whatever is comfortable to you.
Okay. Thank
Okay,
you
ma'am.
so
Thank you,
much.
ma'am.
Thank
It
you
was
so
a-
much. It was an excellent, you organized it really well, and we had good academic content. Thank you.
Yes.
Thank you.
Look forward to meeting you all.
From AIMS, okay, Dr. Banerjee. Okay. Okay, ma'am. So when I come to AIMS also, I'll see.
Of course,
And
of
Dr.
course.
Vidya,
Look
thank you so
forward-
much. Yeah.
Look forward to
Thank you,
meeting
ma'am.
you.
Thank you, ma'am.
Bye.
Thank you all.
Bye.
Okay.
bye, ma'am.
Thank you so much.
Bye, ma'am. Thank you.
Thank you all.
Thank
Thank you for the opportunity.
Thank
Take care.
you.
Bye.
Mr. Sudhir, Mr. Sudhir and Mr. Pankaj ji. Mr. Sudhir,
Yes, ma'am. I'm Alok, ma'am.
Alok ji, we can share the tomorrow's program.
Okay, ma'am.
We can share the tomorrow's program.
Okay.
And dear delegates, we are starting tomorrow morning again, sharp at 9 a.m. Kindly
ma'am.
join in with the links provided. The links remain the same for all the 3 days. Kindly join in again.
Okay.
Thank you. Okay. So, Sudhir ji,
Yes, ma'am.
You can share the tomorrow's program now.
Okay. Hello, can you share the tomorrow program? Hello, bhai. Okay.
Okay, thank you. Meetings and more. We will wind up for today. Tomorrow again, morning 8:30 we start.
Okay, ma'am. Thank you.
Thank you. Thank
Thank you.
you. Okay.